President of Icaaicon, Icai. And we welcome you all on behalf of Pediatric Academy of Telangana State, along with my President, Dr. Surendranath Sir, and EB and OB of PATS 2021 for our special conference on allergy, asthma, and immunology. So today is the third day. In the conference wise, it is the second day. Today, right from 9:32 till 5 p.m., we are going to have the sessions. The schedule has been shared to the delegates in the WhatsApp groups. So now I welcome our President, Dr. Surendranath Sir, to give his inaugural remarks and open the day.
Thank you, Pawan. We welcome you all for today's scientific bonanza, which is going to be very interesting. And like 2 days, it was very well received by the delegates. And today also it was going to be a very successful program. And a lot of important topics are there today. So I request Pawan to start the scientific program for today. Narayan Reddy sir is there. Just take his advice and start.
Yeah, Dr. Narayan Reddy sir.
Good morning, everyone, sir. Excellent session, sir. So it is sensitized into all practitioner, pediatrician, general pediatrician. Allergy is a very important topic now. Future going to be allergy only because infections are coming down. So I do not waste much time. Please start the first session. DN Superior oration. So by I think Dr. C.L. Sharma, sir. You can start.
Good morning, everybody. Is Dr. Gaur there on the line? Dr. Gaur?
Yeah. Sir, Gaur sir be joined with sir, I think.
Okay. Actually, today again, like yesterday, we are going to start with a very, very important session actually. That is again Dr. D.N. Supri oration 2021. Yesterday we had for 2020 when Dr. Behra actually delivered the oration. And today we have another doyen actually, Dr. G.L. Sharma. Before I go there, although we have introduced Dr. D.N. Supri yesterday, but again there may be some new audience. Therefore, I would like to introduce Dr. D.N. Supri, in whose honor this award has been instituted. In fact, earlier, if I say so, this was the Indian College of Allergy Immunology Award, actually, ICI award was given. But after his death, actually, it was converted into D.N. Supri oration. Dr. D.N. Supri will ever be closest to our heart so long we are alive, because he's the one who established this discipline in this country, and that's how he is known as a father of allergy in India. Dr. D.N. Supri actually graduated from KGMU Lucknow and then postgraduate from Agra Medical College. And later on, he joined the Vallabhbhai Patel Chest Institute after a brief stint, and he started a new department of respiratory allergy for the first time in the country at Vallabhbhai Patel Chest Institute. He is the one who founded the Indian College of Allergy and Applied Immunology, with other doyens at that time like Avtar Singh Painter, Dr. R.K. Sanyal, Dr. R. Vishwanathan, and many more people, including Dr. Agarwal. I joined after two years, actually, the college. However, his services and his affiliation to the college will always be remembered. So that's why, in order of remembering him as a father of allergy in the country, we instituted from ICI to D.N. Supri oration. And today we have got a very, very distinguished speaker, or the orator, you can say, D.N. Supri oration, Dr. G.L. Sharma. And I'll request the president to formally introduce the speaker.
Yes, firstly, good morning to everybody. Now, Dr. G.L. Sharma, he has done his PhD in medical sciences from PGI Chandigarh and in medical parasitology in 1983 before joining a prestigious organization in India. And I
request the president to formally introduce the speaker.
Yes, I am doing that. Dr. G.L. everybody. Good morning. Now, Dr. G.L. Sharma, he has done his what is this? PhD in medical sciences from PGI Chandigarh and in medical parasitology in 1983 before joining a prestigious organization in India,
Pavan?
Can I request the president to formally introduce the speaker?
What is this happening? Is repeating
It's a
everything.
problem at your end, Dr. Surendranath.
Yeah, Pavan? Dr. Pavan?
Yes, sir. Maybe this is with GL Sharma, sir.
No, just see.
अभी शेयर
ask
मत करिए
other-
स्क्रीन डॉक्टर शर्मा.
Ask other.
Let the
Screen-
organizers continue.
Sir, Anand
that.
Singh, sir. This is your screen, sir. Anand Singh, sir's screen.
No, not screen.
अनशेयर कर दो डॉक्टर सिंह.
Huh?
अनशेयर कर दो आप.
Pavan, it is not the screen problem. I
okay.
think some
Now,
audio
हाँ,
problem.
sir.
अब
Audio
डॉक्टर
is
पवन
repeating.
can take over.
Sir, pardon, sir.
शेयर करिए. अब आप शेयर कर लीजिए स्क्रीन डॉक्टर पवन.
Sir, sir का slides मेरे पास नहीं, sir.
अच्छा इनका
No, I will
स्लाइड नहीं
introduce.
है.
Can you hear me?
Let President
Yes.
introduce first and then.
We can hear you.
Dr. GL Sharma, he has done PhD in medical sciences at PGI Chandigarh in medical parasitology in 1983. Before joining the prestigious Council of Scientific and Industrial Research as scientist. His novel discovery in the areas of diagnostics, vaccine candidates, disease genomics, and proteomics, immuno and pharmaco were made, and he represented India at several international scientific fora. And Dr. Sharma rose to the position of director of an institute dedicated to impart education in biomedical sciences at Jhansi. He has been superannuated at present as chief scientist from Institute of Genomics and Integrative Biology, CSIR, Delhi. Now his original high impact research papers published are 65, research projects 8, invited speakers, scientific lectures in India and abroad more than 150, science book 1, patent he has filed 11, patent granted 5 at US patents, 2, Indian 2, and European 1. He has organized about 12 international conferences and 4 national conferences. Dr. GL Sharma, this is a brief biodata of Dr. GL Sharma. We know him very well, but I know one thing more, that he has been the returning officer of ICI for a long time, a very strict returning officer. So I now request Dr. GL Sharma to give his prestigious DN Shipuri oration. Yes, Dr. Sharma.
Thank you, Dr. God, for nice compliments. Thank you very much. I express my heartiest thanks to you. Worthy chairpersons, friends, ladies and gentlemen, on this occasion, would like to present the DN Shipuri Oration Award lecture. But before I just hold, it is not sharing, please. It is shared.
Yeah.
So before I present to you today the Dr. DN Shipuri oration, I wish to express next.
Yeah.
So I wish to pay my sincere tributes to Dr. DN Shipuri, who had been the great physician and the nice researcher of his time. I thank the peers, the EC members of ICAAI, Dr. God, the president, Dr. Singh, the secretary, Dr. A.B. Singh, Vice President Dr. Bansal, Dr. Rajkumar, the editor of the journal, and Dr. Katuria, and also other honorable members of the ICAI Executive Council. I also thank the organizers of Icaaicon 2021 because they have given me the space to present my work today. I am indeed grateful to Dr. Mahesh Goyal, Director and Head, Department of Allergy, Asthma and Sleep, CKS Hospitals, Jaipur. This is very pertinent today to mention this work of D.N. Shipuri, Studies on Allergenic Fungal Spores of Delhi, India, etc., which was published in Journal of Allergy way back in 1969. Other authors in this work have been Agrawal and Mukherjee. Agrawal is not other than our beloved and respected Dr. M.K. Agrawal, who is present in today's audience. Thank you, sir. Dr. Agrawal, with Dr. Shipuri and Mukherjee, observed that aspergillosis is one of the 5 most prevalent species, allergenic fungal species in Delhi, India. So this information will set the stage for my presentation on challenges in diagnosis of aspergillosis, the relevancy of early stage antigens of Aspergillus fumigatus. Aspergillus fumigatus received its name because it resembled with an aspergillum, a holy water sprinkler used in churches. First recorded infection attributed to Aspergillus was reported in 1789, and in 1863, the species Aspergillus fumigatus species was first described by a physician, George Fresenius. The incidence after that has increased tremendously. Very alarmingly, it has increased incidence of the Aspergillus infections, and the increase has been due to the change in lifestyle, healthy food habits of people, industrial growth, especially the sugar and food industry, indiscriminate use of antibiotics, long-term immunosuppressive therapy, increased incidence of immunodeficiency diseases, various surgeries, especially the organ transplants. So these are the host-related factors which have contributed to increase incidence. The pathogen-related factors are ubiquitous nature. Hare vyapahe sarvatra samana means Almighty resides everywhere equally. But medical mycologists have found that Aspergillus exists everywhere. So this pathogen is ubiquitous in nature. It has capacity to grow on variety of substrates at wide range of temperatures. Substrates, if you call, only little moisture is required. It can grow anywhere on any surface for that matter. And when we talk about the wide range of temperature, that means we could isolate Aspergillus fumigatus from samples obtained at an altitude of around 30,000 feet in Ladakh. The Aspergillus synthesizes a very potent, highly virulent molecules which help the organism to grow and establish infection, evade the immune system of the host. This is the conidiophore of Aspergillus fumigatus here, and large, tiny conidia are produced here in this conidiophore. These conidia are very small in size, around 2 micron, and get airborne very easily. This is how they circulate in the environment, and when are in the air, they can infect any host and then produce various disease conditions. This is superficial infection. Figures I have taken from the net. This is the leg, foot, nose, ear, the ophthalmic infection, and the buccal cavity. When the spores or the conidia, they get entry into the upper airways, they can cause bronchial irritation, cough, bronchitis, and when at later stages, short breath, sputum plugs, malaise, fever, and the chronic state of allergic bronchopulmonary aspergillosis. In case of invasive aspergillosis, the growing mycelia can necrotize the tissues, can penetrate to the circulatory system, and can produce the invasive pulmonary and the invasive extrapulmonary conditions in which any organ of the body can get infected, including all vitals here. This condition is mostly fatal. So disease has emerged as serious threat to public health in last 3-4 decades. This only I'm not saying. I think any mycologist working in this area will say like this. And Janet said cytotoxicity of Aspergillus fungi as a potential infectious threat. The RABAC, emerging threat of triazole-resistant Aspergillus fumigatus. So the condition is worrisome. And it is important to relook at the diagnosis and treatment strategies for Aspergillus infections. Diagnosis is directly related to the outcome of the treatment. Now, diagnosis, for that matter, it is true for any infection, but in case of Aspergillus infections, early diagnosis is important. This slide I made based on the discussions I had with Dr. Denning and Greenberger in a meeting. And if one is able to diagnose the disease, the infection of Aspergillus fumigatus at around 10 to 11 days, there are every chance of successful therapy. But after that, chances of therapy decrease, and after 25 days, it goes to a non-treatable phase. So it is difficult to diagnose early the Aspergillus fumigatus because clinical presentations of patients is so ambiguous, so incomprehensible that clinicians, by looking at the symptoms, find it difficult to comprehend on the diagnosis of aspergillosis. Cutaneous aspergillosis can represent with acute inflammatory responses with tissue swelling, abscess formation with pus and necrosis. The lesions may appear red and indurated and often progress to a cover of black eschars. Pulmonary symptoms I have already told, but angioinvasion results in necrosis of tissues, which may ultimately lead to cavitation in lungs and the hemoptysis. Shah and Punjabi considered allergic bronchopulmonary aspergillosis a perplexing clinical entity. In rhinocerebral infections, unilateral facial swelling, headache, nasal sinus congestion with pain, bloody nasal discharge, and fever are generally observed. Further spread of the infection may cause ptosis and proptosis and the vision disturbances. Necrotic lesion, if they have spread to the palatal region, if infection has gone to infect that part, then it may result in discharge of black pus from eyes. Disseminated, I already said, it is mostly fatal. Gastrointestinal is rare, but if it happens, then dyspepsia, constipation, abdominal pain, diarrhea, and fever, these are the symptoms are seen in the patients. But what is currently available to diagnose the Aspergillus infections? A skin prick test is very frequently performed in different laboratories and pathology centers, in which antigen is inoculated subcutaneously or intradermally to see the reaction arithmetic wheels, and then it helps in diagnosis. But specificity issue was always there in this particular skin prick test. Microscopy is performed in different type of samples, the sputum, bowel, nasal, and excreta, to demonstrate septate hyphae with dichotomous branching. When you expect the number of spores in the sample very less, then you can go for culture and then go for microscopy to demonstrate these mycelia in the sample. The microscopy is very, very specific, 100% specific, but sensitivity is around 50 or maybe sometimes less, 50% or less. The X-ray and CT are frequently performed and analyzed to diagnose the pulmonary as well as invasive aspergillosis. These methods are quite helpful. However, observations sometimes are not very clear, and that leads to misdiagnosis. The aspergillosis is very frequently misdiagnosed as TB. Therefore, X-ray and CT are considered to be the just supportive tests. Gel diffusion, immunoelectrophoresis, enzyme-linked immunosorbent assay, radioallergosorbent assay, they are performed very, often in laboratories, in research laboratory as well as pathological laboratories. But you always get variable results. It is because the unstandardized crude extracts of the antigen, they are employed to perform these tests. Richardson published a very huge review article, Aspergillus Serology. Have we arrived yet? In the conclusion part, these authors mentioned the quality of crude extracts of diagnosis for diagnosis and therapy of aspergillosis is very unsatisfactory. We realized this much before than Richardson, because one has to keep in mind that aspergillus has very complex cytoplasmic organization and an array of morphological expression and a remarkable, diverse, highly adaptable metabolism. So keeping this in mind, we in late 90s developed an ELISA-based diagnostic test for aspergillosis using partially purified, partially characterized antigens of Aspergillus fumigatus, and this test was quite sensitive, 92% sensitive, and specificity also was quite good. And we used in the laboratory this test for almost 15 to 20 years. And thousands of patients we analyzed. We also developed a much more sensitive luminoimmunoscent assay for detection of specific antibodies in allergic bronchopulmonary aspergillosis. Detection limit of this system was 0.19 nanogram per of the human IgG, whereas with ELISA it was 1.48, so quite sensitive. But specificity we compromised. We were not able to find an appropriate cutoff where you can say this is positive or negative, because lots of overlap and high signal of this radiation, it was little difficult. So application was difficult then. Recombinants have been used, almost 10 to 12, a dozen almost, they have been expressed. And 18 kDa ribonuclease, 88 kDa dipeptyl peptidase, and 360 kDa catalase, they have been shown to be useful in diagnosis of aspergillus infections. Galactomannan, mitogillin, and chitosanase also have been used to detect the anti-aspergillus antibodies in the sera samples. And these methods, the recombinant antigens may be good, but they have not found application so far to that extent what is required by the clinicians at present. You can find out the presence of galactomannan and DNA directly in the samples. So galactomannan is a carbohydrate molecule. which you can detect by using the anti-galactomannan antibodies. Especially, it has been used in invasive form of aspergillosis. DNA also could be detected, and it is difficult, in fact, what are the target genes, what is segment of the genes, and what are the universal primers which could be used to detect the DNA in the sample. It is not yet standardized very well, so problem still persists. The early diagnosis of aspergillosis has become more challenging due to emergence of corona pandemic in last 1.5 years. COVID-associated complications in pulmonary aspergillosis and invasive form of pulmonary aspergillosis have been reported last year. Now, with all these developments, knowledge generated so far, some criteria have been described to diagnose the aspergillosis, especially the ABPA. So this is the list given here by Greenberger in 2002, where asthma has to be there, immediate cutaneous reactivity has to be there, total IgE should be more than 1000 nanogram per ml, elevated serum IgE and IgG against Aspergillus fumigatus, central bronchiectasis. These are the parameters should be there if you want to say that, yes, this is the case of Aspergillus fumigatus ABPA, in fact, specifically. Nicholas and Greenberger again gave little better explanation and better list of these parameters. Patients of bronchial asthma with positive SPT, if they have any 4 of the following, then it is certainly a patient of ABPA. Elevated IgE, presence of a specific IgE, presence of specific IgG, presence of precipitating antibodies, proximal or central bronchiectasis on CT, pulmonary infiltrates on chest X-ray, and peripheral blood eosinophilia. So any 4 of these 7 plus asthma and SPT positive, it should be a case of ABPA. The Agrawal, Ritesh Agrawal and Dr. Shah, all this is a group working, the Shah from VPCI, Ritesh from PGI Chandigarh. They published a review and gave a new diagnosis and staging criteria for Aspergillus fumigatus. Even with all these developments, we often encounter misdiagnosis as well as the missed diagnosis of ABPA. The diagnosis of invasive aspergillosis also is quite challenging. And in conclusion, one can say diagnosis of invasive aspergillosis remains challenging. Novel methodologies and the standardization of GM and galactomannan and DNA by PCR might provide more reliable diagnostic tools in future. This is what the Maurice Avartus and his colleague said. So can we do something to deal with this menace by identifying new molecules for specific and reliable early diagnosis for the development of immunotherapy for aspergillosis? Theme of this remains during germination, colonization, invasion, Aspergillus must respond and adapt to diverse types of stressors and effective cell responses in the host. In such stressful environment, pathogen is expected to produce a wide spectrum of stage-specific molecules. Thus, late-stage crude culture extracts of the Aspergillus fumigatus may not be useful in diagnosis. There are more than 120 molecules from Aspergillus conidia as well as the mycelia have been described. But are these only 120, 125 molecules in Aspergillus fumigatus? No, because the sequencing of 29.4 megabase genome demonstrated the presence of around 9,000 genes, around 10,000, you can call 9,926 genes in Aspergillus fumigatus. So that means only less than 1% has been described, has been understood till now. Thousands, more than 99% of proteins of A. fumigatus have not been characterized yet, though their presence in the organism can be predicted by presence of sequences in the genome. Most proteins of A. fumigatus characterized so far have been found to be immunopathologic and virulent factors. But we hypothesize that there must exist some crucial molecules in A. fumigatus which may be exploited for the benefit of the host. To test this hypothesis, we took up a project on immunoproteomics to identify the novel functional early stage molecules, early stage, this is important, of A. fumigatus, which could be of immunodiagnostic and immunotherapeutic relevance. This is the group to whom I acknowledge their contribution, my students, professors, Professor Bhadoria and D. Behra, and foreign collaborators, Dr. Ulrich, Reichard, and Asif, who had been the part of this project. We prepared the proteome, characterized the proteome, and then found out their functional capabilities of these molecules. These are the two strains of Aspergillus fumigatus, ITCC 6604 and DAYA. This is German strain, this is Indian, and both were used to prepare the antigens. Two types of antigens we prepared: secretory fractions, late stage, and conidial hyphal cytosolic fraction, which is early stage antigen. This is how two types of antigens are developed: the secretory, this side, culture filtrate, precipitation, purification, determination of protein, and then the culture at 16 hours, the germinating conidia are used to prepare the antigen. So this is the protein profile on gel. Hundreds overlapping proteins you can see in the gel, and this is the proteome, two-dimensional electrophoresis. You can separate them into different spots. So these proteins are in the molecular weight range of 10 kDa to 200 kDa, which has been found to be allergenic by other persons. Serum samples, positive serum samples we obtained from LNJP hospital and Dr. Behra when he was in that LRS. Proper exclusion and inclusion criteria were used to identify the subjects, and these are the IgE immunoblot. We developed the first proteome, then it was immunoblotted using the IgE antibodies in secretory antigen, and then IgG in the secretory antigen. And here is the IgE immunoblot of early stage CHC fraction of antigens of Aspergillus fumigatus. So large number of proteins you can see. This is one strain, this is a second strain here, and this is the narrow range of gel. This is 4 to 7 broad range. And after developing these immunoblots, this is IgG immunoblot. We isolated all these proteins, all these spots, and subjected to analysis by IgE, IgG reactive proteins from both strains of Aspergillus fumigatus. And these proteins then analyzed by mass spectrophotometry using state-of-the-art facilities available at Germany, and then went for in silico analysis. So in secretory fraction, which is the late stage fraction, these two fractions, they differ in their molecular architecture. So this secretory fraction, we could isolate 35 immunoreactive proteins from here. And this is the list. You should not bother for this list to remember. These are the accession numbers of the proteins. Here the names, 18 here and 17 here. So total 35 proteins from secretory fraction of Aspergillus fumigatus. Biological functions annotation of all these identified proteins was designated by in silico analysis tools, UniProt and Cognitor. Students, they are very expert in using this type of tools these days. And here is the characterization, the categorization of these all proteins. So this is 14% were post-translational modifications. This number of proteins, these percentage of proteins were responsible for this function. And carbohydrate metabolism was governed by 28% of these proteins in the Aspergillus fumigatus. And here is the cell wall maintenance. These 17% we could not find out what for they were in the organism, and some minor proteins here. Now, this is the condidial hyphal cytosolic fraction early stage, 66 proteins. So I told you that they were differing in their protein contents and protein structures, protein architecture in the organism, 66 proteins. And again, here is the list, perfect as identification by name and the accession number, spot number, which we isolated from the gels. 35 and 52, 66, all we characterized at molecular level. Now, again, here is the categorization, functional categorization. So this is amino acid transport, which is governed by these 21% of the proteins. And here is the coenzyme transport, carbohydrate metabolism, energy production here. And this is here is the post-translation modification of different type of proteins synthesized in the host. Now, these results we published in Journal of Proteome Research, 2 papers, one in Current Protein and Peptide Science. And this table is very important to remember. Categorization of all 66 plus 35 immunoreactive proteins of Aspergillus fumigatus. What is important to note here is, I think these are the known proteins which were already described in the literature. But this is number 63 in CHC fraction, early stage fraction. 63 were just putative proteins. They had the predicted functions, and others, these are the novel ones, in fact, which were from the secretory fraction, new proteins, 3 new proteins. But in this case, we could not find any new characterized protein, but 63 were important, which were deduced from the nucleotide sequences of gene. Now, question arises, which of these antigens dominantly, specifically, consistently, and commonly would react with ABPA patients? Can they find application in diagnosis and healthcare, something like vaccine or some vaccine candidate? We segregated all these proteins. This is a schematic presentation here. And then the reactivity with individual sera. this proteome is developed to develop the immunoproteome by using anti-IgG antibodies. So individual serum, one serum is used here, and like this, 12 patients. One is, I think, this is the normal crude, and 11 patients we used to develop the IgG immunoblots of secretory fraction. So these are the 18 proteins whichever we found to be important, immunoreactive consistently with all these patients. I mean, common here in all these patients, they were common 18, and these are the reactivity immunoblots of CHC antigen, 11 patients again, and IgE reactivity. After that, we found out that there were another 18 protein in this secretory fraction also. So based on the high and consistent immunoreactivity and novelty, we prepared a panel of 14 proteins, total 14 proteins. We made a panel of that and tried to clone them. But unfortunately, we could clone only 4. These are hypothetical protein. It's a novel protein, new. It was not known before. So we selected this, but we were lucky to express a clone and express this protein in our system. Sorbitol, SOU1, fructose bisphosphate aldolase class 2, FBA2, abbreviated, alcohol dehydrogenase. We could express these proteins, and immunoreactivity of all these proteins was very high. So this is PCR amplification of all these proteins, 1, 2, 3, 4. This is the H6, here is the hypothetical protein, and here is the SOU1 sorbitol, and this is the FBA, fructose bisphosphate aldolase, and here is the alcohol dehydrogenase. So it could be cloned very nicely, and then we restriction enzyme assay was performed. Then again, these pure proteins, they could be, these clones could be obtained here, and this is the vector here. So these proteins, all 4, H6, ADH, SOU1, BFA2, could be expressed very nicely in the system and could be purified. These are the purified H6, cloned purified. Here is the cloned purified SOU1. Here is the ADH purified cloned, and recombinant FBA2. Now we try to look at the immunoreactivity, very important gel this is. Now here is the secretory fraction. Now you see, this is the CHC fraction immunoblots. These are the immunoblots. They are not the gels direct. These are the immunoblots. And here is H6, here is SOU1, here is ADH, FBA1, right? So this band is specific to all these 4 proteins which we recombinantly expressed. This side is the control panel. Control panel means, in this case, we use the whole serum to immunoblot here. So now what is important to look at these 2 gels is that in this case, with non-specific reactivity, you could see with SOU, sorry, this is ADH. ADH non-specific reactivity, SOU non-specific reactivity, H6 non-specific reactivity. But in this case, there is no band here. You must appreciate that there is no band in this particular lane here, which is very much here. That means with negative sera, this protein did not react. That means recombinant fructose bisphosphate aldolase 2 did not react non-specifically. So very specific reactivity with this cloned recombinant FBA2.
Time over, sir. Time over, sir.
So fructose bisphosphate aldolase class 2, which is the cytosolic early stage antigen of epidermis, could be one of the important molecule for application. What is not explored yet, I have given here. I can explain sometimes later. But in conclusion, aspergillosis is very difficult. Diagnosis is challenging. It is frequently isolated from respiratory tract of patients or asthma who do not meet the criteria of AVPA. IgE sensitization to a fumigator associated with reduced lung function and lethal consequences due to several in severe asthma. Available methodologies are not enough to diagnose. Many of the respiratory conditions, including corona pandemic, have made the diagnosis most difficult. Highly immunoreactive 66 cytokine enlisted antigen of SLS fumigators have been characterized. One of this, that is FBA2, is important. Very highly immunoreactive trace proteome. This is something for future. And with this, I thank you. Thank you very much. And happy Diwali.
Thank you, sir. Excellent presentation, sir.
Thank you, sir. Thank you, GL Sharma, sir. AP Singh, sir, unmute yourself, sir.
Yeah, Dr. Sharma, thank you very much for highlighting something very important and something important that which can probably be used in future to definitely diagnose a case which is of AVP, a disease which is very prevalent, especially in this part of the country. Thank you, Dr. Sharma, very much. Thank you.
Move on to next
Thank you very
session.
much.
So, allergy and inflammatory disease of the upper airway by Dr. Ashok Shah.
Ashok sir is there. I request Ashok sir to share his screen.
Dr. Ashok Shah, unmute yourself.
Done it. He's done it.
Dr. Chakrapani, Dr. Raghavendra.
Yes.
Pawan, if they're not joined, you introduce the speaker.
Dr. Shah, you are in a plane or what?
Yes, sir. I request Dr. Ashok Shah to share his first introduction slide.
He's not in a plane.
Just a moment.
Oh, he's there. He's there.
Is there joined, sir?
You can bata.
Is the screen visible?
Yes, sir. Thank you so much, sir. Now the next speaker is Dr. Ashok sir, who is a former professor and head of the Department of Respiratory Medicine at TSIC Medical College and Hospital, Faridabad. And sir is also the former director professor, Department of Pulmonary Medicine, Vallabhbhai Patel Chest Institute, University of Delhi. So sir is going to speak on allergy inflammatory disorders of the upper airway. Over to Shah, sir.
Thank you. At the outset, I would like to thank the scientific committee as well as the organizing committee for this opportunity to be with you today. I'm going to be speaking about the impact of the upper airways inflammatory disorders, allergic in nature, on the lungs below, and you'll see how it goes. So just cast your mind back to the last time you had a cold and how miserable you felt. There are many people in this world who have this daily, and no one gives sympathy for the fact that you just have a cold and a cough. So here we go. Allergic inflammatory disorders comprise allergic rhinitis, sinusitis, and nasal polyposis in the upper airways. And of course, since the airway is one from the nose to the alveoli, it is bronchial asthma below. So what do we understand about allergic inflammation? It is the chronic allergic inflammation which is the cause of the pathology, and therefore the burden of the disease reflects the long-term consequences of this event. This happens at the sites of persistent or repetitive exposure to allergens. Rhinitis has been defined as inflammation of the membranes lining the nose and is characterized by nasal congestion, rhinorrhea, sneezing, nasal itching, and forced nasal drainage. Atopy is an important risk factor for rhinitis, and allergic rhinitis is the most common form. So this in 2018, allergic rhinitis was defined in a consensus statement as AR is an immunoglobulin-mediated inflammatory nasal condition resulting from allergen introduction in a sensitized individual. It is estimated there are about 600 million people with allergic rhinitis in the world, 200 of them with asthma. In the United States, up to 30% of adults and 40% of children have allergic rhinitis. In Europe, up to about 28.5%. And in a study done 20 years ago from 11 Asian countries, there were about 30% of adults in Asian countries and 46% of children. So it's not a small problem at all in any way. The Isaac study, we did the two-phase studies in children. The 13 to 14 years, there were two age groups, 13 to 14 and 6 to 7 years. And you can see that from 10 years time, this has increased from 18.6% to 29%, from 8 to 17%. So this is a problem which is constantly increasing. The same figures were there seen in the lower age group also. So what is the importance of allergic rhinitis? It is most commonly associated with asthmatics. This coexistence has been recognized for centuries. Everyone knows about this. And in fact, we have this journal to help people out with this. It shares common risk factors, including atopy. Might even be a manifestation of the same disease. So if there is allergic rhinitis, there's always a risk for the future development of asthma. So in 2001, people got together and said, let us find out sorry, how do I remove this? Sorry. Anyway, this ARIA document came out, and they said these are the 4 symptoms, and if you have 2 or more of these symptoms for more than 1 hour in a day, for most days, you have a clinical definition of allergic rhinitis. Then ARIA also adopted something that Professor Neil Megan had initially proposed from Denmark. They categorized it as sneezers and runners and blockers. People who had a lot of running nose, sneezing, and those who had blockers, which are predominant symptoms. Sneezers were paroxysmal. They had running nose, itchy nose, and nasal block was variable. But the symptoms were worse during the day rather than at night. And in contrast, the blockers had very thick mucus, or very severe nose block, and constant day and night, maybe worse at night also. So then we were the first to characterize it clinically, so it was proposed at the time. And we had 114 patients. And out of this, approximately two-thirds were sneezers and 1/3 were blockers. And you can see these are all very significant figures. There was a very strong family history of atopy. There was ocular itch, the throat and palate itch, ear itch, skin itch. There was a lot of itch, and they were affected by house dust. In contrast, the blockers had history of breathlessness, mouth breathing, loss of smell, and history of prior nasal surgery. Because of nose block, people keep on getting their DNA straightened out and all that things. And the same reflects with pollens. Outdoor pollens were mostly seen in sneezers and runners, and indoor pollens were seen in blockers. These are all very significant figures. So, in conclusion, we saw that sneezers and runners have more allergic manifestations, may possibly require oral antihistamine in addition to intranasal corticosteroids. And blockers, regular administration of intranasal corticosteroids would most probably be required, and antihistaminics may not be effective during persistent nasal blockage. So, 1 minute, please. So, what are the associated problems? Usually coexist with asthma. If you do not treat rhinitis, there's suboptimal control of asthma. And there is diminished quality of life, sleep disturbances are there, obstructive sleep apnea. There is impaired activities. No one gives sympathy for just a cold and a cough. There's impaired activities, there's impaired learning, work performance, especially for children. There's mouth breathing and dental malnutrition. And these are the comorbidities. This is the adenotonsillar hypertrophy, cognitive disorders, serosotitis media, but more important, and poor quality of life. But more important, if you have your sinusitis, polyposis, conjunctivitis, sleep disturbances, and for children, missed school, and for adults, missed workplace, or days where they have less activity. We also found that allergic rhinitis affects the quality of life, especially on family. You can see the family is upset, but after appropriate treatment, the family's degree of upset gets lowered. Sleep is also affected by allergic rhinitis. There's daytime fatigue and somnolence due to nasal congestion as well as sleep fragmentation. Snoring is there in about 2/3 of the patients. Impairment in sleep-specific quality of life questionnaires. And when we studied this in nasal runners and blockers, we found that blockers are significantly more sleep disturbances. And then we looked at 114 school-going children with asthma and/or rhinitis. And we found that they missed school, there was impairment in class, total class room impairment was there. And in conclusion, it was summary. Allergic rhinitis severely affects the quality of life and work productivity in school-going children. Sinusitis occurs very frequently in children with allergic rhinitis, and whenever there is sinusitis, there is impairment of quality of life in children with AR. So it is definitely not a trivial disease. Sternutation is another term for sneezing. What is the status in India? It's a neglected disease in India. Independent diagnosis of AR is yet to be accepted. Major impact on quality of life, but rarely given importance. Patients fail to attribute AR to symptoms due to just common cold. So, and is most commonly associated with asthma. Is often treated as an orphan disease, falls in a gray area between otolaryngologist and pulmonologist. Whenever there is sinusitis associated with rhinitis, it is considered to be more severe form of the disease. Concomitant occurrence of sinusitis increases the morbidity. We had 131 patients of allergic rhinitis, out of which 88 had sinusitis on CT. And those with sinusitis had significantly more breathlessness, nasal blockade, nocturnal awakening, halitosis, headaches. They missed work for social activities, more fatigues, and increased severity of symptoms. The term rhinosinusitis was coined because the symptoms of rhinitis and sinusitis overlap. Sinusitis rarely occurs in the absence of rhinitis. It can occur, of course. And because the middle turbinate and ethmoid sinuses are linked, there's a cyclic variation in the nasal turbinate swellings can occur. Sinusitis typically involves nasal passages as well. That's why you can see over here how it works. First of all, there's mucosal congestion due to virus. The secretion stagnate, changes in pH, mucosal gas metabolism occurs, cilia and epithelium are damaged, changes in the host milieu takes place, secretions are retained, cause tissue inflammation, and this leads to bacterial invasion and develops into sinusitis. Nasal blockage thickens and creates further blockage, and this osteum is blocked, and this vicious cycle continues. So, what is the definition? It was defined it as 2 or more of the major symptoms with either endoscopic diagnosis or CT changes. And this is the pool of chronic rhinosinusitis. In this pool of chronic rhinosinusitis, there's a smaller pool of nasal polyps. And this is a patient of ours with nasal polyps and sinusitis also. And when polyps are there, it becomes a more severe form of the disease. So recently, just this year, there was a proposal by Professor Hawkins, at least this is the new epidemiological definition of chronic rhinitis, and it says at least one nasal symptom is present for 3 weeks or per year. This is a better definition. We also evaluated patients with nasal polyposis and found that quality of life indices was significantly affected, and that too very adversely. And it also increased the severity of disease as evidenced by the VAS and SNOT-52 questionnaires. So nasal polyps also impacted sleep indices. And when we did evaluated vitamin D levels in AR, CR, and we found that it was the lowest in nasal polyposis. And whenever vitamin D was low, the quality of life was worse. So we also evaluated vitamin D blockers and found that blockers had a poorer quality of life in those with rhinitis. So in conclusion, we find that this importance of diagnosing and treating chronic rhinosinusitis and NP cannot be overemphasized, especially when a significant population is afflicted. Negative impact on the daily life, both during the day as well as during the night. So even people can't sleep well, people can't work. It's not a small problem by any means. Now we come to wheeze and sneeze together. So this was the title of the editorial I gave many years ago. Rarely does one hear a wheeze without a sneeze. Sorry. In this huge pool of allergic rhinitis, we have a smaller pool of allergic rhinitis with asthma, and very few patients with allergic rhinitis, asthma alone. So it's a continuum of inflammation with one common airways. So childhood allergic rhinitis is a significant risk factor for asthma, and impact of effective treatment upper airways on both the development and the presence of established asthma are important critical questions that we need to think about. So the ARIA defined allergic rhinitis as a major chronic respiratory disease, not a ENT disease. This is because it has links with asthma, it's associated with sinusitis and comorbidities such as conjunctivitis. Non-atopic rhinitis at the age of 6, and it sees that there was childhood significant risk factor for asthma development through adulthood independent of atopy. This was a study that was published in 2003 and was followed up in 2019. So nasal symptoms are seen up to 78% of asthmatics and up to 38% with asthma. 99% of all allergic rhinitis had rhinitis, and the conclusion of the study by Tobias and et al. Was rhinitis is ubiquitous in allergic asthmatics. So we always, if there's asthma, we always look for rhinitis. A meta-analysis of 29 studies concluded that allergic rhinitis is strongly associated with asthma. Relief of airway allergic manifestation may require dual control of allergic rhinitis and asthma. So please take care of rhinitis in order to take care of asthma. So it has been thought that about 85% diseases occur simultaneously. But rhinitis is an important risk factor for asthma. When we studied this, we found that 75% of children had asthma and rhinitis, and 80% of adults had asthma and rhinitis together. And it occurs simultaneously in 74% of children and simultaneously in 80 or 55% of adults. So when there is asthma with rhinitis, this is the most severe form of the disease. You can see asthma without rhinitis without asthma. Rhinitis is bronchial hyperresponsive, and the severity increases when there is rhinitis with asthma. Now, this is an important study that came out. People evaluated practically 5,000 patients with allergic rhinitis. Out of this, 73% had concomitant allergic rhinitis. And we found that those who were treated for rhinitis reported to the emergency rooms to only 1.3%. Of those who were not treated for rhinitis, there was 6.6% of these patients who had visited emergency room department. So it highlights the importance of treating allergic rhinitis. There's also effects on quality of life by activity limitations and emotions. You can see over here that activities were limited, and if appropriate treatment comes back to towards the baseline. It affects all the behavior and lifestyle also. You can see over here. So the conclusion being that take care of the sneeze, not get rid of the wheeze. Asthma, whenever the sinusitis, asthmatic severity increases, there's increased sleep disturbances, frequency of exacerbation is there, and bronchial hyperresponsiveness occurs. So you can see patients with asthma having sinusitis about 74%, patients with allergic rhinitis having sinusitis 67%. That is the important trigger factor for asthma, and optimal control of sinusitis is required to prevent frequent exacerbations of asthma. And we looked at this. There were 216 patients of asthma with or without rhinitis. And this 20 out of the 27 patients of asthma, we found that 20 had sinusitis. And they all without nasal symptoms at all. And mean CETA scores were also higher in asthma with rhinitis, and number of sinuses were involved in asthma with rhinitis. Now you can see over here that those who had sinusitis, their PFT parameters were much lower than those of asthma. These are significant figures, of course. So asthma severity is significantly affected in those with sinusitis. This is a patient of ours with sinusitis with no obvious nasal symptoms. To our surprise, we found that the patient had huge maxillary sinusitis. So this is the armamentarium we have against allergic rhinitis. We have the antihistamines, oral, intranasal, and intraocular. Corticosteroids, of course, the mainstay of therapy, very effective all the way. Chromones are no longer in use because it has to be used about 4 to 6 times per day. And though, of course, a very safe drug. Anticholinergics were used for gustatory rhinitis. Antileukotrienes are there, but is useful in rhinorrhea. It's a query as far as nasal obstruction is concerned. So, use of steroids is always mixed with fears, anxiety, misconceptions. So currently, intranasal corticosteroids differ little in efficacy and safety profiles. So there must be some way of requiring which patient will suit what. And we did a preference study, and we found that mometasone was, people were most happy with mometasone over here. People were all blinded. So the order of administration did not affect findings. Mometasone was significantly more liked because of moisture and lacking of odor, less irritation after taste. And fluticasone, there was significant irritation and odor strength. So seasonal drugs could appear significant differences more than the blockers. And people thought that they would be happier with mometasone. Of course, all the sprays were blinded, pouched completely. People didn't know what they were using. So these, if you treat appropriately, you find that this is sinusitis cleared up after appropriate therapy in a 48-year-old female. This is another one before and after treatment. You can see the sinuses completely clears out with over 16 weeks therapy. This is bilateral sinusitis cleared out over here. Of course, this is persistent, which we could help, but symptoms have reduced drastically. This is another male with sinusitis cleared out after treatment. But you have to be very careful how you prescribe this nasal sprays, especially in steroid nasal sprays. Otherwise, you can land up with nasal septal perforations. This is a patient who had used it inappropriately and he had to get operated. His nasal septum was perforated. Now, sensitization to aspirate antigens can occur in rhinitis. We found that a fourth of our patients had that. And since rhinitis is an important predisposing factor to sinusitis, these patients could possibly be a great risk for allergic sinusitis. And we found that when we looked at these patients, out of 131 patients of allergic rhinitis, 23 were blockers, 9 were season runners. And we found that aspirate sensitized blockers with sinusitis had higher eosinophils, total Ig was elevated, more severe and extensive sinusitis was seen, and higher mean sinus scores was seen, as well as number of sinuses involved.
Ashok sir, time is up, sir.
Okay, just a moment, sir. And this was the patient of allergic sinusitis. And now we have this asthma, rhinitis, and COPD. And this over here is a pool over here where we find that there are rhinitis and COPD are present. We found that we had many patients patients of COPD. 27 of the 41 had upper airway symptoms, and their quality of life was poorly affected. So, is rhinitis the first step along the respiratory march of allergic disease towards asthma? Does rhinitis play an etiologic role in asthma? What is the role of CRC and CRS and nasal polyposis? What is the role of allergic inflammation? We still do not have answers to that as yet. And this is all interlinked over here. And a word before about COVID and allergic rhinitis. The conflicting studies, Korean studies said that those who had allergic rhinitis are greater susceptibility to risk of COVID-19 infections. a more severe clinical outcome of COVID-19 disease was seen in those at rhinitis. In Turkey, it says that AR did not affect severity of life. Intranasal corticosteroids have been advocated since non-admission will increase nasal obstruction, secretion, infection, and colonization, and it has been advocated. Antihistamines should be used in these patients, and aerosol should be avoided because fugitive emission goes, and 50% of generator effusion during therapy is not inhaled but passes into interstitial, even there for several hours. So nebulization PFT should be avoided as far as possible. And it's difficult to recognize the difference between allergic rhinitis and COVID-19. These are the symptoms that would indicate COVID-19, and these would be more in favor of allergic rhinitis. And this is the Galen and last slide, ARIA Allen Galen consensus statement of 2021. They said if you look at all these things, it would enable differential upper respiratory tract symptoms. So in the end, for the PGs that we have over here, my favorite quote, education is not something you can finish. Thank you very much indeed.
Thank you so much, Ashok Shah, sir. That's really a wonderful presentation. I think we all enjoyed that. Now moving to the next session. Sir, A.B. Singh, sir, would you like to introduce Dr. Suryakant, sir, the president of 2020?
Is Dr. Gaur here? Dr.
Yes,
Gaur?
sir. Gaur, sir, is there. Yeah. Gaur, sir, President Dr. Gaur.
Okay, friends. Now we are going to have another very, very important session. That is the Foundation Day lecture of 2022. In fact, the Foundation lecture was instituted to remember the Foundation Day of the Indian College of 67. So it was instituted about 7 years back, and we are having 6 luminaries before actually who have delivered the Foundation Day lecture, and Dr. Suryakant will be joining the luminaries of 2020 actually for Foundation Day lecture, and he will speak on role of non-pharmacological adjuvants therapies in the management of bronchial asthma. And I will request our president to formally introduce Dr. Suryakant, although he is very well recognized and known everywhere in the country, but even then, this is a tradition to introduce the speaker or the orator. Dr. Gaur.
I think you are right that we have to introduce because it's a formality, we have to do it.
Gaur, are you there?
Yes, yes. Can you hear me?
Yes, sir. We can hear you. Good.
Right. Dr. Suryakant is professor and head Department of Respiratory Medicine.
Gaur?
Yes. I am speaking by.
No, we are able to hear you, Dr. Gaur. You go ahead.
Yeah, Dr. Suryakant is professor and head Department of Respiratory Medicine at KGMU, UP Lucknow, and he is a national vice chairman of IMA AMS, governing body member of AIMS Patna. He is a strong academician, IMA honorary professor since 2017, and he is a national expert of 22 committees for making Indian guidelines on various respiratory diseases. He is an able administrator, he is a vibrant professional leader, and he is currently national vice president of this thing. IMA-AMS, partner of Front Line COVID Critical Care Alliances, and brand ambassador for COVID vaccination in National Health Mission. He crusader against tuberculosis, tobacco, and pollution, and leading TB elimination program as chairman of UP Zonal TB Research. And he has organized more than 100 international and national and state conferences. He has got immense contribution in the field of COVID-19, which has been appreciated. He is involved in various charitable work through more than 20 NGOs in the field like tuberculosis, tobacco, cancer, COVID, air pollution, eye, and Divyang relief. He has been past president of NCCP and Indian College of Allergy, Asthma and Immunology. He has got total about 700 publications, published 17 books, citations, and H index is very high. And he has given oration, more than 10 orations and he has guided more than 200 students. Apart from this, he has got a big list of his contribution, his credit. The KGMU is now having 75 years of the establishment, and I think Dr. Suryakant is doing 75 programs in a year to celebrate this platinum jubilee of the KGMC, which is a very, very huge task. And I know he can do it, and he's doing it. He's almost completing it. This is something really creditable to Dr. Suryakant. With this, I just ask Dr. Suryakant to please give his Foundation Day oration lecture.
Thank you, sir. Good morning to everybody. Thank you, Dr. God, President of Indian College of Allergy, Asthma and Applied Immunology. And thank you, Dr. A.B. Singh, Secretary of Indian College of Allergy, Asthma and Applied Immunology. And of course, a great congratulations to the Dr. Surennath and his whole team from Hyderabad for organizing this wonderful event in a such odd situation. For last almost 1.5 years, we have been facing a lot of crisis in terms of not only patient care, but in terms of academics also. That's why we have clubbed the two conferences, the year 2020 and 2021. And I'm again thankful to the Credential Committee for choosing me for delivering this Icaaicon oration that is called Foundation Day Lecture 2020. So with this introductory word, and of course, good morning to everybody, I'm starting my topic. Sharing my slide. I think now everybody can see my slide. My slide is visible.
Yes, it is visible. Dr. Suryakant, it is visible. Go ahead. Dr. Suryakant, can you hear me?
Yes, Dr. Suryakant, go ahead. Slide is visible.
No, not yet.
Yeah, I can see.
Anchor gain shared internet.
Am I audible?
Yeah, you are audible.
Okay. So basically, we have trained our younger generation that we have to make a combination and a balance of pharmacological therapy as well as non-pharmacological therapy. Both are equally important. You see, the non-pharmacological interventions and measures can contribute up to 30 to 40% part of the management process of asthma management. So with this introductory remark on the role of and place of non-pharmacological therapy, I'm coming to the talk per se. According to the GINA, even GINA has emphasized the role of the non-pharmacological therapy. This is the definition of latest definition of asthma, which says it's a heterogeneous disease characterized by variable respiratory symptoms such as wheeze, shortness of breath, chest tightness and cough, and variable expiratory airflow limitation. It is usually associated with chronic airway inflammation. And if you see the burden, around 300 people globally and 37.9 million in India, and cause 46
There is something wrong with his internet. I am not able to hear anything. It is again probably hanged.
Yes.
Dr. Pawan?
Yes, sir.
Can you take care? Actually, there is something problem. It's not moving.
Slides are not moving, sir.
Slides were not moving. He was also not heard.
Voice is also not.
There is some internet problem, sir, in the King George Medical University, Lucknow. Am I audible now?
Yes, sir. Yes. Now it is visible, sir.
Okay. It is
just
visible? Okay.
Try again, sir. Try again.
Okay. So this is the GINA 2021 slide, which basically outlines the management of asthma. And if you see, the number 5 point, that is non-pharmacological therapy and strategy. So this is a very much evidence-based part and parcel of the asthma management that is highlighted by GINA guidelines 2021 also.
Again, there is a problem.
सर का इंटरनेट इश्यू है सर. Slides are there, but sir, now we are not able to hear sir.
This interruption, frequent
Can we
interruption.
request him not to switch off his video so that then audio can?
Yes, sir. That possibility is good. Yes, sir. Suryakant sir, can you hear us? Switch off your video so that you can be heard well. Suryakant sir, you can switch off your video and try, sir.
Unmute करिए Dr. Suryakant.
वीडियो हमारा कर दीजिए. Video.
Unmute करिए Dr. Suryakant. You are muted.
Okay, am I audible? Okay, so I'm
Yes,
switching
sir,
off
yes.
my video. Okay, now it's I'm audible.
Yes, sir. Audible, sir.
Okay.
Very good.
So, in continuation of this GINA guidelines, I personally prepared this slide, and we have made 9 points for the as a non-pharmacological strategies. Number 1 is asthma education, which is also mentioned in GINA guidelines. Written asthma action plan, which
It's not working.
Dr. Suryakant, you can use your mobile now.
That is the only way. Probably he will not have any problem. Can somebody call him and ask him to switch over to
for those
mobile?
And strategies for dealing with the emotional stress. So now I'm coming one by one for the various non-pharmacological strategies. Now coming first to the asthma education. Now asthma education is the, of course, the first point of GINA guideline as a non-pharmacological strategy. And the component of asthma education program may include information about airway inflammation and bronchospasm using figures to illustrate the concept. So patient has to understand what is the pathogenesis process, what is the inflammation process, the rationale and methods for avoiding irritants and relevant allergens, specific information on food allergy, description of the rationale, correct use and side effect of preventive medications and bronchodilators, means inhalation therapy, demonstration and practice of inhalation technique and monitoring, description of criteria for control and steps to take when control, of course, deteriorates, emphasis on the need for regular follow-up. So this is the asthma education plan guideline in GINA 2020 guideline as a first part of non-pharmacological strategy. Now coming to the, of course, written asthma plan. An asthma action plan is a written step-by-step guide to help and manage your asthma and recognize when it's getting.
Bhavan.
Sir, yes sir.
అదే
సార్ దగ్గర నుంచి ప్రాబ్లం ఉంది సార్ అక్కడ.
మొబైల్ సార్ మొబైల్ తో మాట్లాడండి చెప్పు.
Am I audible again?
Yeah. Audible, sir.
Actually, there is a some.
Suryakant, why can't you use your mobile?
That will be the best.
Okay.
Use your mobile with the hotspot on. So you are not worried about Wi-Fi then.
Mobile se connect.
No, I think best will be to use the mobile directly.
Mobile directly. Okay. Okay. Meantime, can I continue with this if I am audible? Okay.
Sure.
Okay. स्लाइड कहाँ से आएंगी इसमें?
स्लाइड हम यहाँ से प्रेजेंट करते रहेंगे।
हाँ अच्छा, नहीं ये तो कनेक्ट चाहिए ना, इससे आवाज जाएगी ना केवल। पीपीटी ट्रांसफर करो, पीपीटी ट्रांसफर करो, पहले इसको स्लाइड करो, वो भी चल रहा है। पीपीटी इसमें जैसे एक सेकंड।
Now you speak with mobile.
Okay. So a lot of asthma triggers we have to take care of. Avoidance of outdoor and indoor allergens. So a lot of asthma triggers are there in this country, and they are entirely different from the Western world. And we have to see various kinds of triggers and allergens. Avoidance of allergen is a very important measure as a non-pharmacological strategy. And that's why for the elimination of house dust mite, use the mattresses, sheets, and pillows, wash bedding weekly in hot water and dry in heated dryer, and remove dust mite reservoirs, reduce indoor humidity, and clean furniture, walls, and carpet if you are having in your house. And you should avoid the pets. And also you should take care of cockroach and pests, because cockroach allergy and pest allergy is also well known. And of course, you have to take care of the fungus also inside your house, and you have to keep the care of pollens also. And very important in this country is the perception of dietary foods. So food allergy can be the trigger for the asthma, but in this country, we did a study in which the perception of dietary food items as a food allergen asthmatic individual in North Indian population is entirely different from the rest of the world. And in this study, we found that roughly 22 commonly consumed food items were identified in this study as a patient perception, not actual.
Again, some issue, Dr. Surikant. सब कुछ आपके साथ ही होना था.
Elimination. Okay. Conclusion कहाँ से आए? Conclusion नहीं भाई.
Yes, sir.
Yeah. Okay. So next point is, am I audible, sir?
Yes.
Yes.
Okay. Next point is avoidance of air pollution and occupational exposure. As it is mentioned that air pollution is a major health hazard globally and in India also. It is associated with a mortality of 70 lakh people per year globally and 17 lakhs in India also. It has been clearly shown to be associated with causation and exacerbation of asthma, and certain occupational exposures to the allergen or sensitization account for a substantial proportion of the incidence of asthma. Always ask for all patients with adult onset asthma about their work history and their work exposure. Smoking cessation is also one of the important non-pharmacological study. And in this country, there are 12 crore smokers. 12 crore smokers. And not only these are the active smoker, well, they're also associated with passive smoking and later on the environmental tobacco smoke exposure. The management of asthmatic smokers should begin with the emphatic recommendation to stop smoking, including having no contact with environmental smoke. In my practice, I used to say कि या तो मेरा हुक्का चलेगा या तेरा हुक्का चलेगा, मतलब मेरा इनहेलर चलेगा या तेरा cigarette या हुक्का चलेगा. So you can't use both at the same time, inhaler as well as smoking. So you have to give the option, either use the smoking or use inhalers. So smoking adds to the problem of asthma and increase the risk and frequency of exacerbation also. And that's why the GINA has given a beautiful chart how to approach the asthmatic smokers. During each medical visit, you encourage these for the smoking cessation. Whenever possible, motivate asthmatic to avoid exposure to secondary cigarette smoke or passive smoking. Advice for parents and caregivers: do not allow smoking in the environment in which children, especially in sleeping room and automobiles. And in the initial evaluation of the patient, in patient with a history of smoking for more than 10 years, evaluate the possibility of asthma COPD overlap syndrome. So we have to always take care of proper history and proper motivation for the smoking cessation. Very important, another aspect is the pulmonary rehabilitation. Yes, It has been mentioned again in the GINA that pulmonary rehabilitation is a multidisciplinary approach of the disease management. Usually the patient undergoes a comprehensive assessment by specialists in order to tailor each intervention on a specific patient needs. And that's why we need patient education, counseling, breathing training, outcome assessment, nutritional advice, psychological support, etc. And the educational component of these programs can ensure the therapies are being used appropriately. And as a part of pulmonary rehabilitation, regular physical exercise can increase endurance, can reduce inflammation, can improve lung capacity, strengthen muscle, improve cardiopulmonary fitness, provide advice about prevention of exercise-induced bronchoconstriction to all patients so that they should not have the severe exercise. And certain other advice like warm up before exercise, SABA before exercise, low dose ICS formoterol before exercise, but regular physical activity should be encouraged. Now, what kind of breathing exercise we can offer? As soon as patient with benefit from
Too many interruptions.
Very complementary. And of course, there is an established mechanism for the. Am I audible, sir?
Yeah.
Okay. So is there an established mechanism for the yoga effect of yoga on the asthma? The all aspect of human psychosocial functioning improve. When the breath is steady, emotions become more balanced. When the body is still, the mind starts to calm down. Conscious focus on the present moment. Integration breath pattern with the coordinated smooth body movement. And that's why it has been seen that yoga help in asthma control in various ways, like acting as an adjuvant, affecting the biochemical profile, improving the antioxidant level, oxidative stress, biomarkers by improving lung function as well as increasing the overall well-being. And we did a study that I think this study is very well, of course, aware, and the PhD student got the Richard von Precare Prize also for the young student present researcher. And in this study, we used yoga as an adjuvant therapy for the asthma and management. And then, of course, we have a lot of publication on this study. There was a significant improvement found in daytime symptoms in yoga group at 3rd and 6th month, then control group. And the study was funded by the Indian Council of Medical Research. And then we have there was significant, another part of this study, that is there was significant improvement found in the proportion of hemoglobin and antioxidant superoxide dismutase, and it was published in the International Journal of Yoga. And then, of course, we did a randomized control trial on the result shows, the conclusion shows that overall this study shows that yoga is an effective tool to improve the pulmonary function, and it can be practiced as an adjuvant therapy with the standard medical treatment of asthma with better outcome. And again, it is published in an international journal. So this is our yoga room in the Department of Respiratory Medicine, King George Medical UP, Lucknow. And you can see a lot of people there practicing yoga. And of course, the pranayam is most powerful and most important part of the yoga, and that is having the healing potential for by a lot of mechanism. So prana means the life force or breath sustaining the body. Ayam means translates to extend or draw out. Together two means breath extension or control. So pran plus ayam means extension of breathing. And mental stress is an important cryptic trigger of asthma, and pranayama help in eliminating this trigger by making the mind and body calm and relaxed. And another important is healthy diet. You see, in Indian scenario, every patient expect that you should give some kind of other kind of advice regarding the diet. So what is the place of diet for the asthma management? The Western diets typically emphasize the consumption of animal product at the expense of fruits, vegetables, whole grains, and legumes. Asthma prevalence has increased with the westernization of dietary pattern. And that's why now GINA also says that high fat intake and low fiber intake have been associated with airway inflammation and worsens lung function in asthmatic patients. So we did a study on diet and nutrition also, and we published also. And the weight loss and improved functionality of organ help the body control of disease like asthma. And this another study we did, and that also resulted into the high fruit and vegetable diet is associated with the lower risk of asthma. And there is some evidence that in increasing fruit and vegetable intake leads to improvement asthma control and reduce the risk of exacerbation. So I think these are the 12 powerful anti-asthma foods. The University of Pittsburgh Asthma Institute has recommended these 12 foods. I think they can be practiced in India also. You see, banana is very much, notorious in terms of asthma practice. Whenever you ask the patient कि banana आप खा सकते हैं, तो patient will say, अरे banana तो सर्दी होती है, इससे तो खांसी होती है, इससे तो सांस फूलती है. So it's not like that. And ginger, turmeric, and all things, they can be especially used. And of course, green broccoli and spinach, they can also be used as an antioxidant also, and anti-inflammatory and immunomodulator also. So I think some other the home remedies for asthma, they can be used, including the honey also. My guru, Professor M.S. Agnotri, was very much fond of prescribing tulsi and honey to all patients of asthma, and I think they should be used as a non-pharmacological measure in terms of diet. Optimization of body weight is also important, and all because there are so many studies which have clearly shown the link between obesity and asthma. And of course, we should of course try to reduce the weight of all asthmatic patients who are obese. And obesity leads to the mechanical overload, which leading to airway hyperresponsiveness, insulin resistance, and ultimately the imbalance between TS2 and TS2, of course, immunity. So overweight and obese children are at high risk of developing asthma than the normal weight, and this has been published in so many studies. So this obesity can be due to so many factors. It can be genetic factor, it may be microbiome, inflammation, nutrition, airway changes, and metabolism. These are all manifestation and causation in the obesity, and that's why for the we have to do the weight loss intervention, and of course diet and nutrition are the very important part. And that's why I usually propagate, if you want to have the disease-free or immune child, you should make your child as a vegetable child. If you want a non-immune child or allergic child, then of course you can go for the burger child. So this is the usual saying, vegetable child versus burger child. And of course, this kind of education should be imparted to the patient and patient family of asthma. And then, of course, a bariatric surgery was also recommended if BMI is more than 35 kg per millimeter square. Then you can recommend for the bariatric surgery also if the patient is giving consent. Then, of course, the strategy for the dealing with the emotional stress, that's also important trigger factor for the asthma. And we should not leave the patient without evaluating his psychological status, because psychological status is also important risk factor for the precipitation of asthma. So these are the 9 points as if non-pharmacological.
I think this is the last slide, Dr. Surikant. Surikant. I think that was the last slide, Dr. Surikant. Audio problem.
Dr. Surikant?
There is some audio problem from their side.
Internet problem in general.
Sir got disconnected, sir.
Power.
He should
Yes,
have,
sir got disconnected.
he should have connected through cell phone and hotspot.
Dr. Surikant, can you hear us? No.
I tried to call him. He is also not receiving the phone.
Because phone he had been using it, na?
Yes, sir has joined, sir. Sir has joined.
Yes, sir.
Okay,
I have finished. Sir, I have already finished my conclusion also.
Yeah, that was the last slide I could get.
Yeah.
But in between there was a connectivity problem. Dr.
Yes.
God.
I tried to change from Wi-Fi to some another network, to some Geo,
Best,
BSNL. So many
would have been
network
to.
I tried during the last.
बहुत ज्यादा टेक्निकल savvy
Best
होने
would-
का भी
I was trying
I
to
think,
do.
yeah, Dr.
इसलिए अगली
Surikant,
बार फिजिकल कराइएगा.
Dr.
Yeah.
Surikant, yeah, we will do
In
it.
Delhi, it has already been recommended up to 200 people in the conferences and seminars.
Yeah, great.
Yeah, Dr. Surikant, I think I'm really thankful for your lecture. It was really a beautiful lecture I've heard before also. So I think, but unfortunately, I think there's some problem technical which is beyond our control. You tried a lot through all sorts of devices, but yes, we could get I would say 90% of the lecture. But yes, it was a disturbance, and I'm sorry for that. I think we all sorry for that. Because it was a wonderful lecture on something new topic. So, Dr. Surikant, thank you very much for your talk. Thank you very much.
And you can invite him again after some time for felicitation.
Yeah, I know. Yes, so we have decided that because of this virtual, we thought that we will have some sort of small brief program in Delhi or nearby, so that all the people who got the awards will be felicitated there.
Thank you, sir. Thank you.
Yeah, thank you so much, sir.
Thank you,
Now
sir.
I invite. Yes, sir. Narayan Reddy, sir.
Pawan, continue.
Now we invite Dr. Rajiv Kumar Bansal, sir, to deliver a talk on antihistamines in treatment of allergy. Sir, request you to share your slides, sir. Yeah. Dr. Rajiv Kumar Bansal, sir, is a consultant pediatrician and allergist at Santkoba Durlabji Hospital, Jaipur, India. Sir is very well known in the domain of allergy practice and all. Over to Rajiv Kumar, sir.
Good morning and thank you very much. The Indian College of Clinical Allergy and Dr. Surendra, Dr. Pawan and the team. I'm extremely thankful to you for inviting me and giving me this opportunity to talk to on.
दे दिया था हाथ का हाथ भर के आप किसका satisfactory report.
On after the legendary talks of the stalwarts, I'm taking you on a journey which is most on something which we commonly use in our clinical practice. That's the antihistamine in the treatment of allergy. I dedicate. Excuse me. Just a second, please. Yeah, I dedicate this talk of mine to Professor Dr. K. Nagaraju, who's father of pediatric allergy. He was my teacher, mentor, and philosopher. I really miss him while I'm delivering this talk to all of you. Let me take you to a brief journey of antihistaminics. Antihistaminics were discovered almost a century back, and they were pioneering studies from Annie Mary Staub and Daniel, who were awarded the Nobel Prize. The Icaaicon was introduced in 1942, and then diphenhydramine, chlorpheniramine, promethazine, something which we are using even today. And the most commonly used second generation antihistaminics were available in the market from 1980s, and they've really changed the scenario in the way we use our antihistaminics in our clinical practice. So antihistaminics are one of the most common OTC prescribed drugs, and the drug which is prescribed by clinicians too. More than 40 preparations which are available in the market. One need to understand that these drugs are inverse agonists rather than H1 antagonists. The major concern for H1 antihistaminics, which I'll tell you in detail subsequently, is the safety concern in children. However, second generation drugs of these antihistaminic groups are safe in children beyond 6 months of age. The histamine as a product or a chemical is being released from the mast cells, basophils, as well as from dendritic T cells, T cells, macrophages, and so on and so forth. And then they stimulate the various histamine receptors like the H1 receptors, H2 receptor, H3 and H4. H1 and H2 receptors have been widely studied, and they are present at multiple sites in the body. And the major role of histamine is in the allergic inflammation, as we all know. These drugs lead to hypotension. These this medication, this substance rather, leads to hypotension, flushing, and headache. And this is mainly because of the effect of histamine on H1 and H2 receptors, which are present in the vessel wall. The nasal congestion and the itching, which we see in our patients with allergic rhinitis, is mainly because of H1 and H3 receptors stimulation. And the bronchial smooth muscle constriction is mainly because of the H1 receptors. Now, this is all to be known because when we are using our medication, we have to be specific in how to use these drugs. As far as going to the concept of understanding of H1 receptors, because this is important when we talk about the side effects of the drugs, the efficacy of these drugs. Though in this particular diagram, which I'm showing you on the slide, there is a 7 transmembrane domain of the histamine receptors. As you see, the histamine activates when the histamine is there, it activates and it links the domain 3 and 5. And if you take a drug like cetirizine, it activates or links the domain 4 and 6 and makes the receptor inactive. So basically, it's an agonist in a different manner. It's not an antagonist, but it affects the it binds or links to different domains, and which makes the histamine receptors inactive. So we all know that when these inverse agonists act, they just don't let the histamine act onto the body and prevents the effect of the histamine. This is also important to understand that pre-treatment with oral histamine reduces early response to an allergen challenge in skin, conjunctiva, nose, and lower airways. Now, this is very important from the point of view that when we are doing a skin prick testing in our patients, the antihistamines have to be stopped for at least 5 to 7 days or more, depending upon the availability of the drug in the serum or the blood availability. Another important factor is antihistamines suppress the wheal and the flare response that is induced by histamine, and the antihistaminics blocking of H1 receptors on the sensory nerves leads to the itching and sneezing get suppressed because of these receptor activity. Now, coming to the classification of antihistaminics, antihistaminics are basically classified into first, second, or third generation. However, there's a lot of controversy on this classification, especially branding enantiomers or metabolites as second generations, the third generations. And for this reason, majority of the texts at the present moment take the antihistaminics as first or second generation drugs. And there is another way of classifying these drugs based on the brain histamine H1 receptor occupancy. Now, this is a very important concept which one needs to understand. If the antihistamines do not cross the blood-brain barrier and there is no CNS penetration and less than 20% of the brain H1 receptors are occupied, then the side effects are minimal. And the main 2 drugs in this category are fexofenadine and belastine. Sorry for the mistake. And the less sedative ones, the greater than 20%, but less than 50% occupancy is there with cetirizine, levocetirizine, loratadine, desloratadine, propatidine, and olopatadine. And the sedative antihistaminics, which are the first generation ones, they are diphenhydramine, chlorpheniramine, ketorifene, hydroxyzine, promethazine, and trazodone. So this figure tells you, now this has been analyzed in detail by Yami et al., and they have used the positron emission tomography to see the antihistaminic effects and their H1 receptor occupancy in the brain. So when we are talking of an ideal oral antihistaminics, we are looking for something which has no sedation or cognitive effect, which are selective. They preferably have a long duration of action with once daily dosaging, having a rapid onset of action with no cardiac effects. There are other things which we need to have, but these are the most salient features when we are looking in terms of a drug which is an ideal one for clinical use. So what are the most commonly used first and second generation antihistaminics in alphabetical order, which are available in clinical practice, are like chlorpheniramine, cyproheptadine, diphenhydramine, hydroxyzine and promethazine. They're still used in adult clinical practice, but in pediatric age group, as far as possible, we should try and avoid it because of their side effects. For the second generation antihistaminics, which are available with us, they are like cetirizine, bilastine, desloratadine, avastin, fexofenadine, levocetirizine, loratadine, etc. Coming to the first generation antihistaminics, the most important aspect of it is, the important thing to remember is they are available as an injectable form, and that's where they score over other drugs which are available. However, there are multiple adverse effects of H1 receptor antagonists, of H1 receptor antihistaminics. They lead to CNS neurotransmission reduction, leading to sedation, cognitive effects, xerostomia, urinary retention because of muscarinic receptor activity. They have effects on the alpha-adrenergic receptors, leading to hypotension, dizziness, and tachycardia. They have effect on serotoninergic receptors with increase in appetite, and they have effect on the cardiac channels, leading to QT prolongation and arrhythmias. And this is one reason that we have to be very careful using these drugs. Now, other important thing is the effect of first generation antihistamines on the sleep-wake cycle. And this is a classic study which was done by Church, MK et al. And this shows that there is an effect on the REM sleep, which results in less attention span, visual memory, and vigilance. And especially this is important in children, and children, those who are going to school. So, and even because of these factors, for people like who are driving vehicles, and for pilots, etc., the first generation antihistaminics, which affect the REM sleeps, are contraindicated for use. The other important thing, which especially with H1 receptor antihistaminics, is the effect on the QT prolongation and torsade de pointes effect, and hydroxyzine is notorious for that. Also, second generation drugs like avastin also prolong QT interval, and we have to always look for antihistamines which are cardiac safe, and cetirizine is one of those drugs which is branded as cardiac safe. So coming to the second generation antihistamines and why they score over the first generation is the second generation one are effective not only on the H1 receptors, but they also affect the H2 receptors, and they bound to both of them, and this where they score over the first one. They help in relieving nasal congestion and conjunctival edema because of H2 stimulation. They have a relative specificity for the H1 receptors and negates anti-serotogenic, alpha-adrenergic, and muscarinic effects, which we have seen earlier, responsible for multiple side effects. Very important thing is they have an anti-inflammatory effect, and I'll be talking in detail about them. They got a great affinity for the peripheral receptors as compared to what the central receptors are, and they're useful in school-going children. The anti-inflammatory effect of cetirizine, levocetirizine, loratadine, and fexofenadine have been studied in detail, and this effect is mediated by the activation of NKKB, a transcriptor factor. And this is a very important thing, especially when we are talking in terms of nasal congestion. And they also have effect in the reduction of pro-inflammatory cytokines and eosinophils action, and they reduce nasal congestion and hyperreactivity. Looking to this factor of nasal congestion, it's important to realize that we need to give antihistaminics, especially the H2 ones, on a continuous basis rather than as a demand therapy to have an excellent effect. When we are dealing with these drugs, we also need to understand the metabolism and elimination, because that's only where we can come to a point where we know that where we will have the side effects of these drugs. One need to realize that many of the antihistaminics are metabolized through the CYP3A4 enzyme systems, and drugs like desloratadine are metabolized extensively in the liver. But the drugs like fexofenadine have a minimal liver metabolism. They are in fact secreted in the intestine and are primarily excreted in the feces. The other important thing, as far as pharmacokinetics and pharmacodynamics of these drugs are concerned, these drugs are rapidly absorbed and they are reach serum concentration within 3 hours. However, food slows their absorption, and one has to realize that pharmacodynamic activity is unrelated to the serum levels. In fact, it's related to the distribution of the drug in of these drugs, and this affects the overall activity of these drugs. Also, one has to realize that these drugs have got a very high safety profile, and they can be even given up to more than 4 times the standard dosages without any side effects. It's also heartening to realize that the second generation antihistaminics have no interaction with alcohol, and that's where the beauty of these drugs lies with. So coming to summarizing the pharmacodynamics of the major second generation drugs, as we see, their onset of action is generally within 2 hours, maybe even earlier than that. The duration lasts for almost more than 24 hours, and the elimination varies from 6 hours to almost 24 hours. And when we see for the clinical profile of these drugs, majority of them are metabolized in the liver, and the elimination is mainly renal, and the adverse effects are mainly related to sedation to some extent and headache, and they are either to be dose adjusted or contraindicated in severe renal insufficiency or hepatic insufficiency. They have to be looked for their drug interactions, and they need a dose adjustment, as I have told you. The contraindications are especially in patients with epilepsies, and this is very important when we are using the first generation drugs. Should preferably be avoided in acute porphyria, the exception being chlorpheniramine, promethazine, and loratadine and fexofenadine. And they should not be used in neonates. And promethazine is actually contraindicated below 2 years of age, though in fact the pediatricians so commonly use antihistaminics and promethazine in their smaller children. And at the same time, we need to realize that cetirizine is very safe for the heart. Now, what is the evidence? What's the clinical use, and what's the evidence supporting the use of H1 receptor antihistaminics? And they are used in multiple conditions like allergic rhinoconjunctivitis, urticaria, asthma, atopic dermatitis, etc., by all of us in day-to-day practice. So the mainstay of treatment for allergic rhinitis are antihistaminics, as we all know, and they are the first line of treatment for seasonal and perennial allergic rhinitis. They're very effective in the symptoms of nasal itching, sneezing, and rhinorrhea. The drugs like levocetirizine and fexofenadine, and as we have already seen, shows improvement in nasal obstruction because of the anti-inflammatory effect. These drugs are used in children born than 6 months of age, especially cetirizine, levocetirizine, and fexofenadine. However, loratadine should be used beyond 2 years of age. And the newer drug which is available in the market and is much more talked about, the belastin, which has got very, very minimal CNS penetration or CNS side effects because of sedation, is recommended only beyond 6 years of age. And the intranasal preparations of these drugs are available, especially azilastine, though it's very bitter when they take it, and it's not that easy for small children to take it. As far as urticaria is concerned, the second generation antihistaminics are the first line of treatment. In acute urticaria, from clinical point of view and from our day-to-day practice, cetirizine or levocetirizine should ideally be used because they have the fastest onset of action, and levocetirizine is more effective in suppressing wheal and flare response as per one study which I saw and studied. And the daily administration of histamine is more effective in chronic urticaria. We need not miss. They may sometimes have to be given for longer period of time, maybe 3 months, 6 months, or in patients with angioedema up to 6 to 12 months. And one can use safely up to 4 times the routine dosages if in case it's indicated. As far as allergic asthma is concerned, the rhinitis component is taken care of by antihistamines, and where the role of this drug lies, it has been seen that cetirizine reduces exercise-induced asthma and it improves cough in children with pollen allergy. So this is where the antihistaminics have a role. Otherwise, GINA doesn't give it much hype for antihistamines used in asthma. As far as atopic dermatitis is concerned, they have very limited role. They can use adjunctive drugs only. It has been seen that cetirizine may reduce the duration and amount of topical steroids, and it seems that the new H3 and H4 receptor antagonists, which might be available in near future, will have a better anti-proliferative effect in patients with atopic dermatitis. As far as the use of antihistaminics in anaphylaxis and non-anaphylactic acute allergies, antihistaminics don't have a role as a first-line drug in anaphylaxis. One has to and should insist on the use of epinephrine and initial resuscitation. However, antihistaminics can be used in hypersensitive reactions to drugs, for mild transfusion reactions, and these drugs are also indicated in patients with vertigo and motion sickness. As far as allergic conjunctivitis are concerned, older drugs can be used. We have got some excellent ocular preparations of these antihistaminics, especially olopatadine and levocarbastine, and these drugs provide immediate relief, and they can be used along with mast cell stabilizer drugs. As far as the use of antihistamines in cold and cough, it's a big no to use these drugs because they can cause thickening of the mucus and they don't have a role in common cold. In fact, most of the pediatrician or even adult specialists, they try to use antihistamines for cold and cough. They should not be used. They are not the drugs at all for cough. They are only to be indicated if there is a component of allergy associated with the cough and cold. What about the safety of antihistamines in pregnancy? Most of these drugs are relatively safe, and they have been studied extensively for use in pregnancy. So just to summarize, antihistamines are among the most widely and commonly used drugs, but they are incorrectly used medications worldwide. The first generation antihistaminics are associated with substantial and sometimes fatal adverse effects, and they should preferably not be used in the present era. Newer antihistaminics are safer, they are affordable, and they are efficacious as compared to the first generation antihistaminics. Antihistaminics should not be used instead of epinephrine to treat anaphylaxis, and most antihistaminics are safe during pregnancy and lactation. I thank you very much for your patient hearing.
Yeah, thank you, Dr. Rajiv. A beautiful lecture and a beautiful illustration of basic management allergies. So that's very true. Wherever itch, antihistaminics there. Nasal itch, it is there. And though there's an itch, urticaria, atopic dermatitis is a beautiful role to play. But there is an individual variation in the response to the drug. And some of the people, even in the 1/4 tablet of the levocetirizine, gets acidated. That's one of the points to be noted. Number one. Number two, all antihistaminics are not safe in pregnancy. It's the class 2 evidence is that the levocetirizine is only safest drug out of all antihistaminics in pregnancy. That's not even the class 1. It is the class 2 evidence. Number 3, the point is this, just gone to my market. Yes, so very truly said, there are contraindication. There's a mismatch with the setup of the drugs. Number one, they should not be given along with calcium channel inhibitors, because many times we are in habit to pop up 2 or 3 drugs at one time. So we should be very careful not to pop up with anti-hypertensive drugs like calcium channel inhibitors, because nifedipine has mismatch reaction with the antihistaminics. Number 2, that's truly said, antidepressants. Again, you should be very careful not to take 2 molecules along one side. Number 3, anticonvulsants, truly said, not to be taken at a one gulp. It should be spaced by 4 to 6 hours. So 2 molecules should not be taken all along. Anyway, Mayal, congratulations. Heads off to you, sir. Congratulations.
Yeah, thank you so much.
Thank you very much. Thank you.
Thank you, sir. Thank you so much, Raju Bansal, sir. Now we'll next move on to the next interesting session. This is about interesting cases in allergy, which is being moderated by Dr. Swati Gupta. She's the moderator, and the panelists will be Dr. U. Narayan Reddy, sir, myself, and Dr. Deepti Pujari.
Sound wave?
Yeah, Dr. Swati. Dr. Raju, will you stop sharing your screen, sir? Dr. Raju? Azhar, can you stop screen sharing of Dr. Raju, sir? Yeah.
No, sir, I can't.
Yeah.
Yes.
Yeah, now I introduce Dr. Swati Gupta, who is an MD, fellow of allergy and clinical immunology. And she's an associate consultant of pediatrics and at Allergy Clinic Fortis. And she did her MBBS and MD Pediatrics. She's a gold medalist from SSG Hospital. And she has a fellowship in allergy and clinical immunology from Savita Medical College, Chennai. And she's the first prize for poster in annual conference in IAP Chandigarh 2019. And she's faculty at Pediatric Allercon 2018, 2020, and RhinoCon 2019. She's author of Investigations in Pediatric Allergy in the IAP Textbook of Allergy and Applied Immunology. Over to you, ma'am.
Thank you so much, Dr. Pavan. Let me start with thanking all the organizers, Dr. Pavan, Dr. Surendranath, and all the seniors to give us this prestigious dice to present our cases. I'll begin with introducing our panelists. Let me share my screen. Is it visible to all?
Yeah.
Thank you. So, Dr. Upin Narayan Reddy, he's a professor and HOD at Department
Will
of
you make
Pediatrics.
it a full screen?
Sure. It's done?
Yes.
Yeah. So Dr. Upin Narayan Reddy is a professor and HOD Department of Pediatrics, Deccan College of Medical Sciences, Hyderabad. He's also have a 30 years of experience, vast experience in teaching undergraduates and postgraduates. He's got 30 publications in index journals. He's also a Central IAP EB member, National Coordinator of CADE module, and has also organized many national pediatric conferences, as well as he's an executive member of IAP city branches and state branches. Next is Dr. K. Pavan Kumar. I know he's known to everyone now. He's a professor of pediatrics, MNR Medical College, consultant pediatrician at Omega Clinics. He's got Best Researcher Award, as well as got National Award winner for his scientific research paper, and has got many medals to his achievements. Dr. Deepthi Pujari, she's a consultant allergy specialist at Dinanath Mangeshkar Hospital at Pune, and she has been trained at different hospitals in UK as well as in Mumbai. She's a national trainer for IAP CADE module and cough module. So I welcome you all, and let's start with the session with first case. This is a 9-year-old boy who presented to triage with acute abdomen. He had fever and articular rash for last 3 days and came with acute abdomen. For last 2 days he was wincing in pain, and when he landed into triage, it was impossible to stop his pain with many management done at that time. He also had loose stools for 1 day and an outside report of total counts which showed a high TLC of 18,000. He was taking some oral antibiotic as well as steroid for last 2 days, and on presentation there was no rash. This patient was 50 kgs, vitals were almost normal, 99-degree fever, 114 heart rate, 98% was saturation, BP was okay, 110/70, GCS was also normal, but he had a mild hepatosplenomegaly and there was slight tenderness in right iliac fossa. So we thought it's an acute appendix. We ordered for an ultrasound. There was a probe tenderness, but appendix could not be visualized. Meanwhile, we tried different analgesics. We tried rotavirin, diclofenac, tramadol, one after the other, but the patient was still wincing in pain. We started amikacin, ceftriaxone, as well as supportive medication, thinking of acute appendicitis or a colitis. Meanwhile, investigations were sent. There was a raised TLC count in our hospital also, but CRP was highly raised. But surprisingly, the peripheral smear had no toxic granules. Urine showed protein plus WBC slide 2 to 3. Typhoid was negative. and we got a CT scan done. It again showed a circumferential thickening of the ileum, and there were few discrete subcentimetric mesenteric lymph nodes, but there was no appendicitis. So we thought, what would it be? This was the CT finding. You can see terminal ileum was having a circumferential thickening. This is called a donut sign with a contrast lying inside the intestine. They had put a query infective etiology. Meanwhile, what happened? The patient showed a fresh episode of acute abdomen with urticarial rash. And it was almost 12 hours after the admission when he was having a moderate pain, but this was a pop-up of pain again. We gave him phenyramine injection, and surprisingly, rashes went off, but pain also went off. So this gave us a clue that this is something else. We retook the history. Mother gave us this time a history of mild intermittent rhinitis, seasonal allergic conjunctivitis, and history of recurrent abdominal pain occurring since 5 years of age and which has almost become perennial now. Family history was also positive with asthma in grandfather and recurrent pharyngitis in father. So we thought this must have an allergic background. We got an IgE done, which was raised. And provisional diagnosis of allergic acute abdominal angioedema was kept, and we started managing on these lines. Workup was sent, patient was given IM adrenaline, as Dr. Rajiv rightly said, this should be given at the first line management, and patient was totally pain relieved for next 6 hours. After that, fresh episodes of high-grade fever with shivering occurred at an interval of every 10 hours, but the child was totally normal in between the episodes. His procalcitonin was sent to see whether infective etiology was really there, and yes, it was not that much raised as CRP was raised. So it could be an inflammatory reaction also. Then we decided to give him pulse methylpred and then treat on the lines of abdominal angioedema only. Patient became asymptomatic within few hours only, and child was discharged after 3 days. Follow-up investigations show a drastic decreasing pattern. CRP came normal by day 10. TLC, DLC also decreased. Now serum tryptase, which was sent, came after 15 days, which was raised, and it proved diagnosis. So we went on ahead, did a skin prick test after 6 weeks. He was sensitized to dermatophagoids, terinosis as well as farinae, and to cyanodon also. So our diagnosis was acute allergic abdominal edema with mild intermittent rhinitis and seasonal allergic conjunctivitis with recurrent abdominal pain. So let us start with some questions. First question to Dr. Narayan Reddy. Can you list some common 5 differential diagnoses of non-surgical causes of acute abdomen?
Yeah, thank you. So common cause of pain abdomen, children we commonly see functional, number 1 actually most of the time. Functional usually around umbilicus. Any abdomen beyond umbilicus, definitely think of organic. Of course, mesenteric lymphadenitis also you can get pain abdomen. Always think of course, this season dengue fever also they can present severe pain abdomen, non-surgical. Yes. Right? Acute pancreatitis. Of course, you can see HS purpura also they can acute pain abdomen. Even porphyria, I have seen 2-3 cases porphyria acute severe abdomen where they done surgery also. And even sickle cell anemia, I would think of they can present the acute severe pain abdomen. And even diabetic ketoacidosis, sometimes they can present severe pain abdomen. And abdominal migraine also they can present severe acute pain abdomen, non-surgical. Abdominal epilepsy also, yes. These are the causes of non-surgical acute pain abdomen. And also, as you said, hereditary angioedema. So there may not be urticaria. That hereditary angioedema, there is not non-allergic angioedema, where they may present acute severe pain abdomen.
So abdominal acute abdomen, which is not associated with skin symptoms or other systemic symptoms, sometimes can mislead, and patient may end up into exploratory laparotomy also. So second question to Dr. Pawan, what are the types of angioedema?
Yeah, if you see the angioedema, so it is classified most commonly into 4 types: acute allergic angioedema and non-allergic drug reaction. These 2 are most common, and idiopathic or chronic angioedema, which is also histaminergic and non-histaminergic, and there is a hereditary angioedema also. So if you go, this mainly these types are like because based on the kinin-mediated angioedemas are like increased level of bradykinin will be there, There will be endothelial cell activation, and there is increased cell permeability is also there, and unresponsive. The main feature is they are unresponsive to antihistamines. So the one which is most common is like hereditary angioedema. If you see the frequency of 1 in 10,000 to 50,000, there will be a swelling of extremities, respiratory and gastrointestinal tract will be swollen. It has a childhood onset, which is very important for the pediatricians, and that there is a family history, the strong family history. Almost 75% of the cases have the strong family history. There is no underlying disease, and they usually does not respond to antihistamines. And there is an absence of urticaria, and the swelling is spontaneous and triggered by stress. And second common is a drug-induced angioedema, which may account to 4 to 8% of angioedema, wherein the swelling may occur anywhere. And it's frequently caused by ACE inhibitors, which are very commonly used. And there is an absence of urticaria and no family history in this. And the other two are like acquired angioedema, that is also very rare, which usually see in the adult onset, like more than 40 years. Here also there is an absence of urticaria, and the swelling will be similar to hereditary angioedema only. And if you see that the fourth type, the idiopathic or non-histaminergic angioedema, this is also very rare, but it also does not respond to antihistamines. So these are the 4 types usually, which we commonly see in the practice.
Okay. So next question, Dr. Deepti, can you describe the pain in abdominal angioedema?
Okay. Thank you, organizers, for this opportunity. So pain in angioedema could be really varied. Sometimes it can be chronic, persistent, recurring, occurring again and again if left untreated. But many times when the angioedema attack is there, it could be severe, excruciating, cramping, colicky abdominal pain, which is really severe, almost seen in 80 to 85% of the cases. And it could be associated with vomiting and diarrhea in almost 70% of the patients. Now, the interesting point is it could have prodromal periods. So most of the GIT manifestations are associated with non-specific prodromal phase like extreme irritability, extreme aggressiveness, fatigue, hunger may precede such attacks. So if you have some suspicion and a child is presenting with some such abnormal behaviors, our antenna should go up that the child could be ending up into abdominal angioedema.
Correct. And had we not treated with this case or the case, like we say the pain, if we don't treat with adrenaline, what would have been the course?
Okay. So interestingly, most of the children, they would resolve typically over the next 2 to 5 days. But remember, our child had severe symptoms. He was not responding to many drugs which were given. So such children, had we not given our proper adrenaline, steroids, everything, such children may develop severe ascites and even rarely hypovolumic shock. This occurs due to massive fluid in the abdominal cavity, the peritoneal cavity, and the intestinal lumen. And interestingly and unfortunately, most of them would land into surgical emergency as acute abdomen, end up in operation theaters, end up opening the abdomen, laparotomy for appendicitis, finding out that the appendix was normal. So this is typically the course which we can follow. So maybe acute abdomen, surgical landing, resolving on its own in 3 to 5 days, or severe ascites and hypovolumic shock. And sometimes other features might come up, like you have already mentioned in your case, ending up into erythema, urticaria, rhinitis, conjunctivitis. So associated features can also develop if left untreated.
Right. Thank you, Dr. Deepti. So the take-home message is, if this is for ER doctors especially, if you think the patients, especially in case of children, but nowadays these patients also come in adult age group also, any pain which is not responding to normal analgesics, your antenna should be higher up, that these could be something related to allergies or angioedema, and take a proper history and try, and you can start with these emergency medications at there only, so that the patient doesn't land up into an ICU. So coming to second case, this is 22-year-old female who's a nursing staff working at a corporate hospital. She actually came to OPD for a second opinion. She had twice history of anaphylaxis while on duty. The first episode occurred when she had an ankle sprain and she was taking Ultracet some painkillers, and then she took Ultracet also, and within 5 minutes of that she got red and itchy rash. She was having itchiness all over the body, and then suddenly developed choking. She took Avil and Hydrocort but was not relieved and ended up in ER with choking. She was shifted to medical ICU immediately, given IV steroid, adrenaline, supportive medications. She was ventilated for 5 days and then discharged, and then the diagnosis was kept as laryngospasm and ARDS. After 4-5 months itself, again, she developed a similar episode. This time after a breakfast, after 10 minutes, she developed rash, itching, and stridor. Again, given adrenaline nebulization, ventilated on NIV for 3 days, and then discharged. When she came to me, we planned for an SPT, but we said since 6 weeks have not been over, let's wait for another 2 weeks. But in next 10 days itself, this patient again got admitted with another third episode of anaphylaxis. Now this time she was actually menstruating, and she took Meftal-Spas, and then developed wheezing, quickly became breathless, unresponsive, again given similar ICU management. But this time, the other history which she gave was that she was in the habit of taking Meftal-Spas in every cycle. And the last episode also, she took this medication, and that was during periods itself. And last 2 episodes, she consumed some South Indian food in breakfast. And after that, within few minutes, she was having choking along with some other medications intake. We took a past history. She was a hostelite. So we know what are the rooms, what are the conditions in the room in a hostel. For 3 years, she was in a hostel. Then she was in the corporate hospital. Again, there she was residing in a hostel. She developed seasonal asthma the moment she shifted to the corporate hospital in Dehradun. There was a sudden shift of climate from Haryana to Uttarakhand. And she developed seasonal asthma. She was taking steroids and inhalers in the change of season. And she was also diagnosed with inflammatory bowel disease there. The family history was diagnostic of asthma in maternal grandparents. His mother was also severely allergic to Congress grass, and she was almost taking daily antihistaminics and steroids for the whole year. So this gave us a clue. We evaluated for allergy. This was a skin prick test done after some time, after a few weeks, and she showed sensitization to cyanidon as well as peanuts as well as dermatophagoids. We kept a diagnosis of seasonal allergic asthma with inflammatory bowel disease with recurrent anaphylaxis. Could be catamenial, could be NSAID induced, could be peanut allergy with an atopic background. So with this case, my first question goes to Dr. Narayan Reddy. Which signs and symptoms point towards anaphylaxis?
So anaphylaxis, most of the time it is underdiagnosed, undertreated, because unfortunately it is very cheap drug available to treat them to prevent more prolonged hospital stay. So that's why there's a criteria by National Institute of Allergy, Infectious Disease and Food Allergy Anaphylaxis Network. There's a 3 criteria, 1 arm 3 criteria fulfilled. Definitely you can say diagnose anaphylaxis. Of course, the sudden onset reactions within minutes to hours, within 2 hours develop sudden onset. Number 1, skin manifestations. More than 90% they have skin manifestations. The urticaria, angioedema they may have. Respiratory manifestations they have 50-60%. Like upper respiratory, like stridor, they may have wheeze, they may have chest tightness, they may have. Severe suddenly they collapse. They have hypotension. Less than 30% of the blood pressure comes down. Also, GIT manifestations they have cramp, pain of abdomen, vomiting, diarrhea they may have. So these are the manifestations. They have at least 1 among 3 is there. Definitely you can think of anaphylaxis and give injection adrenal immediately. Intramuscular, intra-arterial thigh should be given. You can relieve the symptoms, you can save the time.
Okay. So anaphylaxis, if we know the allergen and the patient has consumed allergen and patient suddenly goes into shock, this is anaphylaxis, or could be just hypotension. If we have a doubt on an allergen, then we should have 2 systems involved, or it could be rashes. So out of the 4 systems of a skin, of a cardiovascular system, respiratory system, BP goes down. If you have any 2, this is anaphylaxis. So have to act immediately. Okay, Dr. Pavan, which food can cause anaphylaxis?
There's a one reservation, madam. In fact,
yeah, please.
Anaphylaxis has a 2-phase reaction. Many times it is an early phase and late phase. So never try to believe on the first phase. Treat the first phase, but always keep another 1 injection with adrenaline or EpiPen. Some of the people do have a late reactions also. So
yes, sir.
that's very important. Number 1.
Are there. Yeah.
Number 2, choking, ghabrahat, sweating is one of the very important phenomena. One should be very careful, because if anaphylaxis is not managed in first 20 minutes, 90% deaths are reported. So we have to be very careful about it. And we should request the country authorities also to provide EpiPens also, because till now we don't have EpiPens in our country.
Very true, Dr. Pradyum Sharma. But though we know that it is anaphylaxis is a severe and potentially life-threatening condition, the cause, if you see, only 1/3 of the patients only have identifiable triggers. So the most common one is the food, followed by bee wasp stings, medications, and blood products. But the food remains the most common cause. And in the food also, if you see that the common 5 things which we tell the parents, like the peanuts, fish like shellfishes like oysters, lobster, shrimp, crab, and other things like milk, egg, and wheat products. These 5, like these are the common food which can induce anaphylaxis, Dr. Swati.
Correct.
Truly said, but the drugs are very important, because in many times in our setup we have seen a patient is using a diclofenac gel.
Correct.
Nothing happened. Taking a tablet, nothing happened. But the moment we gave an injection, she went just hypertensive, shock, and decent.
So Dr. Deepti can very well answer this question, I think.
We understand the food, but besides there, many of the molecules are deodorants, because they have been so reported.
Yes, sir. Yes,
so
sir.
We have to identify many other molecules.
So, Pradyum sir,
definitely.
The next question follows.
Adrenaline and oxygen are the 2 mainstay.
Correct.
Yes,
so the next question actually is based upon that.
Yes, sir.
So Dr. Deepti, please answer. Which OTC drugs can cause anaphylaxis?
Yeah. So we are coming to the point. So a lot of drugs, patients, especially in our country, they see some neighbor taken some drug, felt well, they'll just go to the chemist, and even chemists prescribe anything and give anything. So especially antibiotics, the penicillin, sulfa, and the tetracycline group of drugs are notorious to cause anaphylaxis and severe reactions. Because penicillin is such a big molecule, it forms haptens quickly and leads to a lot of anaphylaxis. That's why the fashion of using penicillin is slowly going down, unfortunately, in our country. Same thing with Septran. Over the counter, Septran is available left, right, and center, and it can cause really lot of trouble. So also with tetracycline. Now, like in our case, non-steroidal anti-inflammatory drugs, the most abused drugs, over-the-counter drugs, which are really notorious to cause anaphylaxis. And the problem is they cause, because of their mode of action, they cause leukotriene, prostaglandin imbalance. So if you are allergic or anaphylactic to one non-steroidal anti-inflammatory drug, because of its mode of action, you should be avoiding the whole group of NSAIDs, because they act in almost the same way. So the whole group should be avoided. Third, ACE inhibitors, because they increase bradykinin. They cause, very commonly used in our country, enalapril, captopril, lisinopril for decreasing blood pressure. Over the counter, even chemists give many a times. They are notorious at anaphylaxis. These are some of the over-the-counter drugs. Then, as we all know, some other products, vaccines, muscle relaxants, all these drugs, but they are definitely not over the counter, but they also cause anaphylaxis.
Correct. Thank you, Dr. Deepti. And next question, accordingly, like we have drugs, we have food, which are the cofactors in a patient which can amplify anaphylaxis? Dr. Reddy, would you like to answer, please?
Yeah, particularly any acute infection, respiratory, GIT, they can decrease threshold. Number 1, stress, particularly women during menstrual cycle, exam, any stress, they can one of the factor, and also exercise, following exercise, and also even disruption of routine, flying, airplane, but the disruption of routine sleep, they also affect the anaphylaxis, decrease the threshold. That is the reason actually.
And for females, as in our case, we get the possibility, right? Okay. So next question, Dr. Pawan. First line medication in case of anaphylaxis, how soon to be given, what route, what dosage?
Yeah, undoubtedly, Swati, I think it should be the adrenaline remains the first and the most important drug to be administered during the management of anaphylaxis. The dose should be 1 in 1000, the dose of 0.01 mg per kg, maximum total of 0.5 mg, and it should be administered by intramuscular. Please remember, it should be administered only intramuscular into the anterolateral part of the thigh, and can be repeated every 5 minutes to 15 minutes, depending upon the patient response to the previous dose. And it acts directly by acting as a sympathomimetic agent. We all know the alpha adrenergic action increases the peripheral vascular resistance, which helps to reverse the peripheral vasodilation, and it also has a positive chronotropic and inotropic effect. And the beta-2 adrenergic effect causes bronchodilation and reduces the inflammation mediator release from mast cells and basophils. So the potent drug, the only drug should be the adrenaline intramuscular.
Okay. And Dr. Dipti, what after this? So after this, what management to be given so that there is not a recurrence of anaphylaxis?
So very rightly said by Dr. Pavan, acute management is adrenaline, adrenaline, and adrenaline. But as we all know, there is always a late phase of anaphylaxis. We don't want it to recur. It can recur anytime, even up till 24 hours. So the best mode of action is and keep this patient under observation. The patient has to lie flat on the bed, leg end raised, high flow oxygen, and then depending on the condition, we should go ahead. Suppose we are saying a lot of hypotension, then IV line should be put, and along with adrenaline, I repeat what Dr. Pavan said, adrenaline is the first. Along with adrenaline, we have to give normal saline 20 ml per kg boluses. If there is a lot of stridor and wheeze, then along with adrenaline intramuscular, we should be giving salbutamol nebulization. We have to reassess the patient, and then we can repeat the same process of IV normal saline bolus, salbutamol nebulization after 10 to 20 minutes. Along with this, to prevent the late reaction, we can give IV or intramuscular chlorpheniramine and hydrocortisone. Chlorpheniramine, depending on the age and weight, anywhere from 2.5 milligram till 10 milligram intramuscular or very slow IV. Same thing, hydrocortisone, to prevent late reaction, we can give anywhere from 50 milligram to 100 to 200 milligram in more than 12-year-old kids. Slow intravascular or even IM injections can be given. But the bottom line is patient should be admitted, kept under observation, lying flat, leg end raised, high flow oxygen, and continuous monitoring to prevent any late complications.
And after this, once the patient is stabilized, we send them home. There has to be a 2 weeks complete coverage of steroids, oral steroids plus minus antihistaminics. That's a protocol which was missing in my case, and even I forgot when she came to visit me. That's why she had a third reaction again. Okay, coming to the third case, this is an 11-year-old child from Karnal, Haryana. He was symptomatic since 3 years of age. Recurrent fever every 1.5 months, nose block, sneezing, headache, itchy watery eyes. He had seasonal asthma requiring inhalers. He had recurrent urticaria, and the symptoms were severe enough to disturb his daily routine as well as sleep. There was a positive family history of rhinitis and asthma in father. Patient was typical, having allergic shiner faces, adenoid faces, rhinitis, pharyngitis, dry skin. He was actually referred to me from an ENT. He was posted for a FESSF and for a fungal granuloma removal, and he required my assessment. So I just told them after surgery only we are going to complete his evaluation, but right now let me go for a screening. This was the reports he had come along with a normal TLC count, but TLC showed eosinophilia. CT scan showed fungal granuloma, sinonasal polyps, severe adenoid hypertrophy. And I screened him for his immune deficiency workup. Immunoglobulins were normal except IgE, which was highly raised, and specific IgE was also highly raised. So he was operated. We got his test, skin prick test done after 6 weeks, and he showed sensitization to dust mite, both the species as well as to fungus. His basal levels were also raised for both of these, fungal more than the dust mite. But then we decided to treat him because this patient may end up having continuation of allergic march. So this was his diagnosis: severe adenoid hypertrophy, allergic rhinosinusitis grade 4, sinonasal polyp, fungal granuloma, seasonal asthma, mild conjunctivitis, and urticaria. We decided to treat him, gave him subcutaneous immunotherapy. He took 2.5 years till now. And yes, he has almost every condition has become passive except the rhinitis, which is mild and seasonal. So rest all things are gone. So my question now is to Dr. Narayan Reddy, what is different between polysensitization and polyallergy?
See, polysensitization, there is sensitization. There is no disease, there is no allergy. So they always have to correlate clinical history. So because there's some multiple skin test positive doesn't mean they have allergy to that particular antigen. So polyallergy means, of course, they have disease manifestation to that allergen. So I always correlate with history is very important, but avoidance or immunotherapy.
So
of course, multiple
polyallergy
immunotherapy
is
cannot give. One
Yeah.
one antigen should be given now, recently recommended. So we can't give multiple antigen for immunotherapy.
Right. So all polyallergies will have polysensitizations, but all polysensitizations will not have polyallergy. May not have. Okay. Dr. Pavan, could snoring be a presentation of allergic disorder?
Yes, Dr. Swati, I think we all seen in our protein practice during the allergy season, it's a busy time for the snoring complaint and all. Allergies in and of themselves don't typically cause snoring, but the effects of allergies on the body, especially in creating the blockages of the airway, that can lead to or exacerbate the snoring. The most common one, which we, as the case comes, like, allergic rhinitis is the most common, and the adenoid atrophy, these are the common things which will induce this. How they do is the allergy cause your nasal passages to swell, which restricts the airflow and makes breathing more difficult while you are asleep. If you can't breathe through your nose, I think most of the times what happens is the throat, it will result in sleep apnea also. So they indirectly, they will make the passage swell, and that will result in snoring.
Correct. And sometimes I've seen many patients, the parents won't say the patient snores, my child snores.
Very true.
But indirectly, if you ask, is there some saliva coming out of mouth, an angle of mouth?
If you ask them mouth breathing, then
they'll say yes,
they will tell you.
But they will never say it's a mouth breather or it's a snoring.
Snorer, yeah. Very true.
Okay. So next question, Dr. Deepti, which factors you consider for starting immunotherapy in children?
So yes, we should be very careful before starting immunotherapy, otherwise it will be a failure. So it shouldn't be given to any allergic condition. Patient comes and we start pea soup therapy. No. So what are the indications? Who will benefit? Mostly it is mild to moderate to severe allergic rhinitis, allergic conjunctivitis, mild to moderate persistent allergic asthma, and Hymenoptera venom allergy. Now, should we start all the patients with these conditions? No. Again, only if there is insufficient response to environmental control. If there is insufficient response to pharmacotherapy, or the patient is getting too many side effects due to pharmacotherapy, or there is a compliance issue, not taking drugs regularly, so there are exacerbations in between and then a normal period in between, not sticking to the schedule that has been given, that is one indication. Also, if prevention, to prevent the allergic march from allergic rhinitis to asthma, it is a very important indication. Immunotherapy is known to prevent the allergic march. And lastly, it has been seen, even though we consider immunotherapy is very expensive, but it has been seen in long term, rather than taking expensive medications on and off continuously, immunotherapy is seen to be almost 3 to 4 times less expensive than long-term use of expensive medications. So even to cut the cost. So these are some of the indications where immunotherapy is of benefit.
Okay, Dr. Reddy, what are allergoids and why are they better than other extracts?
Allergoids, they are hypoallergic extract, madam. They have less side effect, more safer, so they are more effective.
Okay, so Dr. Pavan, what is standardization?
Yeah, this is most favorite of our beloved teacher, Dr. Major Nagaraju sir. Yeah, the standardization of allergen extracts is very, very essential in order to control the variability. And we all know that allergens are the molecules with the capacity to elicit IgE responses in humans, right? So when stimulated with allergens, most allergic patients respond with the production of IgE specific for several proteins or allergens in the source material. So that's why standardization is very important to achieve the consistency and reproducibility in the clinical setting. And we all know that the IgE binding capacity of an allergen extract is related to the content of one or more major allergens. It is also important that standardization procedure ensures consistency not only in the overall IgE binding potency, but also in the content and ratio of the individual major allergens. That is very important. Otherwise, we'll elicit a lot of reaction. So standardization is the norm. I think we see in the routine practice, a lot of errors, a lot of reactions also sometimes happen because of not using standardized allergens.
Okay, so in short, standardization means the two extracts, they don't have batch to batch variability.
Correct, very true.
And the results are reproducible whenever you test.
Right, Swati,
okay.
Right. Yeah.
So with this is the photograph of the child actually who presented, and we gave a skit, and this is how he has grown up in last 2.5 years. So with these, thank you all the panelists for joining and giving us such a good session. And with this, we rest our cases. Thank you so much.
Thank you, Dr.
Swati. Thank you so much.
Very
Thank you
well
so much,
conducted.
dear
Thank you.
panelists.
Thank you.
Thank you, Pradyum sir, for that. You have that flavor, nice flavor to the discussion. Thank you so much, Pradyum sir.
Thank you so much for those.
Thank you.
Thank you so much. Swati, will you stop sharing?
Yeah, I'll do.
Yeah. So now I invite Dr. Saibal Moitra. Sir is going to talk on looking beyond IgE in allergy pathology. Dr. Saibal Moitra. Sir, are you there? Yes, sir. Thank you, sir. So, sir is going to speak on looking beyond IgE in allergy pathology. Dr. Saibal Moitra is an adjunct professor and senior consultant in the Division of Allergy and Immunology, Department of Respiratory Medicine, Apollo Hospitals, Kolkata. Over to you, sir. Sir, unmute yourself, sir.
Saibal, are you able to hear us?
Yes, sir. Yes, sir.
Okay.
Yes, sir.
Saibal, sir, please come on video.
Saibal?
Sir, unmute. Sir, 1 second, sir. Saibal, sir, 1 second. Azhar, make sir. Sir, please raise your hand, sir. Azhar, please make sir co-host. Sir, you can unmute, sir, now. Saibal, sir.
Yes. Okay, thank you. Can you see my screen?
Yes, sir, it's clear, sir.
Okay, thank you so much. Okay, good morning, everyone. First of all, I would like to thank the organizers for allowing me to present this talk in this national conference of Icaaicon 2020 and 2021. So my talk is basically to take up or relook the entire what we call allergy pathology. And before I say anything, I would like to pay my regards to the Icaaicon, who in 1966, after discovering the IgE, they have revolutionized of how we know what is allergy, what are the pathways, and how the things happen inside our body in allergic reaction. But there's a flip side to it. The flip side is that we have been made to think in a very straitjacketed manner. So that means whenever we talk of allergy, we say IgE, we say allergy. Almost both of them becoming synonymous with each other. So there has been major emphasis on the IgE, which has led on to lots of difficulties in diagnosing many of the diseases and also misuse of the test on total IgE or the other IgE, specific IgEs. So that's why we need to rethink, relook the entire matter. And at the last, I would like to go back to what one of the best as physician scientist, that is Dr. Clement von Pirquet of Austria, more than 100 years ago, what he said about allergy and how we have shifted from his concept of allergy to what we know or how we see allergy in today's time. So the talk is on looking beyond IgE in allergy pathology. So first of all, let us just look into this schematic slide, which we all have seen numerous number of times. That is, the allergen comes in contact with the body, and there is a sensitization phase, and through the antigen presenting cells, the T cells, then the B cells, then all various cytokines, and production of the IgE goes on to the mast cells, leading on to degranulation of the mast cells and the signs and symptoms which we see in case of the allergic inflammation. But the important thing is that the biological message, which is actually carried from the allergen to the major effector cell, that is the mast cell, this is the main complex area. And it has been to a great extent simplified by the Icaaicons once they have come out with one of the major pathways, that is the involvement of the IgE. So there are numerous cells, numerous cytokines, and numerous other molecules which is involved in carrying this as message from the allergen to the mast cells. And we delineate only one of them, and we talk so much about that. So we need to have a holistic look about this entire process. This is the main complicated pathway where we need to concentrate in my lecture. So what is allergy? We know that the defined definition of allergy is a group of IgE-mediated diseases. However, a large proportion of patients with the clinical manifestations of allergies do not exhibit elevated levels of the serum IgE. This is data from the allergy department of Beijing Union Hospital, published a few years back. It said that 60% of patients with clinical manifestations of allergy do not have elevated serum IgE levels. So it is actually the degranulation of the mast cells and the basophils, which is the definitive event in the allergy. Whereas IgE only serves as one of the key messengers which takes this message from the allergen to the effector cells. So the IgE-mediated diseases are a subgroup of the allergic diseases. So when we talk of allergy, it should be more prudent to say that the allergic diseases are mast cells and basophils mediated inflammatory processes, which may be IgE independent, IgE dependent, which could be other immunoglobulin dependent, like the IgG, which could be non-immunoglobulin dependent. That means direct stimulation, activation, and degranulation of the mast cells by the toll-like receptors or low molecular weight molecules, or it could be a mixture of any of the above three pathways. So this is how it goes. So first is the cause, that is the allergen. Then it has to be combined with, patient has to be carried on by some messengers. Those messengers could be IgG, could be IgE, it could be complements, it could be various other cytokines, which then goes on, acts on the primary effector cells, that is the mast cells and the basophils. And there is also the participation of the secondary effector cells, which are the eosinophils and the neutrophils. So, and this constitutes the allergic reaction or allergic inflammation. So this, as I've stated, this IgE merely serves as one of the messengers to carry the message from the allergen to the mast cells, though there are other players into it, which we quite conveniently or maybe ignorantly overlook. So this is the mast cell. Now, so mast cell being the main primary effector cells of the allergy, our concentration should be focused more on these cells, and they respond to the allergen by an immunoglobulin dependent pathway or an independent pathway. And the degranulation of the mast cells is the definitive event in the allergy, which actually brings about the typical signs and symptoms. If we look into the mast cell receptors, the repertoire of huge number of receptors in the mast cells. And you will find that the mast cells are always in the interface of our body and the environment. That means it is in the GI tract, in the respiratory tract, the nasobronchial tract, in the skin. So that means this mast cells, actually it is in the interface where the body comes in contact with the environment. So it modulates the entire immune mechanisms or the pathways when it comes in contact with the one or the other allergens from the environment. And these mast cells are also in closely, they are situated to the these vessels and the other cells which are there in the actually the submucosa or the mucosal region. So if you just look that there is not only the high affinity IgE receptors, which we talk of so much, but there are also these IgG receptors, there's the complement receptors, there are the sphingosine 1-phosphate receptors, the other cysteine leukotriene receptors and interleukins and many other receptors which are there in the surface. Apart from that, there are intracellular receptors also, like in the endosomes and the nuclear receptors. So all these receptors is actually, they are taking the messages from the outside and then they are translating it in the various ways by reacting to it. So this is very important to understand. We should not be concentrating only on these high affinity Ig receptors, but also we should understand that there are other factors which can cause the mast cell degranulation. So they are actually activated not only by the allergen, which is going and joining with the mast cell high affinity Ig receptor bound IgE, causing the cross-linking, but there is this the immunoglobulin G and its receptors, which is now known, it could be high affinity receptors, it could be low affinity receptors, which is also now known to play an important role in some of the allergies. Apart from that, we have the low molecular weight molecules. I'll be talking about that. We have the protease allergens, we have the complement, and that is the breakdown products of the complement, which are also called the anaphylatoxins, C3A, C5A, and their receptors. We have adenosine, we have cytokines, and also the bacterial or viral products, which is not involved in allergy, but in the other immune effector mechanisms. So if we talk about some other messengers, first comes in our mind is the IgG. So now known that IgG1 and IgG3, they're capable of activating both mast cells and basophils. And the high affinity Ig receptor is not only able to degranulate the mast cells, but it also causes activation-induced proliferation of the mast cells, as we see in case of the high affinity IgE receptors. And the low affinity Ig receptor, like the Fc gamma R2b or Fc gamma R3, they are involved in some of the allergic pathways. And interleukin 4 causes increase in the expression of the Fc gamma R3, which is also involved in the increased expression of your high affinity Ig receptors. Moreover, IgG and allergen complex can activate the complement and produce a C3A and C3 and C5A, which acts by the receptors to degranulate the mast cells. So if you see this list is a huge number of messengers, but only see the IgG1 and IgG3, which are also produced by the B cells upon activation and adequate signaling from the T cells, which can go and degranulate the mast cells. Apart from that, there are other cytokines and which is involved in mast cell degranulation. Next, we talk about the low molecular molecules. What are they? These low molecular weight molecules, now we are coming to understand more and more of their numbers, they cause direct activation of the mast cells. They could be receptor mediated or they could be non-receptor mediated also. And they don't produce the antibodies. Of them, important is heparin, sphingosine 1-phosphate, the iodinated contrast medias, the complement components, and various other pollutants like the diesel exhaust particles, the sodium sulfides, the ground level ozones. So these things can directly stimulate, activate, degranulate the mast cells and bring about the typical allergenic responses. Of these molecules, they could be of somewhat larger molecular weight of more than 10 kilodaltons, and some could be lower molecular weight, which initially we used to call a hapten, and we used to say that the hapten has to, they combine with a larger protein allergen with an hapten combination of larger protein to actually degranulate the mast cell, which is not the case as we know now, because they can also directly cause the mast cell degranulation. Now we talk next with the proteases and the protease activation receptors. Now these proteases, first of all, if we talk about what we very commonly say about these dermatophagoid steroidecinus as their allergens, major allergens, the cockroach allergens, they are basically proteases. Of this, the DRP1, DRP3, DRP4, DRP6, and all these are the various proteases. Now, before we say that this protease, this allergen can elicit an IgE-mediated response and cause an IgE-mediated degranulation of the mast cells. But these proteases can also cause the direct degranulation of the mast cells by actually acting through the protease activation receptors. And this was an article published quite long by 1999, where they showed that these protease allergens, they can breach the epithelial barrier directly, and they can reach the subepithelial mast cells and activate and degranulate them. So these are the various protease activated receptors that we all know. And of this, now the most interest is on the protease activated receptor 2, PAR2, through which the various cockroach allergens and the various of the house dust mite allergen can directly degranulate the mast cells. So this direct degranulation of the mast cells by the protease activated receptors and its ligands as the proteases, it leads on release of multitude of the products. As we all know, that the mast cells, actually interesting thing is that whatever be the signal, the mast cells, when it degranulate, it is called a compound exocytosis. That means they release all the products which is there inside. They do not do by the some receptors, some messengers will release some will release others, not like that. So whatever may be the mechanism, actually the final pathway remains the same when it comes down to the mast cells. Now the toll-like receptors, though we knew that toll-like receptors are an important component of the innate immune system, but the mast cells express numerous phenotypes of the toll-like receptors. TLR2, TLR3, TLR4, they can all initiate or amplify the allergic reactions to the mast cells. Others include the cytokines like 3, 8, 18, 1 beta, which has through their wider receptors degranulate the mast cells. Then adenosine, which acts by the G protein coupled adenosine receptors. We have the adenosine receptor, 4 types of receptors through which they can degranulate the mast cells. And nowadays, we are gaining more and more interest on the mass G protein coupled receptors, as like the MRGPRX2, and many drugs like this fluoroquinolones, this codeine, they act directly through this MRGPRX2 in the mast cell and cause its degranulation, and they do not need any antibody dependent pathway to degranulate the mast cells. So that means if we do a skin prick test with fluoroquinolones, you might get a false positive because they can directly degranulate the tissue skin residing the mast cells by acting via the MRGPRX2. So this was about the mast cells, but there is also one small new knowledge is coming up. We knew that there's the crosstalk between the antigen presenting cells and the T cells causes a differentiation of the T cells into a T helper cells. This T helper phenotype, the Th2 phenotype, by release of the Th2 cytokines, namely 4, 5, and 13, causes the B cells to produce as IgE class switching in the B cells, and then it further goes on to attach to the mast receptors. But one of the important point is over here, where this crosstalk is also decides at what T cell phenotype it can happen, even in case of the allergic reactions. So though this high affinity Ig receptor containing dendritic cells, it skews the Th2 phenotype of the T cell, but there are some other dendritic cells, like the myeloid dendritic cells and interleukin 6 can cause the Th17 skewing. We know that Th17 cells plays an important role in some phenotypes of the severe asthma, where there is neutrophilic inflammation in the airways. And also Th17 cells is known to cause an important part in various other allergic reactions also, and its role is coming up. So now we have this Th17, Th2 balance of both acting in concert with each other to bring about the typical signs and symptoms in allergy. Apart from that, the CD1A plus dendritic cells causes local T cell proliferation, mostly of the Th17 or Th2 or other T cell phenotype in nasal mucosa and systemic allergic, in seasonal allergic rhinitis. So now if we talk about the allergy, basically we can move on from the IgE mediated mechanism to mainly a mast cell centered mechanistic pathway, where in the induction phase, there is basically the production of the progenitor mast cells and the various other signaling in the transmembrane migration of these mast cells through the interleukin 6, interleukin 3 stem cell factors, or this tissue migration of the mast cells. So they go and accumulate in that particular site of the allergen exposure. It's not IgE mediated. It could be various other signaling molecules involved in it. And then in the effector phase, there is the mast cell degranulation, which can occur by the mast cell itself through an autocrine manner or through a paracrine manner, and by the action of the various other multitude of the signaling molecules. We have just talked of the few in my previous few slides, and they causes this mast cell degranulation and leading and causing the release of all the molecules. We have the 3 main subclasses of the molecules which are released, and they brings about the typical allergic reaction and the accumulation of the secondary effector cells. And this is also amplification mechanism, both by the self-autocrine and the paracrine manner. This is what we see in the allergy. So allergy, basically, when we talk about, it is not only a skewed IgE-mediated pathway, though albeit it is one of the major pathway of the mast cell activation and degranulation, but there are other pathways also. So it is mainly a mast cell migration and accumulation and degranulation, by which we can just have a relook of how we see the allergic pathway. So I just end my talk by paying my regards to Dr. Clemens von Pirquet. Actually, what Dr. Clemens von Pirquet had conceptualized about allergy 100 years back, that is, that he said that allergy is basically an altered response of the body to any foreign material. It could be beneficial, which is he called the immunity or prophylactic thing. It could be harmful, which at that time they called antiphylactic, and they named it hypersensitivity, though at that time supersensitivity was the term which was more common. So in an overall, what we have shifted now is that then over a period of years, then only the hypersensitivity part has to be looked upon as allergy and allergic disorder. So that was not the case which he conceptualized around more than 100 years back. And now we have shifted more, and we become more tubular vision. That means we started thinking about only IgE. So that is how we are actually narrowing our vision and of the allergy and allergic diseases. My talk is only about to reopen ourselves, rewind ourselves, and to go back to what Dr. von Pirquet had stated in his initial time, when he came out with this allergy. And now we know in the 21st century, this epidemic of 21st century is the allergic disorder. Thank you so much.
Thank you, sir. Excellent presentation.
Yes.
So now I invite Dr. VK Jain sir, Vikram Kumar Jain sir, to talk on allergen avoidance in allergic disease, the most awaited topic. Sir, will you please share your screen, sir?
Yes,
VK Jain sir.
Yes. I am audible?
Yes, sir. Yes.
I am audible. Okay, thank you. I am now putting my slides. Just wait for a moment.
Thank you, Saibal, for new insight.
You can include me, or I may display my
share your slide, Dr. Jain. Share kijiye.
Yes, sir. We are able to see your yes. It started.
So before that I start, I am very much thankful to the college executives who have, and also the organ in Hyderabad, everybody they have invited me and given me the opportunity to speak on this such a important topics of allergen avoidance, which is very, very important, and I will give the evidence-based information.
Your slides are not visible, Dr. Jain.
Yes, sir. I'm putting the slides.
चलो रद्द देख लेंगे जहाँ है ऐसे रखा इस लेक्चर के बाद 10-15 मिनट Is there any problem, Dr. Jain?
स्लाइड पहले कनेक्ट करने से पहले स्लाइड प्रोजेक्ट करनी होती है।
डॉक्टर जैन, उसे आप डेस्कटॉप पे खोल लीजिए।
हाँ, डेस्कटॉप खोला हुआ है,
दिख नहीं रहा ना ये
किसी
आपका
को बुला
डेस्कटॉप
लो
खुला हुआ।
बच्चों को।
Now
हाँ
आ गया
ठीक है, फुल स्क्रीन कर दो बस।
अब इसको फुल, इसको डिस्प्ले में चले जाओ डॉक्टर जन, नीचे बॉटम में राइट, बॉटम राइट पे स्लाइड्स डिस्प्ले का है साइन, उसको क्लिक कर दो, बॉटम राइट। एक स्लाइड सॉर्टर है, दूसरा स्लाइड डिस्प्ले है।
Sir, make it full screen, sir. Yes, sir. Yes, sir.
नीचे जाइए, कर्सर नीचे ले जाइए,
जो वाइन ग्लास टाइप का बना हुआ उस पर क्लिक करो।
यही यही अभी जो है आया था, नीचे नीचे।
हाँ बस,
हाँ यहाँ
लास्ट वाला,
नेक्स्ट नेक्स्ट, हाँ ये वाला कर दीजिए,
इसके बाद
क्लिक कर दीजिए।
हाँ ये
अभी नहीं, आपने स्लाइड सॉर्टर को क्लिक कर दिया,
आगे आगे आगे,
अभी तो नहीं आया,
Point is,
अब आ गया, ठीक है।
Thank you, sir. Thank you, sir. Let me introduce, sir. Let me introduce Dr. V.K. Jain, sir, who is a professor emeritus of respiratory medicine. He is a MG Medical College, Jaipur. He has many awards to his credit and as an author for many chapters in books, sir. He is a fellow of WHO Fellowship in 1990, and he is a past president of NCCP, Icaaicon 2001-2002. And he's a teaching experience of UG 40 years, PG experience of 40 years. He's a professor since 30 years and HOD since 35 years. We are very fortunate to have you on board, sir. So, sir will be speaking on the allergen avoidance in allergic diseases, the much awaited topic. Over to you, V.K. Jain, sir.
Thank you, sir, for giving me this opportunity and introducing me in so great. And thank you. I will be talking on such a very important topic of clinical use in the clinical practice by the physician. Allergen avoidance in allergic diseases. I am from Mahatma Gandhi Medical College as an emeritus professor, and it is a private medical college. Generally, these are the questions asked by the patients, by the physician also, and discussion that can we really avoid allergens? Is it too simple or is it really feasible? We should share on that ground whether the proven allergen measures exist, whether knowledge and facilities for selecting patient for allergen avoidance measures are existing, whether such measures are practicable by selected patient who likely to get the benefits. As we know, allergy and its diseases are very common in clinical practice, affects millions of persons globally and hefty economic loss, and already said 15 to 20% population is having major allergic disorder, but that is more common in children and young adults. The prevalence and incidence is variable place to place, racial, gender, and geographically, genetically determined and environmentally triggered. The allergic disease and allergy can be predictable and preventable. Allergen avoidance measures are challenging, but still you can use it in clinical practice. The definition, I think yesterday as well defined by Dr. A.B. Singh, the allergens are bioparticles. They are antigen causing allergic and diseases and allergy. They are mainly of protein in nature, but sometimes they may be of carbohydrates. The common culprits are pollen, molds, insects, and mites and foods. If present in the environment, these bioparticles, we call it the aeroallergens. What is the overall treatment of allergic diseases? We all know patient education is far most important, pharmacotherapy, immunotherapy, and more than that, where I will be giving the information on the allergen avoidance. Now, this is a very important paper which has recently updated in 2018 on a NIH workshop in USA. And this has been further reviewed for multiple studies and saying that it is very difficult to find out real number of culprits in the patient. Even by the SPT, we are doing for few tests, but we cannot get. Even if it is known, it is not difficult. It's very unusual to really reduce the exposure those triggers. And lastly, even it is known the patient is many times not willing to perform the necessary This is the first article published in 2000 and the British Medical Bulletin showing the early use in the 16th century use of allergen avoidance to the various that I will give you. Now this is the highlight which I have already given. These are the questions which I have put initially in the first slide. And some of the very important articles published, the home environment intervention for prevention and control of allergy and allergic reason, and what is the reality. I'll not go, whatever I am speaking on the basis of multiple studies, paper published. Now, allergen avoidance, if I go for the historical background, in the 16th century, evidence of allergen avoidance for the treatment of allergic disorders reported when Italian physician Cardinal advised to Archbishop St. Louis, Scotland, to avoid feather wedding and responded miraculously for asthma. Leopold in 1925 in last century treated asthma by environmental manipulation by keeping patients of allergic disorder and asthma in dust-free room. Another evidence available in 1927 in Netherlands kept patient in dust-free climate chamber rather than keeping the patient at home, and there was a significant improvement in the symptom of the patient. Allergen avoidance, allergy and disease are mainly developed because of exposure of both outdoor and indoor allergen, and they are being triggered by various environmental occupational irritants also that include the ETS and various gases, chemical gases. Before recommending allergen avoidance, we should know a specific allergen causing the disease. Otherwise, it will be difficult to give the advice to allergen, and that can be achieved by means of SPT or by means of ELISA test. Complete avoidance of environmental allergen is due to ubiquitous presence of the allergen in the nature. Allergen avoidance is the foremost step application at all level of prevention, that is primary, secondary, and tertiary, for the development of sensitization and disease. Specific airborne allergen control is widely recommended as a holistic approach for prevention of sensitization, development of disease, and even those who are having disease, we can further reduce the severity of the symptoms of the disease. Now, the National Asthma Education Program, it has been recommended that the one allergen avoidance can be recommended in asthma with known allergen sensitivity. The overall approach to allergen avoidance is first we have to find out the positive organ. Then you have to give the total detailed education to the patients regarding the allergen source and what are the different sources, and then you have to, after knowing, really advise the allergen avoidance to the patients or even to the relatives. So education of the patient is very important about the allergens, and then the culprit has to be simple slide. Basically, in the development of allergic, there are three phases. The person who are atopic, repeated exposure, especially in the early childhood, sensitization one stage, development of the disease, either rhinitis or asthma, and lastly, then symptomatic presentation of disease. These are the three important steps. And then every step, we really need the allergen avoidance. At this, to prevent the sensitization, I'll go in detail in the next slide. This is one of the beautiful articles came in the role of avoidance of environmental allergen and other irritants published in 2004 by WHO and BAO. Now here I not talk the irritants, I will only talk the evidence-based guideline recommendation. Reduce exposure to inhalant allergen in young children at high risk of house dust mite, cockroaches, and fern and pets. B evidence. So this is real, and there is a B evidence. Secondary prevention. So we can prevent the sensitization in the atopic individual. This, for not to develop the by reduce the exposure of the various important allergen in the indoor environment. The secondary prevention, which actually basically is the prevent allergic diseases in the person who are already sensitized individual. That is again very much needed in the early age in young children already sensitized to SDM, PATS, cockroaches, etc. The specific exposure should be reduced or abolished to prevent onset of allergic disease. So this is whom we can prevent those who are already sensitized in the early age. If we reduce those culprits after knowing the really, we can definitely prevent the development of diseases. That is a B evidence. Now tertiary prevention, who are already having disease patients, they are symptomatic. Now by either they are having rhinitis, asthma or other allergic diseases, by knowing the culprits, and if we really avoid those culprits, really we can definitely reduce the symptom severity, and even we can also reduce the severity of exacerbation of those symptoms, and that is a evidence. Then even the bed covers which are used as a barrier are also useful for allergic patients who are sensitive to mites. So what are the different strategy or measures which we can by which we can control the environment, and that is maybe what we needed is the control of outdoor environment or the indoor environment. This is only recommended when we know the really culprits of the outdoor as well as the indoor or both. So how to control the outdoor environment? Complete avoidance of outdoor allergen or irritants is impossible. However, because outdoor environment control is very, very difficult, but however, to some extent, we really can minimize by following measures. Avoid exposure of the allergens, avoid exposure to irritant, staying more in the indoor, who are having, especially during midday and the afternoon, use nasal filter or mask for reducing the entering of the allergen into the nose, or if we can also use changing workplace or occupation. If the person is in the history of the increased symptom at the workplace, even we can change the. How to control the indoor environment? The shifting of patient to dust-free indoor is the ideal one. But I think it is very, very difficult to give it because not cost effective. It is really very effective, no doubt, but practically inconvenient to give this advice. It may be very expensive, adapted whenever possible while dust busting is completed around. Again, it is like Diwali. See, if you are cleaning the house, I think it is the best time to ask the patient to avoid to this. At least for temporary time, he can may avoid the indoor environment. Now, indoor environment control can be avoid exposure of different the allergens which are available, especially SDM and dander, molds and pests. We have to maintain the humidity that has to be below 50%. Ideally, is 35 to 50%. Clean indoor environment, that is bed, mattresses, carpet, curtain, furniture, bathroom, kitchen, basement. Many patients now we are getting only because of the Diwali occasion, and then they are coming only while they are cleaning, their symptoms are increasing. They are coming to many clinical practitioners and also to me. Then control of house dust mite is very important, and how to proceed it. So now what are the specific allergen avoidance? As the pollens are mainly present in the outdoor, but sometimes they may also present indoor if the windows are open. It can be carried out by the patient himself in the house while on through their dress, or provide what this can be avoided by providing various mechanical barriers to avoid pollen contact. Keep windows closed at peak pollen hours in evening when airborne pollen descends to lower altitude. Wear glasses or sunglasses to prevent pollen and entry. Masks. Wear mask over nose and mouth. Wash hair and clothes at night to avoid falling to bed. Avoid cutting grasses. Use air conditioning, but it is effective in not possible always. But I think it is, if it is possible, then can recommend it. Install pollen filter, if it is possible, to the nose by putting an enforcing measure. That can be the filter, and can be various type of the cream which is also available in the market and other products. These are white Vaseline, we can put it because the large number of allergens will be stick on it. Pollen blocker creams are also available, micro emulsion, live lipid based ointment, sea water gel, liposomal formulation. These things are recently a methyl cellulose liposomal formulation is available in the market, and the studies are saying they are also effective. Now, this is the one of the paper on the methyl cellulose, a significant. This has been published in the International Archives of Allergy in 2014, that it is showing that by applying the methyl cellulose in the nose, a significant improvement in symptom score of rhinitis, including eye and lower airway symptoms, by putting on it. Another paper on this related, which is also published in 2003 in Pediatric Allergy Immunology, also showing some effective role. Educating a patient about dust mite allergen is again very important. Where they are present, what is the real size, they are small and so. If you educate the patient, really patient can understand how they do, what is the maximum humidity. So more than 55% humidity will increase the growth of the. So that you should give the education about the source of the culprit. And if you will give the time to the patient, probably they will be very happy to understand and also will follow in the for the. Now this is one of the paper of the allergen immunotherapy practice guideline, where the role of the allergen avoidance has also been considered, and this is one of the important paper published by Cox, which is one of the important on immunotherapy. The SDM allergen, other how to control the dust mite. Again, it is it's a art. It is a scientific art. SDM exposure is much in batting than elsewhere, and also, and it can be used by placing the barrier. Different type of barriers are available, and to decrease the release of the mites while the patient is sleeping in the night. Encasing mattress and closed by airtight plastic cover. Very simple. Expensive microfiber fabric covers are also available. Electric blankets on beds, they are costly also. They are also useful, especially to make the mite dry. There are different basic types of allergen encasing barrier. I'll not go in detail because there are different type of barriers: vinyl form, laminates form, non-bovine microfiber form, and bovine microfiber fabric. I think bovine microfiber fabrics are very important, quite effective, comfortable, but very, very expensive. Non-bovine are not that much effective, and laminated and vinyl, they are not also much effective, not much more. They are uncomfortable. They are effective, but they are uncomfortable by using in the night. This is, I'll not go bovine microfabric, which are very costly, but they are ideal, and the studies have been proven that by using significant reduction of symptom and medication score. One of the study published in 2006 and reporting and they have a placebo control use of allergo covers and the placebo, and they find the significant improvement by putting these type of encasing barrier, and there was definitely 46% reduction in symptoms and medication. We can also kill and we can also remove the mites from the house by recurrent regular washing of beds and floor in hot water that has to be more than 60 degrees by weekly. We can use the ascaricides. We can remove dead mites by vacuum cleaner. We can also remove airborne mites by HEPA filter. We can also use, they are also effective either by removing it or to killing these mites. Make environment less suitable to mites. Now, how we can, even if you cannot remove, if you cannot make the mites to die, we can also make the make environmental less suitable to mites, so there will not be much growing of these. So avoid lying things on upholstered furniture, remove carpets and dust collector laid on concrete. So those patients who are having indoor allergy, I think the keeping carpets are not necessary. We can remove it. The humidity has to be removed. It has to be below 50%, and we should also have a air conditioning or even the mechanical ventilation. Regular vacuuming is important, especially to remove the food and shelters and other dead particles of different indoor allergens. Now, recommendation of the how to measure the HDM and how to control this environmental control of the HDM. Now, one can use the ascaricide by applicant in cumbersome. It is very cumbersome. Using regular ascaricide is also I mean, sometimes dangerous to the healthy person. So a cumbersome, and it is affecting humidity component. It has to be if you want to control the humidity, it has to be sustained for a long time. But I think maintaining it is very difficult. Air filter, major SDM allergens are carried on larger particles quickly settle after disturbance of reservoir. Therefore, they are not effective. So air filters are not very much effective in removing to the might remove carpets and soft toys is again very expensive, and there is not a clear-cut evidence recommendation. Allergen impermeable and casing first line approach to reduce dust mite allergen exposure along washing, wetting, and hot is also is effective. Now, in future, in near perceptives, how in regarding the SDM avoidance, recently laminar airflow system is available with a special filter during night in severe uncontrolled allergic symptom. The RTGs appear in recently in thorax in 2012, and then temperature control laminar airflow system in moderate to severe uncontrolled allergic asthma, which definitely reduces exacerbation, severity of symptoms, and also visit if we can control the temperature through the laminar flow, or you can use the laminar flow with a special filter. Probably we may get this is the future hope to then how we can remove and the how we can give the education to the cockroach culprit and their source and avoidance. We know the sources. Cockroach allergen education is important to patients and the relatives. Cockroach allergen found in saliva, fecal material, secretion, cast skin, and debris. Particles are large and settle quickly to the ground. Allergens commonly found in dense population areas. Level of allergen found in the kitchen. The basic objective is to remove or to kill the cockroaches, eradicate cockroaches with appropriate insecticides, seal cracks in floors and ceiling, remove source of food, control dampness, scrub floor regularly with bath water and detergents, regular wedding, dusting, washing of curtains and clothes are required. Then ultimately mold allergen education for source of avoidance. That I mean the pet allergen avoidance, how we can objective is just to reduce or remove the pets allergen from in the indoor environment, remove or find another home for pet, not bring new animals in the home, exclude pets from bedroom if possible, keep outdoors if not possible to avoid and remove, wash pet twice. I think in the Western country it is very difficult to remove or not to come in contact with these pet animals. So at least we cannot remove, at least the wash pet. So they should be regularly washed twice in a week. Install a HEPA air cleaner in living or bedroom. Clean carpet and mattress and other things. As I have already seen, probably we can reduce to some extent. Education. So education source is very important, and that regarding to the mold allergen, how again we have to give the education about the different type of molds available in the indoor environment, and we have to give the teaching because they are generally present in the dirty toilets, bathrooms, even sometimes in the kitchen also. They are the rich source of the allergic development of the increased symptoms if they are being exposed. So they may be present not only in the house, but they may be present in the various industries and where the person is working. So cleaning of these molds is very, very important. And that is why again all the things are required, the maintain humidity, so the fungi will not grow. Lastly, the ensure proper heating and the ventilation, air conditioning, using exhaust and open windows, and then use of 5% ammonia to remove molds from the bathroom and surfaces, remove carpets and wallpapers, wear masks during house cleaning, and we remove what. Because of this, now we are during the COVID period, people are using even in the indoor and outdoor also. And I think there is also decrease in number of patients in our clinical practice. But this season is also very high. But now our observation is that we are definitely declining patient in our clinical practice. Probably this could be distancing in the large population using the mask, and both even in the during the working hour in the or they are cleaning in the house, or they are also when going outside. The high altitudes again very important. Various studies suggest presence of low level of allergens at high altitude with development of low rate of sensitization and less allergic diseases. So sometimes high altitude studies also provide a proof that substantial reduction of allergen exposure over a long period may result in better clinical improvement and allergic asthma. So at high altitude, there is a decreased amount of allergens, and probably one can recommend, and we can shift temporarily to these patients at high altitude, especially during the season. And the article very much appear in the British Medical Bulletin. Allergen avoidance, adherence to the allergen avoidance is very important. Adherence part is very, very important, and which is lacking. Allergen avoidance is recommended by US and international treatment guidelines. Regular patient advice, counseling by physician, in spite of best advice and counseling, and also educating about the culprits. Environmental avoidance adherence is still very, very poor. Only 40%, as reported by various studies published in the journal. Patients often reported that they are adherent to home inspection, shows much less. To improve the adherence to allergen avoidance, more concentrated education is required with good partnership with the patients and the physician. And this is a summary. Now, allergen proof is useful for HDM and mold. Dehumidification is useful for HDM. Professional extermination is useful. Cockroach cleaning of walls and floor is needed in all types of indoor pets. HEPA filters are used better useful for pets and more. These are the things I'll not. So the important. I'll not go. I'll take 1 or 2 minutes only. I'm going to finish. Now these are the important papers, and I think they are saying the review of various articles on based on meta-analysis and systems support the efficacy of object of controversy and needs larger study. However, control to specific airborne allergen is still widely recommended as a holistic approach. We cannot say we have to advise. However, there is not a definite systemic and the meta-analysis based evidence. They are 100% effective. But however, one has as a holistic approach. We have to advise all these things, which is recently published paper. So the avoidance is the holistic approach to prevent development of allergic sensitization, BHR, development of disease, and also reduce the severity of symptoms and reduce the exacerbation. Complete allergen avoidance is practically not possible. Wide spectrum measures are required to remove, reduce the allergens and retain specific, which I have described, measures are defined with evidence-based, is still subject of controversy and is still required more research. Adherence is the important part. and it is still very poor. Education is very also poor, and that has to be encouraged. And the recently published on the article, very important, the health and medicine, that how house must encourage biology and evidence. So whatever I've said, it is only evidence based, and it is very important part that every clinician should have in mind and should practice as much as possible. Thank you very much for hearing my talk patiently, though I am not hearing the voice of the participant. Thank you very, very much. And I'm sorry for taking 2 minutes extra. Sorry. Thank you very much. Any questions?
Thank you, sir.
Welcome.
Thank you, Jen, sir. The excellent presentation, sir. Allergen avoidance is very much necessary, sir. Need of the hour. Every patient has to advise allergen avoidance. Thank you, sir. Next, to go on to next talk, sir. Distinguish between allergen and irritants by Dr. Parul, sir. Parul, sir. Yeah.
A very good morning to all the stalwarts of allergy here. I'm highly thankful to be present here. I thank you all for giving me this opportunity. Am I audible, sir?
Yeah, audible. Full screen. Make it full screen.
Yes, sir.
Thank you. Audible.
इसको डिस्प्ले मोड में डालो पारुल. बेस में जाओ, राइट साइड में, बेस में.
Yeah, you're right. Right.
आ गया. चलो, ठीक हो गया.
My talk today is basically to distinguish between irritant and allergens. This will take us to the very basics of allergy. We'll be discussing this irritant and allergen in terms of definition, citing certain examples, the pathophysiology, and the diagnosis. So, what is an irritant? Irritants are usually non-living substances or ingredients such as diesel, smoke, cold, chemicals, etc., which cause irritation by their physical property or worsen the underlying allergy. Well-known examples here would be soaps, detergents, acids, solvents, wood dust, welding fume. Even water can be regarded as a weak irritant. Prolonged and frequent exposure to water can lead to contact dermatitis, eczema. Then there are thousands and thousands of irritants that are known. Irritants can affect our skin, our airways, our eyes. Here are certain examples of the professions that are associated with irritants that can lead to development of irritation to the skin, like the hairdressers. They are in contact with the various coloring agents. The cleaners that are in contact with the cleaning agents. Then the nurses in contact with the disinfectants, cleaning agents. Then we have metal workers which use metal splints, cutting fluids. Then the other professions like the painters that are exposed to the isocyanates. Similarly, the car repair workers are also exposed to the isocyanates. Coming to allergen, what is an allergen? An allergen is a living, usually a protein molecule such as food, dust mites, pollen, fungi, etc., which cause allergy in the body by series of reactions which are usually IgE mediated. Allergens are usually thought to be relatively small proteins or glycoproteins. They belong to relatively smaller number of protein families, and specific properties to interact with the innate and the adaptive immune system allow to explain the allergenicity to several allergens. Examples of allergens would be pollen, mites, moths, pet dander. Allergens are classified as inhalant allergens, ingestants, and insect venoms and others. These are basically the injectants and the contactants. Bee, wasp, fire ants come into injectants. The latex drugs can be contactants. Under inhalants, we have house dust mite, pollens, molds, danders. For ingestants, it is usually the food allergy, the seafood, milk, egg, and the other dietary products. Plants and pollens. Plants and pollens, as we all know, basically pollens is produced by the plants during the flowering periods. Pollens can be of various types like entomophilic, anemophilic, and amphiphilic. The entomophilic are the pollens that are carried by insects, and the anemophil are the ones that are carried by the wind. Usually the anemophilic ones are responsible for these are small and are responsible for allergy, as they are easily carried away to the upper airways and can enter the upper airways. The plant producing the pollen can further be divided into grasses, weeds, and trees. the mites. Mites are tiny animals. We all know they feed off the shed human skin and other appetizing little morsels. Their exoskeleton and gut contains the major allergens. Mites best grow on high humidity, as has already been discussed in the various lectures. Coming to the animals, now pet allergy is also very common. Usually pet allergy is seen to cats and dogs. However, rats, mice, guinea pigs, hamsters, pet birds, horses, cow or poultry can also be involved. Allergens from cats and dogs are found in skin cells, the shed, dander, on hair and in saliva. Molds can be indoors, they can be outdoors. Molds are basically fungi that grow in units called mycelium and reproduce through the formation of spores. They are ubiquitous in biosphere and a common component of household and workspace. They basically need certain conditions to grow, that is hot and humid temperatures. So they are grown in the damp places like the damp bathrooms, damp basements. Even the humidifiers can be contaminated by molds. These are certain examples of the molds. Now, how do we differentiate between an allergen and irritant? Up to now, we know that allergens are the substances that cause allergy but are not harmful to most of the people, and a substance that causes irritation, specifically tending to produce a physical irritation, is an irritant. Coming to the pathophysiology of the irritant, what is the difference? Now, what is happening is that irritation basically results in the direct inflammation arising from the release of the pro-inflammatory cytokines in response to the chemicals or the harmful physical stimuli. The cytokines result in activation of the innate immunity, thereby recruiting and activating the T lymphocytes without the induction of the antigen-specific T helper cells. There is extensive denudation of the epithelium, exposure to the nerve endings that is further leading to the neurogenic inflammation. On the other hand, if we talk about the pathophysiology of the allergy, there is exposure to the allergen that causes the release of the IgE. This allergen-specific immunoglobulin of the IgE class bounds to the high affinity receptor on the surface of the basophils and mast cells, resulting in the immediate release of the mediators, including leukotrienes, prostaglandins, and histamines. Allergy is basically associated with active T cell immunity that is skewed toward the Th2 phenotypes. There is involvement of the mast cells, basophils, eosinophils, resulting in the release of the inflammatory mediators, and there is bronchial hyperresponsiveness, obstruction, symptoms of asthma can develop. Coming to the skin prick test. Now, skin prick test is usually used in the diagnosis of allergy. Whenever we prick the skin, there is allergen cross-links IgE and activates the mast cell to release histamine, and there is a wheal and a flare reaction. Thus, in contrast to the direct tissue damage induced by the chemical irritants, which subsequently leads to the local inflammation, the induction of allergic response is by allergens and is characterized by the induction of antigen-specific effector and memory T cells. Here we can see the difference between the two. Irritation is a non-specific innate immunity. Allergy is a specific adaptive immunity. In irritation, there is chemical toxicity and cellular activation of the skin innate immunity. In allergy, there is activation of the cytotoxic CT8 plus T cells against keratinocyte. Finally, in irritation, there is inflammation that is induced by the toxicity of the chemical. However, in allergy, there is inflammation that is induced by the activated chemical-specific T cells. So, irritants do not mount an IgE antibody and thus cannot be tested via skin prick test and cannot lead to the allergic reaction. However, if you have underlying allergies or asthma, you might have sensitivity to irritants. Coming to the clinical significance, irritants either themselves cause health effects or aggravate the health effects. Irritants can affect the skin, airways, or eyes. Now we can have an irritant contact dermatitis. There can be significant effect of irritants to the airways, which include irritant-induced asthma, which is a form of occupational asthma, and significantly high exposures can lead to a reactive airway dysfunction syndrome. Coming to the allergies again, as they are classified into ingestants, inhalants, similarly, the ingested allergies can be there. That is basically the food allergy. We can be allergic to the various food products like egg, cow's milk, fish, seafood, nuts, seeds, legumes, fruits, and vegetables. Contact allergy. can occur when the substance comes in contact with the skin. This is also called allergic contact dermatitis. Nickel is a common agent. Other common contact allergens can be rubber from the natural latex, permanent hair dyes, biocides that are used in cosmetics, toiletries, and other dermatological creams as well. The inhaled allergy, that is a common form and is caused when we breathe in the allergen. This is also called allergic asthma. Particularly, what agents are responsible are the house dust mite, that is the dermatophygoid species, then pollen, that is also one of the major causes, and dander, that is very small and can remain airborne for long periods of time with the slightest bit of the air circulation. Outdoor molds tend to release their spores in the damp spaces and travel better on windy days. And that is why most of the people of the asthma worse in damp weather. Most common molds are the Alternaria, Cladosporium, Aspergillus, and Penicillium. So allergen versus irritant, which is relevant. So allergens and irritant, both are relevant in terms of respiratory diseases. However, it is very important to differentiate between the two. In terms of definition, an irritant is a substance that causes irritation. An allergen is a substance that causes the allergy, but is usually not harmful to most of the people. In the pathophysiology, an irritant incites an inflammatory response, and an allergen incites a Th2 response. Coming to the question that should SPT be done in terms of when you suspect irritation as the cause, definitely a no, and allergen a yes. Coming to the allergen immunotherapy, whether it can be prescribed in cases of irritation, definitely a no. For allergy, yes. Avoidance though is necessary in both the cases. Thanks a lot. Thank you very much.
Thank you, madam, for the excellent presentation. The difference between irritant and allergen is very important. A lot of confusion. Most of the time, it is irritant allergen. I think we'll join post lunch at 2 o'clock.
Thank you.
Thank you, sir.
Thank you, sir.
We'll
Thank you, sir.
Thank you, Parul.
Thank you, sir. Thank you so much. Thank you, sir.
We shall meet 2 o'clock, sir, again.
Okay, right.
Yes, thank you, sir.
और बात पास कर लो कि देखा है नहीं
Agarwal sir.
Yes, sir. I'm here.
Sir, Anand sir is yet to come. Maybe once he starts, shall we start, sir?
Definitely.
Or shall we start now? One more minute is there.
We can wait for 1-2 minutes and we will start.
There are 2 minutes.
Our program is going on very systematically.
Good evening, sir. Good evening, sir.
Good evening, Doctor.
Lunch over, sir.
Lunch हो गया.
हम बच्चे के डॉक्टर टाइम खाते सर, हम टाइम पे खाते.
जब उम्र बढ़ जाती है तो थोड़ा खाना कम खाना होता है तो टाइम भी कम लगता है.
Sir, Nagendra Prasad sir has joined, sir. Dr. Nagendra Prasad sir. నారాయణ రెడ్డి సార్ మీరు స్టార్ట్ చేసేసేయండి.
స్టార్ట్
వాళ్ళు రాగానే నాగేంద్ర ప్రసాద్ సార్ జాయిన్ అయ్యారు. యా
Already connected, sir. I have connected. I am on the screen, but I am not able to unmute. Hello. I am not able to unmute. Can you?
We can hear you, Dr. Nagen Prasad.
Sir, I am not able to hear. I am not able to mute.
They will make you co-host.
Just a minute, sir. Can you hear me now?
We are hearing you, Dr. Nagen.
Oh, fine.
Hearing, sir.
Some screen has come. Should I go with the sharing?
Organizers must have been sharing.
Start, sir. Start kar do.
Share karo bhai, Dr. Pawan Kumar. Please unshare. Yeah.
Yeah. Audible. Is it visible, sir?
Visible as well as audible. Dr. Nagen.
Make it full screen, sir.
As usual,
fine, sir.
Looking bright and.
Yeah. Make it full screen, sir.
Sir, outer line, sir.
Yeah. Full screen.
Thank you. Shall we proceed?
That is
start, sir. 2 o'clock now. Start now.
Still we start?
Yes, sir. Nagendra sir doesn't require any introduction, sir. He is a well-known person in Bangalore Allergy Center, sir. So, talking about probiotic because of immune system, sir. But go ahead, sir.
Thank you, sir. Thank you. Today we will discuss about the novel targets of probiotics in the mucosal immune system, which is an emerging subject and which is yet to establish its roots. But we have to understand what is the mechanism behind probiotics. To understand about the probiotics, these are the objectives which I would like to discuss. This subject is very vast and I would like to, as much as possible, and make you to understand. The intestinal microbiota, the hygiene hypothesis and microbiota, probiotic bacteria implications for human health, epithelial sensing of microbiota-derived signals, mechanisms of anti-allergic probiotic action, treatment of atopic disease, applications of probiotics, how can probiotics and prebiotics impact mucosal immunity, then pathogen-associated molecular patterns, and gut-lung crosstalk in health and disease. So the microbiota, you should know what it includes. A different microorganisms consisting of bacteria, fungi, virus, protozoa, distributed over many human body surfaces, including the skin, vagina, gut, and airways, with the highest density found in the intestines. The gut microbiota strongly influence our metabolic, endocrine, and immune system, as well as both the peripheral and central nervous system. Gastrointestinal having the highest density of microbiota, weighing approximately 1.5 kilograms, microbiota resides in the GI tract, outnumbered human cells, which is a 10-fold and a genome size of 100-fold. The normal intestinal microbiota have a diverse composition. A conservative estimate is that it consisting of at least 400 species, which is documented, and which is expected it goes more than 1,000. The microbiota changes over time from birth.
अच्छा मैं आपको ही कर रहा था शुरू उन्होंने शुरू कर दिया था मैंने कहा टेलीफोन कर दूं आप.
And in response to environmental factors such as diet and exposures, the intestinal microbiota is to provide against incoming bacteria, example, potential pathogens. This colonization resistance works through several different mechanisms: composition for nutrients and binding sites and production of antimicrobial substances. The intestine is the body's largest immune organ. Most of the antibody producing cells reside in the intestine. A relatively recently recognized function of the intestinal microbiota is to provide a stimulation of the immune system. At birth, we have an immune system of an infant is not fully developed, and it is and tends to be directed towards a Th2 phenotype to prevent the rejection of in utero. Once the baby is exposed to the environment, the baby has to expose to the bacteria and viruses, and Th2 phenotype will be gradually shifted to Th1 before 2 years. Microbial stimulation early in life will reverse Th2 basis, and their combined action will lead to the production of IgA by B cells. IgA contributes to allergen exclusion and will thereby reduce exposure of the immune system. Cytokines produced by the Th1 phenotype will reduce inflammation and stimulate tolerance towards common antigens. This is a small cartoon to give you how these bacteria are in a different level will act. The level 1, which is inside the is and interfere with the growth of survival, improvement of the mucosal barrier function and mucosal immune system at level 2, and effect.
There is some difficulty because his Dr. Nagin Prasad's voice is coming interrupted.
Okay. Can you hear now?
We are able to hear you, but you get in between pause.
Interrupted because of the, I think, internet connection. My speed is okay.
Okay.
I don't know, there is a relay. So this is a immune system programming by microbiota, separated by the structure of the intestine by the epithelial layer. Macrophages, neutrophils. So coming out to the cellular level, you see interleukin cytokines are very, very important, and which stimulate the IL-10 stimulates to maintain the allergenic phenotype, and which is the stimulate and producing the IgE, and IL-12 stimulates a shift towards a tolerant phenotype, and T3 cells through the production of tumor growth factor beta stimulate the shift towards a tolerance. IgE may activate mast cells and cause allergic symptoms. IgA may provide allergen exclusion. We are all data. In 1989, between the occurrence of hay fever and number of coined the term hygiene hypothesis. He proposed the decrease in incidence of infection during childhood and the development of immune system, leading to the increased risk of allergy. Subsequent studies show that the growing up on a farm, attending a child care, and exposure to a dog-associated house dust all provide protection against the development of asthma. These hypotheses were later modified to state that microbial exposure from commensal bacteria that had co-evolved with humans was necessary to correlate with your immune system. Humans have evolved in an environment with a heavy bacterial system has been adapted to deal with that. Processing our contact with microbes has changed. Appropriate microbial exposure may pose a problem for the immune system. In infants, the immune system is still developing. This provides an opportunity to direct development away from the allergic phenotype. In young infants, the immune system is still developing. There is still a possibility to direct it towards the tolerance. In older children, the allergic phenotype is already established, and here one only be able to relieve the symptoms. Similarly, antibiotics have not been very successful in the respiratory allergy. Was not able to reduce symptoms to rich pollen allergy in adults despite its effectiveness in children. Similarly, Lactobacillus acidophilus was reported only to relieve the subjective symptoms of cedar pollen allergy adults. In the case of allergy, the rationale for modulating the intestinal microbiota is supported by observation that allergic children have a different microbiota composition than healthy infants. Children with allergy were found to have an aberrant microbiota even before the onset of allergy. They had a higher levels of Clostridium and a lower level of Bifidobacterium. The microbiota has a metabolic activity that equals that of the liver, our metabolically most active organ. Microbiota contributes to the digestion of exogenous and endogenous substrates such as fibers and mucins. This provides the host with additional energy in the form of fatty acids and metabolic end products such as amines, sulfides, ammonia, etc. So implication for human health by probiotics, which has been studied in the rodent as well as human, the effect is the inhibiting of the IgE, increasing this secretory IgA, decreasing the translocation of increased anti-E. coli, IgM, and IgE, increasing the serum secretory IgA. On cytokine production, there are two trials which has been done human and one on the rodent. The human, which has been shown that serum interferon gamma has been increased. Another is TNF alpha in patients with a food allergy, which has been increased, and decreased a fecal TNF alpha. So similarly, non-specific immunity and 3 rodent studies and 1 human study. And here is increased phagocytes, enhanced phagocytosis, study which is not conclusive. And milliliters.
डॉक्टर नगेन प्रसाद बहुत frequently आवाज ब्रेक हो रही है.
Probably internet is the signal is a problem, but my signal is showing optimum. Anyhow, I'll be trying.
We can hear you, Nagin Prasad.
Thank you. So influenza immunization definitely protects IgG levels. Microorganisms can tightly interact with a host tissue by employing a dedicated protein so-called adhesins. which is very, very important. And this surface express additions are mostly unique for a given bacterial species and encompass integral membrane proteins. The gastrointestinal tract harbors trillions of microbial species collectively termed called microbiota, establishing a symbiotic relationship with the host. Intestinal epithelial cells with the microbiota and are critical for maintenance, and signals from the microbiota are directly IECs are influenced by intestinal health, respond to fortifying intestinal bacterial form. IECs always detect the commensal microbes through pattern recognition receptors or by sensing the production of microbial derived metabolites. Deficiencies in these microbial detecting pathways by ICs leads to impaired epithelial barrier function and altered intestinal homeostasis. This is a small a cartoon just and if it's antibiotics are given, how the colonies will come down and the impairment of immune activity. And similarly, when you supplement it with prebiotics, the colonies are regained. And this is the one section which gives a pro-inflammatory, another section is anti-inflammatory. So both can be altered depending upon the probiotics. The difference in addition to the intestinal mucosa may result in a different or reduced stimulation of the immune system through the gut-associated lymphoid tissue. Not only the composition of intestinal microbiota, but also the metabolic activity of the microbiota may be different. A section of the children from the Swedish who are at high risk of developing an allergy were found to have a significantly higher level of fecal butyrate, isovaleriate, and a caprate when compared to the Estonian children who have a low risk of developing allergies, which is significantly seen. So modulation of intestinal microbiota probiotics have been observed to improve the barrier function of the intestinal mucosa, reducing a leakage of the antigen through the mucosa and thereby exposure to them. Direct modulation of the immune system may be through the induction of anti-inflammatory cytokines or IgA will continue intestinal mucosa. Further, enzymatic degradation of dietary antigens by enzyme from probiotics will reduce the load and expose to the antigens. These and other mechanisms contribute to reduce exposure of the immune system to dietary antigens. This is a small picture to show how the food antigens, food allergy can be reduced by using the probiotics. It is by improved mucosal barrier function, degradation of food antigens, and activity, stimulation production of secretory IgA, change in the mucus production, and a direct immune modulation. So with the gut lumen, by direct interaction with the complex ecosystem of the microbiota, probiotics can also have a direct metabolic effect of the gut by providing enzymatic activities by interaction with the gut mucus and the epithelium, including barrier effect, digestive process, and mucosal immune system. Signaling to the host beyond the gut to the liver, systemic immune system, potential organs such as brain and the lung. So in the clinical expression of the allergic diseases, the maternal fetal interactions is very significant, and exposure to the environment and the genetic factors which is influencing on the mucous epithelia, gut microbiota, nervous system, and immune system. So probiotics have been observed to improve the barrier function of the intestinal mucosa, reducing a leakage of antigen through the mucosa and thereby exposure to them. Direct modulation of the immune system may be through the introduction of inflammatory, anti-inflammatory cytokines or through increased production of secretory IgA. IgA will contribute to exclusion of antigens, which I already discussed. So probiotics is the best known in nutritional therapy. Live microorganisms which when administered in adequate amounts confer a health benefit of the host. In the intestine, they mainly refer to the genera of Lactobacillus and Bifidobacterium and include many different strains such as Paraceae, Rhamnosus, Acidophilus, Johnsoni, Fermentum, Reiterae, Plantarum. Among the Bifidobacterium, Longum, Breve, Bifidum, and Animalis, Suspension, and Lactis. A limited number of strains have been tested for their efficacy in the treatment of prevention of allergy in infants. Allergy may manifest in infants even when they are exclusively breastfed. Standard treatment involves the feeding of extensively hydrolyzed formula. Supplementation of this type of formula with Bifidobacterium lactis or Lactobacillus rhamnosus has been found to lead to the earlier recovery than standard treatment alone. Standard treatment involves feeding extra, that's which I already discussed. And coming on to the treatment with atopic disease, Lactobacillus rhamnosus was not able to reduce the symptoms of birch pollen allergy others despite effective in children, whereas Lactobacillus acidophilus was reported to only to relieve the subjective symptoms of cedar pollen allergy in adults. Infants with atopic dermatitis have been found to have a more adult type of Bifidobacterium microbiota with a high prevalence of adolescences. Healthy infants, on the other hand, were found to be colonized mainly by Bifidobacterium bifidum, typical for breastfed infants. The Bifidobacterium from infants with atopic dermatitis were found to induce a higher secretion of pro-inflammatory cytokines in vitro, whereas the Bifidobacteria from healthy infants induce the secretion of more anti-inflammatory evidence of the functionality of different probiotics in 4 areas that is in the human application. One is metabolism, one is a chronic intestinal inflammatory and functional disorders, third is allergy, and fourth is infections. Among the metabolic dietary compounds in the gut lumen, lactose digestion, lipid metabolism, oxalate metabolism, composition metabolic markers of the gut microbiota, xenobiotics, phytochemicals, indigestible dietary components, metabolic activity of gastrointestinal mucosa and liver. Inflammatory bowel disease like Crohn's disease, ulcerative colitis, pouchitis, and irritable bowel syndrome. Among allergy disorders like eczema, atopic eczema, allergic rhinitis, and asthma. Coming on to the infective factors, infectious diarrhea, traveler's diarrhea, necrotizing enterocolitis, Helicobacter pylori, respiratory tract infections of adults and children, ear, nose, and throat infections, complications in surgically ill patients. So one is the effect of different candidates on the same specific benefit ending in identification of one active probiotic on the specific benefit and one non-active microorganism on that condition, illustrating the specificity of some probiotics. This is very, very crucial. And identification of different strains within the species that are able to provide a similar benefit. Theoretically, when all tested strains and species have a similar beneficial effect, this could point towards a generic bacterial effect. The immune system provides the first line of defense against pathogens and ingested toxins. Immunomodulation is interpreted more broadly and include antibodies, complement, and cytokines, effect on gut barrier function, and induction of antimicrobial compounds by the host. Microbes in the gastrointestinal tract can exert numerous effects on different cells of the mucosal immune system, and in turn induce immune cells. Regulation mucosal immune response, causing a chronic inflammation such as Crohn's disease or ulcerative colitis. Immunomodulation is interpreted more broadly and includes antibodies, complement function, and induction of antimicrobial compounds by the host, which I am repeating. Microbes in the gastrointestinal tract can exert numerous effects on different cells, the mucosal immune system. and turn induce the production of cytokines which prime additional immune cells. Depending on the immune stimulus, toll-like receptors on the surface of immune cells are differentially stimulated, allow the immune system to discriminate between pathogens and a gut microbiome. The mammalian gastrointestinal tract requires a constant balance of power between immune activity and tissue homeostasis. A monolayer of intestinal epithelial cells separate the mucosal immune system from the external environment. Remarkably, trillions of bacteria, fungi, archaea, and virus reside within the intestinal lumen and constantly interact with their host mammalian cells. The sheer abundance and proximity of the microbiota and their foreign antigens create an immense source of potential immune stimulity. Cells act in the resistance of manner, balancing inflammatory and regulatory response to prevent aberrant reactions of innocuous commensal antigens. Pathogenic infections, intestinal immune cells are poised to combat, eliminate invading microbes. ICs coordinate numerous physiological processes, including the nutrient absorption, pathogens, defense, and immune regulations. Intestinal epithelium constantly modulate the absorptive enterocytes, which are responsible for metabolic and digestive process, or secretory lineages that are specialized to maintain a digestive or barrier function. So this is a small example with one of the, just I'm giving you surveillance pathways. One is microbial pathogen associated molecular pattern produced by the microbiota. Another is the metabolites generated by the microbial digestion. So PRRs detect a common microbial molecules termed pathogen associated molecular pattern during the infection.
Nagendra sir, gentle reminder sir, time is up.
I will be finishing another 5 minutes. So this is a different ligands are available. Toll-like receptors were one of the first PRRs to be identified as TLR signaling. Polymorphism on variants of TLR2, TLR4, TLR5, TLR9 have been associated with increased incidence of severity of IBD. So for detection of intracellular conservative proteins called NOD-like receptors, and the short chain fatty acids include acetone, propionate, and butyrate are produced when dietary fiber is fermented by the microbiota. And they are main energy source for colonocytes and are crucial for intestinal epithelial homeostasis. In fact, dysbiosis observed in IBD patients were associated with a loss of ACFA. And supplementation of SAG improve the chemically induced intestinal inflammation and diverse effect of mucosal immune cells function. And secondary bile acids also secreted in the small intestine and eating and are critical for lipid digestion and absorption by the microbiota. And essential amino acids also, serotonin is also secreted by probiotics, and succinate is also secreted. And so these are all, and since 2010, studies have described alterations of the lung microbiota in a number of disease conditions such as chronic COPD, cystic fibrosis, and asthma. Lung microbiota influences both respiratory health and disease. In addition, the gut microbiota have been shown 2 minutes, sir, just 2 minutes. And pulmonary immunity through what is commonly referred to as gut-lung axis. So this is just a small cartoon to show you the difference between the health and disease. The gut microbiota, which is already there, which migrates into the lung or by swallowing or by inhalation. And this is a similarity between the gut microbiota and alveoli, which is having a similar structure, which is colonizing with the microbiota. And this is a gut-lung interactions which is happening between the lung and the intestine through the various modes. And this is a principle of cross-link and a health disease. And this is a chronic lung disease like COPD and a chronic gastrointestinal tract disease such as inflammatory bowel disease or irritable bowel syndrome. Up to 50% of adults with irritable bowel syndrome disease and IBS have pulmonary involvement such as inflammation or impaired lung function. Although many patients have no history of acute or chronic respiratory disease. Furthermore, patients with COPD are 2 to 3 times more likely to be diagnosed with IBD. Thank you very much, sir. Sir. Thank you. Thank you, Chairman.
Should we proceed to the next session now? Dr.
Yes.
Sir, thank you so much, sir. Nagendra Prasad, sir. Now, A.B. Singh, sir. Now, PC.
Okay, thank you.
PC Kathir, yeah, take over.
Friends, we are going to have a next session, that is the Modi Memorial Oration 2021. We had our 2020 RK Modi Memorial Lecture yesterday. You had Rajkumar, and this is for 2021. Those who were not present yesterday, actually, we introduced Dr. RK Modi, in whose honor this oration lecture, this memorial lecture was instituted some 4 years back. First one was delivered in 2018 by me, then followed by next year by Dr. Agarwal, and then Dr. Rajkumar. Now I will try to introduce Dr. Can I share my slide?
Oh, yes, sir. I have. Dr. Kathuria ने sharing शुरू किया.
अरे थोड़ा जल्दीबाजी नहीं करो भाई.
Oh, okay. I stop it. Stop.
Share कर दो.
Stop कर रहा हूँ. I'll now share.
Yeah. Thank you. Friends, those who are not aware, actually yesterday, although I introduced Dr. R.K. Modi, in whose honor this memorial lecture has been instituted, keeping his contributions to the college in mind, long association with the college, and active participation in various activities of the college. Dr. Modi actually was born on 21st January 1938 in a joint family, a large joint family in a Lordanga, which is in Jharkhand state. His initial education was there in Ranchi. Later on, he graduated and post-graduated in medicine from the Patna Medical College. And he did his MD actually under the supervision of Dr. R. Vishwanathan from the Magad University, Bodh Gaya. His research experience includes, he was research officer for 7 years in the Department of Medicine at Rajendra Memorial Research Institute, Patna. During this period, he was associated with several projects actually on the epidemiological work of the chronic bronchitis, bronchial asthma, and co-workers disease of pneumoconiasis. Research and prevalence of bronchial asthma in rural and urban areas was studied by him, which was jointly published by Dr. Vishwanathan. His main interest was skin test, immunotherapy, and clinical research in allergic disorders. He had 40 publications to his credit in this field, and in fact, he was most popular allergist in the Bihar. In Patna, actually, he used to almost spent more than 35 to 40 years in his clinic and established at the Rajendra Nagar his own Modi clinic. Dr. Modi was so popular actually that not only from Bihar but adjoining states used to visit him, and he always used to say, my ambassadors are my patients actually. They are the one who we used to joke with him whether you have almost immunized the entire Bihar. He says this is the beauty of this disease because they get free and then they get symptom free, and that's why they come back to us. Dr. Modi had organized 2 conferences at Patna during his period, and he was so long he was alive, he was the zonal convener from the East Zone of the Indian College of Allergy and Applied Immunology. Actually, he died on 30th of November 2016, and that's how college executive council, keeping his contributions and details in mind, instituted this honor in 2018. With this background, I will like to request Dr. Gaur to introduce today's speaker, who is none other than Dr. P.C. Kathuria, who is our treasurer, and Dr. Gaur will introduce to him in detail. Dr. Gaur, please.
Yes, Dr. P.C. Kathuria, who is MD Chest along with some other degrees. He is working as Senior Consultant, Department of Allergy and National Allergy Center and B.L. Kapoor Super Specialty Hospital in New Delhi. He has got 41 years of experience of clinical practice. He has been chairman of 22nd training courses or 3 days courses, which has initiated in his center, invited a speaker in national and international conferences. He has published more than 50 reviews, abstracts, and research articles. He is the author of a book. His concentration on cluster subcutaneous immunotherapy and sublingual immunotherapy has been his research interest. Immunotherapy and sublingual immunotherapy combined with anti-Ig, that is omalizumab, in various allergic conditions, and he has got keen interest in hereditary angioedema. He is treasurer presently of Indian College of Allergy. He has got various fellowships to the Indian academies. Excellence. He got the Excellence Award in 12th National Conference of Indian Society. Scientific Excellence Certificate Award from Ranbaxy, V. Raju Award from Icaaicon, Award of Honor Manav Seva Kendra from Panipat. And along with this, I think he has got many contributions to his credit, and he has got a big biodata. I now only request Dr. P.C. Kathuria to please give his talk. Oration.
Okay, good evening, everybody. I am audible.
Yes.
My greetings to all. Thanks, Chairperson, Dr. A.B. Singh, Dr. S.N. Gaur, with due regards to Dr. M.K. Agarwal, and all my senior friends. Today is a proud moment for me. I feel humbled to deliver Dr. R.K. Modi Memorial Lecture on common allergens in clinical practice and challenges in the polysensitized patient. Dr. Modi was really a karma yogi. He visited this world, already explained. To add few points, he was a devoted family man. Today, a great family. Her wife, Dr. Prabila Modi, she is an eminent gynecologist in Patna. His son, Dr. Gautam Modi,
Hello.
Charu Modi, they are maintaining the legacy.
Namaskar, sir.
Dr. Agarwal, mute kariye, please.
Some of you don't know that myself.
उसको तो म्यूट कर दिया मैंने.
नहीं किया.
नहीं किया. Okay.
And Dr. Modi took treatment under Professor D.N. Shivpuri in 1979, father of allergy medicine in India. Today, it is my tribute to discuss on common allergens in clinical practice and challenge in polysensitized patients. I will discuss on why polysensitization, how to differentiate species-specific allergen from cross-reactive allergen, whether to mix or not to mix allergen in a case of a polysensitization, and how to reduce the allergenicity in polysensitization. And then I will share my cases combining allergen immunotherapy with omalizumab in polysensitization. My statement starts, anyone can do skin test, but few do it well and can interpret the positive allergy skin test with a clinical relevant sensitization. But the most difficult part in your clinical practice is how to select the allergen in a polysensitized patient. Most of these patients we have seen, their symptoms was perennial symptoms with a seasonal exacerbation. If you do pollen, mites, animal dander spores, or even foods, they are all positive, difficult to differentiate. Polysensitized are not polyallergic. While polyallergic are clinically correlated with the symptoms, they are always polysensitized. If there is a more than 70% of the sequence from the various group structure of the molecules bind to the Ig antibody when use the term cross-reactivity. And it is less than we use, it is cross-sensitization. But if there is expression of the Ig receptors on the various inflammatory cells with Ig antibody with a different group of allergens, then we use the term co-sensitization. 25% of the patients in Europe, as per the study 2010, are polysensitized. In USA, 38.8% they are polysensitized as per the study 2005. If you look at 2014 study, it variable from region to region from 27.5 to 74.3% of the patients. In one of our own study, we found 80% of the patients, those who are referred to us, they are polysensitized. And most of the allergens which we practice are mites, pollens, and cockroaches. Why polysensitization? Is it due to the heterogeneity of the allergen source of extract or content because of the different containing the allergenic protein in our extract from one batch to other batch? Or is it due to certain allergens present in pollens, in animal origin, streptomycin, paralbumin, or is there certain basic defect in the production of the IL-10 interferon gamma or IgG4 antibody in a specific host? Or there is an interaction of the microbes, pollutant with the allergens, that allergens become so cytotoxic that the extract we do the test, all are maybe positive. So it is questionable. Polysensitization, why we are worried? Because symptoms is equivalent to the sensitization multiplied by the allergy load. If patient is a polysensitized, multiple group of the allergen, even if a minimum exposure of the allergen will induce the reaction, will induce the symptom. And moreover, there is a risk to achieve the maximum tolerance dose or the effective dose during the build-up phase and during the maintenance phase. These people, the 6 times higher for highly allergic patients who show a pattern of more than 3+ or 4+ skin test reactivity. Even if my extract is standardized, specific, stable, but polysensitized patients are likely to induce adverse reaction. Take-home message: accurate prescription of allergen immunotherapy depends on the species-specific genuine cross allergen, not on the cross-reactive allergen. With the advent of a CRD, component resolved diagnosis, if we give allergen immunotherapy with a cross-reactive allergen, there is a highly risk of getting the severe adverse reaction, and even the immunotherapy fails. So you have to differentiate whether my patients, whether the allergen is a species-specific genuine sensitization or is it a cross-reactive. The challenge in polysensitized patient is only that you can select the allergen by CRD to differentiate between cross-reactive and species-specific allergen. But where is the CRD? It is not available. Then what to do? For the last 40 years, CRD has come recently, for the last 10 years. But in India, still it is not available. Then what to do? Question is, can our skin test, immediate reaction, late phase reaction, together by allergy skin test, predict the selection of the species-specific clinical relevant allergen? That is the experience which I want to share. You know that this SPT is a gold standard test all over the internationals, we says, and there is a difference in the biological mechanism of the skin prick test as the specific IgE, but this skin prick test detects the cell-bound specific IgE, only the free IgE antibodies, but there is a discordance of 25 to 30%. We do skin prick test. We interact with these 5 molecules, allergens, 2 specific Ig antibodies, 2 receptors, markers, mediators. But we have never looked at this eosinophilic mediator and T cell cytokine after 1 hour. We look only for the wheel size and to make the diagnosis and prepare the vaccine. Now, we have come a long way. If the wheel size is more than 8 millimeter, as per the various studies of diagnostic of peanut allergy, example is there. But if the size is 3 to 7 millimeter, this is a gray zone. Again, you have to correlate with the clinical acumen of the clinical allergist, whether to go for OPT, oral provocation test with peanut or not. Say, for example, if my patients, I do test histamine, this is a control. I will do 33 allergens, which I do in my practice routinely in most of the patients. Out of 33, these 10 are all positive. Can I mix the allergens in a vaccine and make all this mixture of no. I have to differentiate out of these 10, how many are species specific, how many of are cross reactive. I ask my patients to wait for 3 hours. After 3 hours, only 3 allergens are left. Rest of the allergens, they fade off. Nothing is left. Only 3 allergens. After these are the late phase reaction due to the infiltration of the eosinophils. Peaks at 3 to 6 hours. Visible, you can look at 3 to 6 hours. Sustained at 6 to 8 hours and resolves in 24 to 8 hours. Our is most of the patients at 3 hours, they become positive. I will give the vaccines of these immunological significant with these 3 allergens out of 10 allergens in a polysensitive. Even Jellenbaum has beautifully mentioned the different 2 types. Type 4B is due to the eosinophilic activations, Ig, local Ig productions, responsible for the chronic allergic inflammations leading to the persistent tissue damage and bronchial hyperreactivity. But we have never looked, we must look for this type 4B along with the type 4-1. Immunotherapy is not effective against Ig immediate reaction, but it is also prevent the ongoing inflammation. So what is the science behind late phase reactions? I look into the literature. From 1990 onward, nothing was available. Only few of the literature is with me. This says that study has been verified that once you do the allergy skin test, in 5 minutes, there is a release of the histamine or tryptase. And it goes on decreasing at 60 minutes, nothing. You can't see it. But within a 30 minutes, there is a ECP, the eosinophil cationic protein from the eosinophils comes into action. Maximum at 4 hours, 6 hours, and even 8 hours. So from this, not only this ECP, but all the IL-5, the cytokine, which is responsible for the eosinophilic survival, differentiation, it also by biopsy been found that it was an IL-4 was an immediate reaction, and IL-13 and IL-55 was found in the late phase reaction. It was not a biphasic. This was the teaching at that time, 79. No, it is a continuous reaction. Look at this study done in 1988. 1 hour release, another there is a ECP, the eosinophilic, the reactions look as a edema as well as the erythema. Again, this paper 1989, they have confirmed by biopsy, it is the eosinophils with the reactions last 3 to 6 hours. Friends, international consensus gives us a cutoff of 3 millimeter. Why? It is based on nasal provocation test. It is reproducible, not on the clinical relevance. And we have found in our study, if patient's skin prick test is more than 4 millimeter, along with the specific Ig 1 Ku, positive predicted value is more than 70%. But if patient is a polysensitized, then I will take the help of the late phase reaction, not only the immediate reaction, but also the late phase reaction. So my hypothesis, selection of the clinical relevant allergens in polysensitized patient if CRD is not available based on the immediate reaction, late phase reaction together rather than the immediate reaction. And this paper we have published, significance of the late phase reaction in allergy skin testing in a case series we have published. Friends, now let us go to the common allergens. Dr. Bhattacharya has compiled 17 years research work in India, and he found on fungus 160 papers, on foods 159, 80 pollens and 10 insects. And this research was initiated by my mentor, Professor D.N. Shipuri in 1960. And later on, our living legendary figure, Dr. M.K. Agarwal, Dr. A.B. Singh, Dr. Agashe from South, and Dr. S.N. Gore, the architect behind the guidelines of the allergen immunotherapy. We present first paper in my life in 1979, that was the 30th convention of Indian College of Allergy on clinically important allergen 3+ and 4+. Then with my second mentor, we published the prevalence of respiratory allergy in allergy clinic. We started in 1977 in allergy clinic in KGMC, and it found 2 years data, 31% in allergy. Now in 2013, Dr. Rajendra Prasad, Dr. Rajkumar has found that is 30% in the population. So how much consistent and persistent increase? There are 33 common allergens which we do in our practice. First one is a house dust mite, second is a pollen, third one is a cockroach, fungus, danders, and others. We know these are the pollen are the allergen carrying particles. Fecal are the allergen carrying particles. A lot of the work has been done in India on source and particle, but we need molecular characterizations by the mass spectrometer for Ig binding protein. Some work is going on, so future is okay. Detect the molecular, because these are the disease eliciting molecule which varies from region to region. So friends, dil mange more. Why it is though? Because 55% of the prescription were changed after the disease eliciting molecules has been detected in USA, and even 20% of these patients, they does not require allergen immunotherapy. We know the house dust mite presence in a fecal part, very common disease or asthma, rhinitis, atopic dermatitis, but we should know that DERPI2, which country in USA, it is not DERPI1 and DERPI2, it is DERPI23 is also there. And in Japan, in Canada. So our country must know which DERPI1 or DF1 is more common. We need more work on it. Because allergen immunotherapy is done in DERPI1 and 2 in US, it is with DERPI23, not for DERPI10, which is tropomycin, where the immunotherapy fails. Even in atopic dermatitis, is DERPI11, a lot of the work is there. So we need more work. Cockroach, it is a per a BLAG1, which is significant disease eliciting molecule. Rest of them are cross-reactive. A lot of the work has been done by Dr. A.B. Singh, Dr. M.K. Agarwal. In our study, we found 1992, Nirankar Sharma, they were helped me at that time. Fumigators was 8.4%, 12.5% alternaria. But the disease eliciting molecule in allergic asthma due to aspiral fumigators is ASPF1. Morning session was on aspiral fumigators. The molecules so far detected is ASPF2, ASPF4, and 6. Pollen is very common, 25% of our patients. We know allergic asthma, rhinitis, atopic dermatitis, but how to differentiate whether this patient is a pollen fort syndrome, having certain symptoms of urticaria, angioedema, anaphylaxis, or oral allergy syndrome. In 92, it was the prevalence same is there. These are the pollens, 20 pollens are common in my practice. So these pollens are carrying, allergen carrying, but we want more BET-V1 17 KDA, which is a disease eliciting molecule. These are the pollens and these are the disease eliciting molecules. How to differentiate from a pollen? 10 allergens, PR10, procalcin, LCTP. Either you go for the CRD, either you look for the LTP. Either you look for the late phase reaction. Say, for example, this patient of a birch pollen 3+, Cydoron 3+, Timothy 3+, Mugwort 3+, how will you differentiate? But if we know the molecule FELP1 is a primary sensitization responsible for the rhinitis and asthma. But if ARTV3 is there, it is pan allergen LTP. It will produce urticaria, angioedema, anaphylaxis. Like if it is there, LTP, pan allergens, no allergen immunotherapy is suggested as per the guidelines now. How to suspect a LTP? 91% of the patient, if you do the peach skin test by PPT, it is positive. Similar story with the propylene. How will you detect propylene? Because they activate only oral allergy syndrome. But these patients should be confirmed by if you do the PPT with a watermelon. So, friends, differentiation is required. Is my patient is a primary true sensitization and a cross-reactive? Because primary true sensitization needs allergen immunotherapy, cross-reactivity does not, like in glycocalinemic NF, like FLD1 in a dog, they are significant allergen immunotherapy, while all these cross-reactive doesn't require allergen immunotherapy. So take home message that either we should do the CRD, if not available, presently what our practice is based on look at the not only the IR immediate reaction, late phase reaction, and also would complement with a specific in a polysensitization. Now what to do, how to mix these? Whether we should mix as per the guidelines 2021 says the level of evidence is 4. Grade D, weak recommendation, no mixing in a polysensitization. If mixing is only possible if it is a homologous protein, not with a non-homologous protein. 76% patients, if patient is sensitive to pollen, house dust mite, alternaria, give it separately. Rule out cross-reactivity and protease incompatibility. And all over the world, this mixing is done. Pollen, dust mite, pollen, grass pollen, tree pollen. Little bit of the difference, but 76% of these patients, they are house dust mite and pollen. We in India, we are giving this combination, but once patient is sensitive to the alternaria cockroach, we give separately. There is a 3 pollen advice in Europe, and there is a 8 pollen mixture in US. Because Europeans, they say that we are worried about the effective dose. American says that we are worried about the optimum dose, but they rule out the cross-reactivity, they rule out the enzymatic degradation of the allergens. In our Indian guidelines says not more than 4. Rule out totality, enzyme activity, incompatibility, and cross. So there is a clinical experience well on a single allergen, pollen dendrus gives separately 3 vials. Most of the studies, 98 studies have been done so far out of 80% of on the single vial. There is also good evidence on a sublingual separate single allergen, but it should be standardized. There is also you can combine slit as well as the skit also. Patient is a polysensitive. So good evidence, poor evidence if you mix these. Poor evidence with slit if you mix these. But there is a good clinical evidence if you give separately or combine subcutaneously and slit. But one should know the T cell binding epitope in the extract. They are very fragile. If my stability is not controlled, specificity is not maintained, and this becomes brown, you are giving the placebo. Similarly, if you are giving pollen with a mold, you are giving placebo. Stability must be maintained because we have maintained the T cell binding epitope. So summary, the evidence of the efficacy of allergen mixtures in pollution is extremely weak. Global trials and guidelines support the use of the monoallergen immunotherapy, and virtually all the published randomized controlled trial of both. Now, the last part is there, how to reduce this allergenicity in this case. Because we know that the 6 times they will produce adverse reaction. Most of our patients, they cannot achieve the maximum tolerance dose, optimum dose, effective dose. What to do? We did 2008, even the practice parameter, world update says you give cluster with omega. Cluster means 3 doses at the interval of 30 to 1 hour you can give. We did study, observational study in 2008, and it was an eye-opener for us. We admit the patients, 9 cases we did, and we achieved that in 9 patients, cluster immunotherapy, even with a combined allergen immunotherapy, the 3 visits, 3 injections of the melisivir achieved the effective dose in 36 days. And further 2008, most of our patients who have this protocol, first injection of melisivir 15 days before, second injection at the time of the initiating of the allergen immunotherapy, and third injection we continue till patient has achieved the maximum tolerance dose. So this we did study in our patients, like these patients of a secondary prevention allergen immunotherapy with allergic asthma and 4 allergic rhinitis asthma, and 4 we achieved the remissions, no lava ice, and 1 was controlled on ICS. We also added steroid dependent cases, means now we are approaching the tertiary allergen immunotherapy where the steroid dependent has a comorbidity. Combination, 50% reduction in ICS in 12 months. This we published. Another, we found the 2 comorbidities, not only the steroid dependent, but also the atopic dermatitis. Patient took all the updated medicines, but still needs oral steroids. How to reduce? Strong 50% reduction of the OCS once we add omalizumab and we achieve the effective dose. Then we switch on to compare with the conventional immunotherapy with a cockroach, and we found in 3 patients that patients who took omalizumab and cockroach allergens, we achieved the effective dose of 2.5 milligram per month in a 36 days, but other patients took 4.5 months to achieve the maximum tolerance dose. This we published. Then we took the arterial patients with recurrent polypectomy done, nasal polyposis, has to take steroids. No drug is except allergen immunotherapy. This patient was given alternaria, achieved the maximum tolerance dose of 2.5 milligram per month this week. And then we switch on to pollens. Now, pollens is a unique. Some of the pollens, they have got a pollen foot syndrome, OAS they get it. Patients present to us as a case of urticaria, angioedema, anaphylaxis, or OAS. So we do the test and we go back to the history and found that these patients, they have grass pollen, in case of the OS, and tree and wheat pollen if they have got a history of the urticaria, angioedema, and has a past history of the rhinitis. Rhinitis symptoms are not predominant, skin symptoms are predominant, but the past history will say that respiratory symptoms are predominant. And this case, 7 cases we reported. These patients, she used to take chia seeds. A combination, she got anaphylaxis immediately. And we found on the base of the late phase reaction, she was highly sensitive. All the grass pollen were positive. No weed and treat, only grass pollen. She was, penicillium was also there, but we have to rule out penicillium because cyanidone has got a least cross reactivity. We give cyanidone immunotherapy and improve. Similarly, in a tree, this wheat pollen, artemisia, whether it is a species specific, I depend on the LPR. If LPR is positive, I will take this and this patient achieve remission. He used to have a history of the urticaria angioedema. Tree pollen also, LTP syndrome we diagnose. A patient has a history of urticaria angioedema, and this patient was positive to strongly 4+, 5+, prosopis and haloptilia. Even we started haloptilia immunotherapy, but patients got anaphylactic. But with the use of the omalizumab, then we switch on to prosopis. So diagnostic interpretation in polysensitive differentiate first clinically relevant allergen sensitization, PCP specific from cross-reactivity by immediate reactions and late phase reaction. Combined subcutaneous immunotherapy with omalizumab is safe and effective in management of allergic rhinitis, mild to moderate asthma with comorbidities, means food allergy, atopic dermatitis, chronic rhinosinusitis, nasal polyp, HPA separation. In polysensitized patients, polysensitization is not a risk to achieve maintenance dose.
A gentle reminder, sir.
So this is a allergist determines the clinical relevance of the allergic sensitization or cross-reactivity, not the test itself. So I quote George Bernard Shaw, life is no big candle to me. It is a sort of splendid torch of which I have got hold of at present moment. It is my duty to burn it as brightly as possible before I hand it over to the future generations. So, ladies and gentlemen, my regard to Dr. M.K. Agarwal always encouraged me to do some research work. Dr. A.B. Singh also always encouraged me to do some work. So kind of you. And also I acknowledge my staff, Dr. Tanisha Rai and others. Thank you very much. Happy Diwali. Long live College of Allergy and Immunology. Thanks, everybody.
Thank you very much, Dr. Kathuria, for detailing your views about the polysensitization. Thank you very much.
Share.
And you are already aware that the award will be given in a special ceremony somewhere in Delhi afterwards.
Till then, we have to bear Dr. Dr. Kathuria.
No, he knows it.
I know it.
Thank you so much, sir. Thank you so much, Kathuria, sir. Yeah. Sir, now moving on to next session. Next session is the panel discussion on allergen immunotherapy. So I request Dr. Rajkumar sir, Dr. S.N. Gaur sir, Dr. M.K. Agarwal sir, Dr. Nagendra Prasad Komarla sir, Dr. V.K. Jain and Dr. Subin Jain sir to start the session.
Besides that, Dr. Rajendra Prasad and myself are also included later.
Okay, sir. Okay. Welcome you, sir. Welcome Rajendra Prasad sir and also Anand Singh sir.
Backdoor entry.
No.
Sir, over to you, sir.
Dr. Rajkumar.
Okay, good afternoon, everyone, and thank you so much. And now for 1 hour, we are going to just interact with each other, and the audience are also requested. If there are any questions, they can come in between, but I'll request that let us complete it because we are going to go in a phase manner. Initially, I thought it's 1 hour, 40 minutes. But later on yesterday, I came to know it's 1 hour panel discussion. And with me, we have Professor S.N. Gaur, Professor M.K. Agarwal, Professor Dr. Nagendra Prasad, Dr. A.B. Singh, Professor Rajendra Prasad, and Dr. Subir Jain. So,
and V.K. Jain.
Pardon?
V.K. Jain also.
V.K. Jain, A.B. Singh.
And Dr. Professor V.K. Jain. So, can we bring all these people on the screen now at one place if it is possible? Organizer, if it is possible, can you bring these 6-7 people together so that we can see each other also directly? If it's not, then fine. So what we are going to do in this 1 hour, basically, we'll start the journey from allergy, and then how to do the allergy testing, and then how to select the antigens, how to correlate it, and how to go for the immunotherapy, and what are the types of the immunotherapy we have, and which are the possible immunotherapies we have in India, and what is the future of the immunotherapy. So these are the important topics which we are going to touch upon. And I request all the panelists, because we have a limited time, all the panelists to be very precise and very short. And if anybody wants to just comment other panelists, they can comment it, but please do not do the repetition. That's my request. And I know these all stalwarts do not need any introduction, because already they have been introduced several times. So I'm not going to introduce, I'm going directly to the journey, basically starting from allergy to immunotherapy. So with that, the starting comment, I request Professor M.K. Agrawal to just in maybe 1 minute, he can just put across about what is allergy and what is the mechanism of allergy. Dr. Agrawal, sir.
Unmute, sir. Unmute, Dr. Agrawal.
Slide sharing?
No slides, sir. No, sir. Only talk.
Okay. Allergy, as we have discussed, the term was coined by von Pirke in 1906. And it says that it is the altered reaction of genetically predisposed individuals to a second or subsequent exposure to a particular allergen to which his body has already become sensitized previously. That means there are two phases. One is sensitization phase, where the antibody is produced, goes in circulation and binds to the mast cells of the target tissue. These substances are caused allergens when they cause allergic disorders. And whenever these cell-bound antibodies are exposed to the same antigen again on the mast cell of the target tissue, that leads to signal transduction and release of preformed and newly formed mediators, which results in clinical symptoms in the local tissue. If it is nasal mucosa, allergic rhinitis. If it is bronchial rhinitis, bronchial asthma, and skin, it is atopic dermatitis. That is allergy definition. And all those substances which cause allergy are known as allergens.
Okay, sir. I know basically after going through the definition and everything, everybody knows it's called Allah ki marji or something like that, but it's not like that. There is a scientific mechanism for the allergy, and there are signs and symptoms. Whenever there is allergy, it's very important that we must diagnose basically. And diagnosis plays very important role. And in the diagnosis, the history taking is a very, very important. So may I request Professor Rajendra Prasad to just pinpoint the important points while taking the history, and how do we interpret this history so that we go ahead for diagnosis of allergy.
Thank you, Professor Rajkumar. As you know, history in general, if you talk of any disease, is very important. But to my understanding, and I always say 85% of the diagnostic points and even therapeutic points, they come from a good history. Especially in allergy, when we are talking, it has its a very important role. Allergy, you know, as Dr. M.K. Agrawal has said, there are various allergic diseases which may be evident in patient enters in your clinic. But when we take history, I used to say it is etiological history. What are actually the factors, especially the allergic one, that which may be responsible in a particular patient? First, in the history, we try to know whether patient is suffering from allergic disease or not. If the allergic disease is usually, we suspect if the disease started from the childhood, if there are polysymptoms, means multiple systems are involved, if there are seasonal variation, if it is there, if there are geographical variation, and if the family history is there in a particular disease, then we may say, yes, patient has allergic background. Then we take history in a very depth and very detailed. I always say that different case sheets are there. You have to spend time and you have to elicit all other factors. What are the aggravating factor? What are the relieving factor? What time these symptoms occur? Which season these symptoms occur? Whether it is seasonal, perennial, or seasonal with perennial exacerbation. Everything will at least give some conclusion yes, our person, first history will conclude that yes, our person is having allergic background, and then history will also tell, because ultimately when you do a test, any test, always it is correlated with the history. Thank you, Dr. Rajkumar.
Yes, sir. History taking is very important, and I think that the two concepts are very important. Whether you have the problem in-house or you have the problem outside, whether the problem is seasonal variation is there. So in case the person says that they have the history of the problem exacerbation in-house, so that means you have to find out what are the allergens which are there in the house basically. So in this way, history plays very important role. And now basically depending upon which organ is involved, whether it's lung is involved, eye is involved, nose is involved, skin is involved, depending upon that, basically there may be some signs and symptoms. So may I request Professor Gaur to just express his view about the signs and symptoms of the allergic disorders.
Now, first of all, we should understand that allergy is a non-infective inflammation. It's a non-infective, that's important, but it is inflammation. We know the signs of inflammation, what are there. Now, where it will produce the symptoms, that depends. What has been already said that, okay, this person is genetically predetermined to have the allergic positivity or IgE in that patient, so it becomes positive. So that is recessive. But the target organ which is going to be affected is also predetermined. So if the target organ and what the inflammation produces, it produces bronchospasm, it produces localized swelling, increase the muscle tissue and spasm, increase the goblet cell in number and the secretions, increase the cellular diabetes. Diabetes means increased permeability of the cells, increased vascular congestion, and there is increased mucus cells. So all these symptoms which have been produced by allergic inflammation, if you put in the system, and which system is target organ, like respiratory system, skin, or whatever Dr. Rajkumar has said. So in those, you can have the presentation, like say asthma in respiratory system, rhinitis, you can have allergic rhinitis, there will be secretions and there will be itching and running of nose. Skin, you can have urticaria. GIT also, you have got a spasmodic colon. Now eye also, you got irritation and secretions. Respiratory system is the best example for that, because he's got all these systems. The muscles are there, the secretions are there, swelling is there, and there is increased mucus secretion and increased vascular permeability. So depending upon the target organ, which already been decided, patient can have the presentation. And the examination and this thing of respiratory system, I think you are all aware of how to examine the asthma, how to see the urticaria, and how to see other diseases.
Okay, thank you, Professor Gaur, sir. And basically after that, whenever you take the history, then examination, and after that, basically you try to do the diagnostic tests, and we have the diagnostic tests in the form of in vivo and in vitro. I request Dr. Nagendra Prasad to just give his views about the various in vivo tests which are there, and maybe how they are done, maybe some 1 or 2 points.
Yeah.
Dr.
Thank
Nagendra.
you, Dr. Rajkumar. You see, once the clinically examined and confirmed the diagnosis with a history and clinical examination, then you will come with the objective measures with the diagnosis in vivo and vitro. In vivo is more crucial rather than the in vitro. In vivo, we have two tests. One is called skin prick test, another is the intradermal test. But in practice, the skin prick test is more gold standard than the. And the second one is challenge test. The challenge test is ocular challenge test, nasal challenge test. And can you hear me now?
Yeah, fine.
Yeah. So challenge test is another important platform where this allergen, specific allergen is challenged in the particular organ. maybe in the eye, we call it as conjunctival challenge test, nasal challenge test, and a bronchial challenge test. Bronchial challenge test is not advisable. It is only for research purpose, and conjunctival and nasal can be taken into the consideration. Coming out of the in vitro test, we call it as specific IgE test, and different allergens are done in the aero allergens as well as the food allergens are done. And there are open system and closed systems. Open system is more crucial and more lucrative for Indian setup because all the closed systems are done from the imported allergens with having a common allergens like house dust mite, fungal spores, and a grass pollens. So open challenge with these in vitro test are not a viable or not a significant test when compared to the skin prick test. Skin prick test is more gold standard for final diagnosis. Over to Dr. Rajkumar.
Yeah, basically these tests are done for the diagnostic purpose, and when we do the test, basically it's very important what test we need to do. And may I request Dr. Subir Jain to put his view on in vitro test, and if you compare in vivo and in vitro test, which are the tests which are very important according to you, Dr. Jain, Subir Jain?
Thank you, sir. Thank you so much. In vivo and in vitro test. As sir just explained about in vitro test, in vivo test, specific tests are there for the allergens. Allergen specific IgE, that is one of the most important tests. And to start with total serum IgE, then allergen specific IgE, and then IgG1, IgG4 to know the response of the immunotherapy. As you categorically asked me about the comparison, still all over the world, gold standard is the skin prick test. That is the only thing, especially in our scenario, in our area. First and the foremost thing, history as already discussed, and then to correlate it with the skin prick test. But in certain cases where there is a confusion and we want a supporting evidence, we can go ahead with a specific test like allergen specific IgE, that is there. So this way we can go ahead. Over to Dr. Rajkumar, sir.
Okay. Dr. Agrawal, if you want to comment anything, Dr. A.B. Singh, because I just want to spend 1 minute more on this, because always there is a confusion what test is preferred in the market. Many tests are coming, a specific IgE, you send the 5 ml of the blood, 1 ml of the blood, get a battery of the test, and after that also the immunotherapy is being practiced. So these are the practical facts which is going on. So let us spend few minutes and let us have the comments from the stalwarts. I will come to Dr. God also. Let us have Dr. M.K. Agrawal, then A.B. Singh, and then Dr. God, please.
The gold standard for clinical sensitivity of the patient remains skin prick test. And as you have very rightly said, that there is lots of confusion created by the commercial companies by promoting their product in such a way that if you tell lies 100 times, probably people start believing that it is true. When it comes to clinical sensitivity of the person, there is no substitute of skin prick test. And if there is only in special situations, we do blood test also, in vitro test, either for confirming it or maybe in certain situations where the skin test is not possible. So basically, when it comes to clinical sensitivity, the polysensitization and polyallergic and all these things which come, they are all taken care of by skin prick test. So in my opinion, skin prick test remains the gold standard. It is internationally recognized and everybody agrees to that, except the commercial companies.
Dr. A.B. Singh, please.
Thank you, Dr. Rajkumar. First of all, I would like to add a little bit what Dr. Nagendra said about the in vivo test. He probably did not mention about the food allergy in vivo test. There, I would like to advise that besides the oral food challenge and double-blind food challenge test, are also in vivo tests which are available, particularly while assessing allergenic properties of the foods. Due to the practice in the clinical practice, probably oral food challenge is feasible and can be done. But double-blind placebo food challenge is something when you are going to prove any new allergen or new food or something to establish its allergenicity. At that time, probably it is required. So it is a research tool, basically. So besides this, as so far as standard prick tests are concerned, already there is a unanimous consensus that skin prick test is still the gold standard for assessing the IgE antibodies in this era. Second thing is in vitro test. Already Dr. Agarwal has pointed out. This is being, I am very blunt, it is being misused because a distant practice is going on. Just collect a 5 ml of blood or 2 ml of blood, and after 1 week, 10 days, the reports come there, and they don't know what is the shelf life of this, how they have been transported. And based on even the distant practice, even without having, we are emphasizing good clinical history, correlate with the season, correlate with the atopic status of the, nothing is there in those blood samples. Those sitting in the rural areas, the smaller places, just advertised in the books, very, very large books, in the newspapers and media, and people get it done. But they do not have even interpretation of the results that come from the laboratory.
So single sentence conclusion is skin prick test remains the gold standard, and immunotherapy done on the basis of blood report is completely non-scientific and should not be done.
Clinical background of the patient. I think that will make the things clear.
Okay, Dr. God, any comments? Just quick comments, Dr. God, sir.
Yeah, very small. I think SPT, everybody said, we know it is a gold standard. But regarding the vitro test, there is a controversy which is economically motivated. I'm not saying the word, but I think I mean the same.
Okay, Dr. Prasad, you want? Yeah,
Yes,
sorry.
yes, I wanted to say that.
Dr. Rajkumar, let me complete.
Sir, yes, Dr. God, let Dr. God complete.
Yeah, just half a minute. I think the total IG has been now only used for follow-up patients. Specific IG can be used for diagnosis, but again, I am saying it is a supportive investigation along with SPT. Alone, positivity cannot be taken as allergic, and the immunotherapy started, the test is done on the blood, and you are starting immunotherapy with the antigens. This is totally wrong.
Dr. Prasad, if you want to have a comment, both the Prasad.
Yes, I agree with Dr. Gaur and other panelists that this is misused. To be very blunt, it is misused, and people are exploited, patients are exploited, even doctors are exploited. The lack of information and lack of knowledge. This should be discouraged.
Yeah, Dr. Prasad, Nagendra Prasad, any comment?
Usually the doctors who are not in the field of allergy or not known about the allergy field, and the public always feel it that by doing a blood test, they will be knowing much of the allergens which is listed in the pamphlets. One. Number two, the significance out of these tests, they are not known. I think we had to more educate the doctors who are not knowing about the allergy test, specific IgE, and also we had to educate the patients, which is very crucial, rather than condemning a pathologist or a laboratories which they are promoting the in vitro test.
Okay,
May I come in just for a few seconds, Dr. Rajkumar? Few seconds. In vitro test, whatever blood tests are going on, major constraint, medical and scientific constraint is most of the allergens, particularly the aeroallergens, they are not there in many of the plant material, pollen grains and dust stuff. They are not available. Even the food allergens, they are mostly confined to big 8, that is peanut and other things. But what about the legumes? What about the other foods which the general Indian consume? So this is another drawback of the blood test. We don't have the allergens of the relevant allergens from the Indian origin.
Yes, one sentence I would like to add. If Dr. Rajkumar permit me, I would like to add one sentence. The in vivo test for total IgE or specific IgE can be supportive, as Dr. God said, but in a special situation like diagnostic value with respect to ABPA, that can be helpful there. So therefore, it is only helpful in selected cases. Otherwise, it is completely non-scientific to do immunotherapy based on in vivo tests.
Yeah. Dr. Jain wanted to say something. Yeah, Dr. Jain, sir.
Yeah, I am absolutely agreed with what has been said, but the gold standard, gold is not 100% pure. Even it has got some lacuna. So I say,
voice is lost.
Absolutely say it is always 100%, but there are certain conditions where there are contraindication of skin test. In those cases, we can think it can be less than 0.1% also. So I also support, I also sometimes recommend in a very specific cases, especially patient of corticosteroid, the very bad pathological condition of skin, patient with HIV, pregnancy, these are other things where the patient really need, we can think. So I said, gold is not 100%. You cannot say 100%.
Okay, so now I just summarize. The gold standard is the skin prick test, but in the certain conditions where you are not able to do the skin prick test, you can go ahead for the specific IG. That also you need to correlate. In those cases only you can do. But the consensus is very clear. I want to give the participants very clear message. Please directly don't prescribe that, go to this lab and do the test, get the battery of the test 550, 60, and then you tell that you are allergic to this tomato or something like that.
Absolutely agree.
Just once again, that the 3 days back, the person was taking the tomato does not have any problem. And after seeing the test, the person stops that also. So this should be discouraged basically. And that's the consensus of this panel. So we move on to this. So we have taken the history, then we have gone to clinical examination, then we have thought of the allergy testing and everything. So we go for the skin prick test, which is the golden standard for the diagnosis of the allergy. So Dr. A.B. Singh, what are the indications and the contraindications of the skin prick test?
Dr. Jain has initiated this course. I don't call it a contraindication. I call it constraints in the...
Okay, constraints.
Allergy test.
Please, yeah.
Yeah. As so far as skin prick test, as we have been discussing, there are certain situations when patient can't be off the medicines actually. At that time, you require, the IgE test, in vitro test. Similarly, under certain, when there is a demographism, you don't have the space to test properly. At that time, blood test can be substituted for the skin prick test. That's all. There's other situations are also there, but and as so far as in vitro tests are concerned, not the constraints again, the limited number of allergens which are relevant to the Western world, even the food allergens, many of them are relevant to us, but Indian allergens, particularly major allergens, maybe pollen, molds, or the insects, they are not available for specific IG testing in that system.
Okay, from that we go basically, Dr. V.K. Jain, just in a short, basically, you just tell the participants how do you perform the skin prick test and how do you interpret basically in a short session.
Yesterday I told about this, but however here in brief I will be telling, as we said, the skin prick test is most commonly performed gold standard, which can be performed in OPD level or the clinic. Very simple, very feasible, very sensitive, and very reliable. Now the site, we generally prefer the polar aspect of arm. However, sometimes we can prefer the lateral aspect of forearm and the back also, especially in children and infants. And the distance generally we keep it from one test to other is minimum 3 to 4 centimeter, and there must be a distance from the wrist crease at least 3 centimeter, antecubital fossa at least 5 centimeter. We must use the histamine as a positive control of 1:100 concentration, and we can use the allergen extract, and we can also use the buffercinine as a negative control, and we can use the specific allergen to whom we want to test is a 50% glycerol allergen in the strength of 1:10 or 1:20. There are two techniques, but first we have to put the 1 drop of the extract over the area we wanted to sit, the test, and they must be a distance of minimum 3 centimeter. And then whenever we should always mark with the pen of one allergen, and it should be mentioned the name also. And there are two techniques. One is the standard vertical technique, and second is the horizontal technique, where we put the needle about the 40 to 60 degree, and the vertical is a standard method. Here we use the standard lancet or the hypodermic needle, and we should always penetrate by putting the drop. Then we can put directly, we can go vertically in the epidermis of the skin, and we can just have a gentle pressure, and then rapid and gentle. And the other technique is the horizontal, where we can inject the needle through 40 degree or 60 degree. That's a horizontal technique, modified. We observe the wheel as well as the arrhythmia, but for the positivity or reactivity, we considered usually the wheel. And this cut point is the 3 meter or more. 3 or more is considered to be positive, and less than 2 is considered, less than 3 is considered to be negative, maybe 1 plus or plus minus, whatever. And grading interpretation is very important. We should do the reading after 15 to 20 minutes, and the histamine reaction will occur within 10 minutes. And the grading is, though in the Western countries, they are not following the grading, but in our country, our association is recommending that we should have always grading, and it depends upon the size of the wheel, and we are always comparing with the positive histamine. And if the wheel size is between 3 to 5 millimeter, we say it's a definite 1 plus grading, then 2 plus grading. They all are definite positive, and 2 plus grading we consider between 6 to, the 3 to 5 is 1 plus, 6 to 8 is 2 plus, and 3 plus is more than 9 degree. And we also consider the pseudopodias, their numbers to be mentioned. And these are the grading which we are practically using in our practice.
Friends, these are also given in the college has came out the guidelines also, and these are already given in the guidelines of allergy and immunotherapy. And when we are doing the tests and everything, we should be very careful that we in our setup, basically we should have a good setup for the allergies testing. There are many equipments which need to be kept. Your preparation of the skin testing room is very important. Preparation of the patient is also very important, so that you must see that the patient has not taken any sedative, any other medications which are contraindicated before the testing and everything. And when we do the test, we should be very careful when we do the test. And there are many complications which may occur. Professor Rajendra Prasad sir, what are the complications and how we manage, and how should we prepare to manage these complications?
Thank you, Professor Rajkumar. As we have reached a consensus that skin prick test is a nearly a gold standard test, no doubt about it. But then as far as complications are concerned, I must say in the beginning that SPT is supposed to be a very safe test. In majority, in most of the patient, what I have seen in last 45 years, there are few minor reactions can happen. Especially but the side effects, one has to be take it very positively that it's a rare phenomena. But rare means that it will not happen. It may happen in some of the patients. And usually they may include allergic reactions. They may include exacerbation of asthma even if you are doing. And they may have an anaphylactic shock. We have also seen vasovagal attack during the testing. And then fatality is the rarest of the rare thing. At least in 45 years, my own practice, I have not seen any, but in literature, very rarely, even fatalities has been reported. So, Dr. Rajkumar, you said that your room has to be equipped with all the things. Although it's a safe, but you don't know in which patient it is going to happen. So you need oxygen, you need BP instrument, you need all the resuscitative measures, you need adrenaline, everything. If it happens, then you have to act swiftly and you have to prevent it. But in the end, what I wanted to say, I wanted to share with all the participants that skin prick test is really a safe test, but that doesn't deter you to take the precautions. You have to take the precautions. If anything happens, you have to manage accordingly. Thank you, Dr. Rajkumar.
Yeah, thank
May
you,
I,
sir.
Dr. Rajkumar, may I add something?
Yeah, please.
You permit me?
Please, please.
Yes. Whatever said by Doctor, I absolutely agreed by me and maybe also by the other panelists. So what is most important, which we are seeing out of 10, 2 in girls and 1 in the gents, the neurogenic shock, a fear of the injections. You have to explain everything to the patient. It's not dangerous. It may come. Whenever you are observing, always talk to the patient and observe whether he is going to develop in the neuro. Suddenly there is a bradycardia and then followed by the tachycardia. So we have to always observe, because this is a sudden acute onset bradycardia neurogenic shock, which should always be care. Other we will not be taken in the right time. Otherwise we will be losing the patient. This is very not frequently other, but it at least in 10 to 20 for my patients are developing these things, and I am very aware of these things, and it is a simple treatment. Just ask raise the leg in a patient of neurogenic shock. By real shock, patient will be having tachycardia followed by the bradycardia. Just reverse switch. So you have to differentiate. Just you put the finger over the radial pulse, you find sudden disappearance. Patient is unable to talk, suddenly closing the eyes and not active at all. So this has to be observed only. The message should go to our.
Okay, sir. It's very important. I understand it's very important that you prepare the patient also. That's very also important.
If you permit me, Dr. Rajkumar, this being a very important point, because this is life-saving situation, life-threatening situation which can come in patients of when they are skin tested. We started testing patients in 1965. And at that time, we were testing with intradermal technique. And to start with, we were using 1:50 allergen X-ray. So we had many situations where patient got anaphylactic reaction. Now, even prick test, even after my retirement in Metro Hospital, we have also found 2-3 patients who had mild anaphylactic reaction. So the only thing required there is that a pre-filled syringe of adrenaline has to be kept ready. It should not be filled at that time when the patient is getting anaphylaxis. It is a very cheap, we fill up every day, we throw it every day, but whenever it is needed, it is needed. So pre-filled 0.3 ml of adrenaline is number 1.
Yeah.
Number 2 is we should not be bothered about I may be corrected by any one of the panelists that whether the person is getting vasovagal or an anaphylactic reaction. You don't have to bother. Treatment remains the same. Adrenaline. And adrenaline may create some sort of sardard, but it will not kill the patient. It will save the patient, whether it is vasovagal or it is anaphylactic reaction. So we should not try to think over bradycardia followed by tachycardia or tachycardia followed by bradycardia. If the patient is getting problem, give him injection adrenaline.
Agrawal, I am little bit different as a clinician. These are the clinical points, very important. And the patient of anaphylaxis will have a other symptom. Patient of neurogenic shock will not have any laryngeal spasm, bronchospasm, or unable to speak.
Okay.
So
I come in between. So it's very important that when you do the test, basically you should be prepared for the complications.
Yes.
And your skin testing room should be ready with the emergency tray. And basically what I feel that each and every patients, when you are going to do the test and everything, you must show them the video of how the test is being done, how many antigens are to be injected, how many needles are to be given, and all those things. So that reassurance is very important before the person goes to the testing and everything. Your adrenaline pre-filled should be there. If EpiPen is there, EpiPen may be there. So everything should be there. But this is also important that you should be able to differentiate between the vasovagal shock and anaphylaxis, because these are the two different things. And accordingly, you need to assure or you need to treat the patients. With that, we move to the next question, because many times, many times the controversy comes for what is the age of the patient when we should do the allergy testing. Many times, many questions are being asked. Is there any age limit? And so what is the age limit means? And till what age we can give we can test do the allergy testing, and of course give the immunotherapy. So there are two questions which are interlinked. One is when we can do the test, what is the earliest age when you can do the test and give the immunotherapy, and the next three subsequent is the maximum is when we can do the test and give the immunotherapy. Dr. God has the vast experience. He has seen the child also. He has seen the old patient also, adult also. So Dr. God, what is your view on this?
I think very rightly said. Patient comes to you, he has got some symptoms, then you have to decide whether you do the SPT or not. Now, as far as the patient, if you are considering the child for doing sublingual immunotherapy, at the age of 2 years and above, you can do the skin test. If you are considering other things, you can do in 2 years, but because the immunotherapy starts at 5 years and other subcutaneous immunotherapy. So 2 to 5 years, you can do the skin test. But upper age, previously we were having 45 or 50 years of age. Now, internationally, it has been accepted that at any age you can do the skin testing, and at any age you can start the upper age. Any age you can start the immunotherapy in these patients. So 2 to 4 years minimum, 2 to 5 years, and any age above you can do the testing. And what has been said in the before, I think children especially, I want to add one sentence in the last discussion, especially in children, if you are doing the skin testing, suppose the children see patient coming out with so many points written, number 1, 2, 3, 4, with the pen even, and he sees so many injections, he just runs away. What Raj Kumar said, I think very nicely, everything has to be explained in a video. Then you show him the patient who has skin testing is done, tell him to explain the child that, okay, this is okay, nothing happened. So these consolation is very important, because vasovagal shock is very, very, very common in the skin test if you don't explain. So counsel the patient. So as far as the age is concerned, I already replied.
Dr. Subir Jain, what is your comment on that age about the doing the test and giving the immunotherapy? Dr. Subir Jain.
As sir pointed out, 2 years and above, that's absolutely right. I agree with him. Another point, upper age limit, there is absolutely no age limit for that, for skin prick test. But for immunotherapy, yes, definitely. We don't want to give immunotherapy above age of 65, 70. One point, at this point of time, would like to categorically state that we had good amount of discussion on vasovagal shock and neurogenic shock. To avoid vasovagal shock, what I have learned, I always do skin prick test patient in the lying down position, and I don't allow patient to see the skin pricks. Nowadays, as we do with 1 millimeter lancet, it's absolutely painless, but the practice teaches us, every patient teaches us, and this has happened. There was a boy of around 12 years age. Previously, I used to do skin prick test in a sitting position. He was just seeing continuously towards the needle. There was no blood at all, but even then he developed vasovagal. Immediately, I had to put him on my trolley and manage him. But since then, each and every patient of skin prick test should be lying on the couch, not should be done on sitting position. Patient should not be allowed to see the pricks. That is my submission. Thank you, sir.
Yeah, well taken, Dr. Subir Jain. Another question I just wanted to ask you, Dr. Subir. How many allergens do you do at your practice? How many total allergens while doing the test?
I started 166 initially, then looking towards the sensitivity pattern of this area, Madhya Pradesh area, I selected the allergens, and now it's with 127 allergens. And I go in details with the history, and whatever is relevant and significant with that history, I do that only. But practically it comes to around 80, 90, 80, 90.
Okay, great. So the message is very clear that although we are also doing around 60 or something like that in Vallabhbhai Patel Chess Institute, but that is for our research purpose and everything. But you should restrict the minimum. You should restrict to the allergens and see the geographical area, which are the allergens which are prevalent in particular area. If you are in north, south, east, west, wherever you are, and then you should have a good touch with the botanical department, or you should know the flora and fauna of this area, and accordingly you should select those allergens for doing the allergy testing. So setting of your allergy center is very important for each patient basically. So allergens has to be prepared beforehand while doing that. Dr. A.B. Singh, how do you choose these antigens? Because you have a long experience about the botanical affairs and everything. And is there any calendar or guidelines? And because with your experience, you should come out very clear cut. These are the allergens should be practiced in this area, in this area, and this area. So comments in just 1 minute because you have sort of time. Yeah.
Thank you, Dr. Rajkumar. You have already given a brief introduction. Keep a watch on your local fauna and flora. So in any area, actually, as we know, I mean, the fauna and flora of different parts of the country is quite variable. Something, whatever is existing in the Himalayan region is altogether different. Plants and the flowers and the trees of the southern part of the country are different than what we find in other. So basic idea is to find out in your geographical region what are the important, preferably the airborne allergens. If there is no list or no calendar, no literature available about their concentration, seasonality, and duration, then probably you go by the botanical surveys. And whatever presence in the field actually there, that has to be kept in mind. So
what I want to ask Dr. Subir,
the allergens as far pollen are concerned, mostly the airborne ones, not necessarily the others will not cause there is a very close contact with that particular plant or the tree. So the idea is to look for if availability is there, either the books or the literature or the calendars of your state, your district is available. That will be a help in selecting the appropriate allergens for testing purposes.
Yeah, Dr. God wanted to say something. Yeah, Dr. God, sir.
I want to ask Dr. Subir, you are doing 66 tests, even in children?
No, yes, sir. Yes, sir.
So you do the 66 in one sitting or?
No. He's saying 18, 19, not 66, sir. 18 or 19.
80, 90.
I'm asking
80, 90. Yes, sir. I do 80, 90. And even yesterday I did a test and there was number 1 and number 2, the two kinds of mics were overlapping. There was a big induration on number 1 and number 2, that is my hernia and tetanus sinus. I repeated it on the other side and took the readings.
So
many times, sir, so many times it has helped that whenever there is it is not possible to detect which allergens are responsible for allergy by the patient himself. Then there comes the role of skin prick test, and we are going to help them out this way.
That is right. I am saying it. Yeah.
Dr. Subir Jain is also testing routinely food allergens.
Why I'm asking a 2-year child, you are doing 80 tests.
Yes, sir. On both the hands.
both the hands cannot have it. You have to go to the back. Why I'm saying
yeah,
back?
if needed. Yes, sir.
My emphasis is that you can use the back of the patient, especially.
Correct, sir. Correct, sir.
That is
Correct,
what
sir.
I want to emphasize and tell the audience, because the child 88 or whatever number you have selected out of the area you are staying, it's not possible in two arms of the child. So don't go anywhere. Don't go to abdomen or
Even
leg
if
or
it is
here.
possible, there is no need for that.
Dr. Rajkumar, may I come in for a moment?
Yeah, please, please.
What doctor, I always say the number of antigens being tested should depend upon the area, no doubt about it, but numbers should be restricted depending upon the patient condition, depending upon the fauna and flora, one thing. And second thing, apart from the pollen calendar, I always say, if you want to do a practice of allergy, you should recognize these, especially the pollens around you. If you move and see, you open your eyes, you will recognize yourself that this is the tree and this is this. So depending on that, you may reduce the number of tests.
Okay, to summarize, basically now we have gone into the history, then we have done the test and everything, and I agree that the allergens, number of the allergens should be restricted and should be made as the flora, fauna and the botanical status of that particular area, and we do the test. So we have done the test also, we have interpreted also, and after interpreting, we have correlated with the history also. So after correlating the history, whichever allergens are avoidable, we ask the patient to avoid that allergen. And if it is not avoidable and you want to start with the immunotherapy and everything, so we go ahead with the immunotherapy. So we have, I think, 7-8 minutes. So we'll try to finish in 7-8 minutes. So Professor Agrawal, what is actually immunotherapy and how does it work?
Okay, immunotherapy is inducing.
One of the participants like Ari Thomas wants to ask some questions. Is it open?
Later on.
Later on, I'll finish and I'll request the organizers to give me five minutes for the other people to ask. Yeah, please,
Okay,
Dr. Agrawal.
Immunotherapy is the procedure of inducing tolerance to allergen-specific tolerance in patient. For this purpose, the causative allergens, mixture of that, are injected from a very low concentration to gradually increasing doses till a maximum tolerated dose is reached. And this procedure takes at least, if it is effective in 1 year, then we continue for 2 more years at least, so that it is the number of injections keep on decreasing over the time and the patient gets allergen-specific tolerance to immunotherapy.
Okay. Yeah, I'll come. So we give the allergen immunotherapy, and we have the different kind of the immunotherapy which are usually given. One is the SCIT and the SLIT. So these are the two which are given, and the other new immunotherapy are there. So Dr. God sir, what are the pros and the cons of SCIT basically, and when you decide to give SCIT immunotherapy?
When the patient is positive, giving positive history, and that particular antigen is present in the environment, SPT is positive, then you decide that, okay, you should give immunotherapy. Now, what are the pros and cons? So coming to pros, allergen immunotherapy is very effective. I don't say effective, it's very effective. This is now world over, people know it, because it modifies the natural history of disease. And it's cost effective. After some time, initially you are taking both the things. It's an additional factor to the medicine, but afterwards medicines are withdrawn. So it is cost effective after 2-3 years. The other thing is that the effect lasts even after the withdrawal of immunotherapy for many years. And there is a remarkable result in few of the patients, as I've given my lecture also, venom therapy or very highly positive patient or single antigen is much better. It prevents the development of asthma in patient who are rhinitis. So the progression of the disease, progression for the allergy is also been affected. Now coming to the cons of this thing is it's a prolonged period. It takes long time. It is a very slow process. And second is you should watch for side effects. Now, side effects has to be explained like anaphylaxis. You give in writing or explain to the parents, explain to the friends or the wife or the spouse, these patients, so that, okay, this happens, stop injections. The stop word, first word should be stop injection. Don't without consulting your doctor, don't start it again. That is number one. Number two is that first injection should always be taken in clinic. If if the patient says, no, I will do it, no, don't allow this. Ask him to take first injection in the clinic and wait for 30 minutes. And that is one thing which should be explained to the patient, because these things will happen. Now it is twice a week, it will become once a month afterwards. That all these things should be explained. Now, other things to be explained to the patient is not 100%. That is a con. Tell him that it is not 100%, but those who are getting effect, they are getting very good effect, and it will take at least 1 year to see the effect. Now, what has been said, overuse, misuse, and I think underused. Yesterday, Dr. Agarwal said these three things are the main culprit who is giving a bad name to immunotherapy. Suppose one person or two persons are being genuinely treated with immunotherapy and 8 of them has not been properly treated, then on an average, the result becomes bad. So that is how the people who are thinking about, they are meeting the 8 of them, any one of them out of the 8, and say, no, it's not effective. So the thing is that this is the misuse, overuse, or underuse. And people don't diagnose. No, there will be so many injections. I don't go for testing and this thing. So these things make the people aware, make the doctors aware first, and make the people aware that this is this and this is going to benefit in this way. So this is one thing that I think, I'm not saying cons, but I am saying that these cons should be taken care of by like this. Yes, Dr. Rajkumar. Hello.
Dr. Rajkumar.
Hello.
Oh, he seems to have some net problem. He is not there.
Yeah, there's some problem.
Okay, there is a next question regarding the. Shall I proceed?
Yes, you can proceed, Dr. Dag. Meantime, there is no communication.
Dr. Rajkumar, yeah.
Dr.
You
Rajkumar?
can join later on. Next question, Dr. Nagendra.
Yeah,
Okay.
on the same topics. You got next question.
After this kit, this alternative is the slit. The slit is emerged after the skit. The reason behind is skit, no doubt, as Dr. Gaur said, it is wonderfully works, and immunotherapy has got a significance, and it has got a maximum index of therapeutic value. But there are some accidents which has happened even in India and abroad. There are some anaphylaxis and death were concerned. And because of that events, then alternative routes were emerged. And the routes which is successfully is done right now is only sublingual immunotherapy. The difference between the sublingual and subcutaneous is the route of administration. And the concentration of allergens definitely varies because of the routes. And thirdly, the subcutaneous immunotherapy has got a build-up phase and a maintenance phase. Build-up phase, minimum 6 weeks to go to the maximum of 3 months. And here you can start with a build-up maintenance dose as a daily dose, which is calculated according to the maintenance dose, what is fixed in the particular allergen. Secondly, there are different forms are available in the form of drops and tablets and the strips. In the form of drops, what happens is yes, sir. Dr. Rajkumar?
Yeah, Rajkumar?
Rajkumar, we have taken the next issue. He is discussing about
okay.
Okay. Sublingual we have taken.
Yeah, no problem. Quickly, Dr. Nagendra Prasad, quickly, please.
Yes, sir. So coming on to the drops of the slit, which is in a dilute liquid form, which is unstable for a long time, which cannot be kept. And a delivery will be a variable because of the size of the drop, which may be a more or it may be a less. If you are giving a one month dose, it may finish within 15 days or it may be extended for 2 months. So the uniform dose is not there. So there is a side effect, adverse observations. And secondly, coming out of the tablets and strip form, definitely it has got a big role, and only the standard allergens and the quantity of the allergens what you are putting should be very, very optimum. Then only it works. And coming out to the long-term use with this, the adherence to the patient, adherence to the therapy with the patient is, whether it is skit or escalate, is by counseling. The more you counsel it, then only you can accept it. Otherwise, reject it, because these patients always, they use it for a short period of 6 months to 9 months. Once the symptoms are completely total free, then they stop it immediately, and again they will come back after 6 months to 9 months. So that is the only setback in immunotherapy with the skit or escalate. Over to Rajkumar.
Yeah, we have the skit and the slit. Doctor,
Yes.
may I ask Dr. Agrawal and Dr. A.B. Singh to comment, and Dr. God also, what is the status of skit and slit in our country? Dr. Agrawal first, then A.B. Singh, and then Dr. God.
The sublingual immunotherapy has been recommended by the International Committee on Quality Control of Allergens to the Drug Controller General of India. However, it has not yet been approved by the Drug Controller General of India. And number one, that is number one, which is a limitation. Number two is that we have got a limited number of allergens. Whatever sublingual immunotherapy reagents are available in our country for our allergens is very limited. So in case of sublingual immunotherapy, the limitation remains the availability of the whole spectrum of causative clinically important allergens in sublingual form is not available, number one. Number two, custom-made combination of allergens as is possible in subcutaneous immunotherapy is not available in subcutaneous immunotherapy. Sublingual immunotherapy with single allergen, house dust mite, can be probably considered in patient, but when it comes to multiple polysensitized patients, sublingual immunotherapy has got limitation of non-availability of reagents. Dr.
Okay, Dr. God, sir.
I think, yes, subcutaneous immunotherapy has been established, well established for over 50 years. So there is no doubt about that. Sublingual immunotherapy, has what Dr. Agrawal says very rightly, has not been approved by drug controller. Now the objection of drug controller was that there is no evidence, Indian evidence, of these studies. Now there are two, three papers have come from India, and I think one came last week also.
From Srinagar.
Yeah, from Srinagar, yeah. So all these papers will be submitted to drug controller, and probably they will agree. But the second point still remains, because there are very limited number of antigens which are available with sublingual immunotherapy, and the mixing of antigen is also not been reported or not been recommended in sublingual immunotherapy. Single antigen, yes, it has been recommended, but provided the controller give the permission. Now the permission is only for doing research.
Dr. A.B. Singh.
One comment on this.
I agree with both the panelists. Only thing I would like to mention here, the unethical practice of sublingual immunotherapy use by the pharma industries and by the physicians, because they are supplied from the diagnostic allergens as a sort of sublingual immunotherapy allergens, which 80% of the physicians are very well aware. They never supply pharma industries as an immunotherapy vial in doses or concentrations. They simply write the concentration. 1 in 10, 50% glycinated buffer saline extract. So
And
these are something. So long the government is not approving proper guidelines, proper procedures, probably you should stick to the guidelines or the regulations and try to avoid the sublingual immunotherapy in general. Now, since 2 or 3 more papers have come, and Patel Trust itself can submit its own roadmap by doing a pilot project study that will make, the regulatory agencies to get it formally approved, so that the pharma industries can apply and get the proper license.
Any comment, Dr. Subir Jain? Any comment from your side?
May I comment, Dr. Rajkumar?
I got
a comments. Yeah.
Please, I will come to you also. Dr. Subir Jain, then Dr. V.K. Jain, then Dr. Nagendra Prasad.
Dr. A.B. Singh sir, Dr. A.B. Singh sir has just said that 2 or 3 papers have arrived. I got a study of 510 patients who were on sublingual immunotherapy and got very good results. They were on sublingual immunotherapy for more than 36 months. And yes, definitely I'll send
it is
that
not
study
accepted by the government. Your personal experiences and observations are not considered to be a
Publish it.
study.
Publish it.
Dr. A.B. Singh,
Yeah.
let him complete first. Let him complete. Let him complete, please. Hai na?
Yes, definitely I'll publish it. That has been accepted by Asia Pacific Congress of Allergy, Asthma, Immunology.
As a
And
presentation,
yes,
presentation papers are not accepted. I mean, this is what the misnomer is there.
I'll present it. I'll present it under your guideline. I'll present it under your guideline. And yes, that will be accepted. And yes, that will be a big support for the sublingual immunotherapy.
Okay,
Over to
Dr.
Dr. Rajkumar.
Yeah, Dr. Subir Jain, the question only I just want, the indication, the effectiveness and everything, nobody is doubting about that. There is absolutely no problem on that. From where do you get the antigen? That's the question basically.
That is the question.
I get antigens from Allcure Pharma. Since day one, I'm getting Dr. A.B. Singh sir is there. He knows it, everything.
That's how I mean, I point out. That's how I point out.
Sir, one second. Let me complete. You get the antigen from Allcure. There is no problem getting the antigen. So is Allcure, I also want to start basically. Is Allcure giving the sublingual antigen for the patients? Yes and no. That's all I want to start.
No.
Yes.
They give for the sublingual.
Not for sublingual.
Yes, sir.
Yes.
Okay. So
They don't have
the
any
people
approval.
who are attached to, maybe the people who are advisor or attached to the Allcure should listen that yes, they are giving. So let us stop this point here only. Dr. Jain wants to give any comment. VK Jain.
Yes, we know that the efficacy wise and whatever is said, it is equally good and bad. But the point is that it is not recommended in our country at all not to use unless because it's unethical. It's not. It's somebody goes in the court, then what will be who will give the answer? But one thing, no doubt, the facility is convenient, better for children, better tolerance, easily acceptable, everything merits. But when I was reading yesterday and meta-analysis published in Allergy Journal in 2017, they say acute exacerbation is not reduced in the select, but there is a reduce of exacerbation in the skit. So this is one of the important limitation with the slit. This is another which I was reading. And this is very beautiful thing that exacerbation is not significantly reduced in the slit. Remember, this is
Dr. Rajkumar, one line.
Dr. Jain. Yeah. Dr. Nagendra Prasad, quick 30 seconds only if you want to do anything. Yeah.
You see, the slit approved for particular allergens in the world from US FDA and European Medical Agency is only for a house dust mite.
Dr. Nagendra Prasad, please listen to me.
Yes, sir. Tell me, sir.
There is no problem in the efficacy of the slit. Absolutely no problem. Efficacy.
No, I am not telling about the efficacy. No. I am telling about the availability of the slit in the world. Please. Is only two. There is only house dust mite and a pollen which has been approved by the US FDA as well as European Medical Agency. Not all other allergens what is used in this kit. That is one. Number two, the slit is what we are using in our own lab is approved by the Karnataka Medical Karnataka Pharmacy Director, and which is approved. Which once it is approved for all the population in India. So that means it is an approval agency. It is even the skit is not approved. Where is approval for the skit? So if that is the case, then you have to logically think what is approved, what is not approved. What is approved, then how is the application has to be done?
Dr. Nagendra, this is a wrong statement that skit is not approved. Actually, this has been approved 40 years back.
If it is a wrong, please let me know. Definitely, I will withdraw my statement, sir.
So now let me complete. Please let me complete. So
Yes.
already the skit is approved. The skit is been practiced for maybe for 40, 50 years being, and slit is a new phenomenon which has come. And the people, if anybody is using and getting the antigen from the approved agency, that is fine. And if they are using it without getting from the approved agency, that is wrong. That's my statement. I think all of you will agree on that. That's okay. So
Yes,
yeah.
agree.
So now coming to the third topic. So we have the skit and the slit, but there are new modalities of the immunotherapy, and I think Dr. Agrawal will be interested to give his statement on the intralymphatic and epicutaneous route of administration for the immunotherapy. Yeah. Dr. Agrawal.
The important point is that intralymphatic immunotherapy has been the new method supposed to be effective only after giving 3 injections. 3 injections are supposed to give as much relief as the 74 injections given for immunotherapy, subcutaneous immunotherapy in 3 years. So therefore, I have been promoting, I have been requesting the clinical fraternity to undertake research on this aspect, because as far as I understand, giving intralymphatic injections of the antigen is not very difficult. Earlier, we had limited number of papers available. Now, more and more papers have come establishing clearly the therapeutic efficacy of intralymphatic immunotherapy by 3 injections only. So in my opinion, that is a very good, and Dr. A.B. Singh can give his opinion because he's also read about it. What do you say, Dr. A.B. Singh?
Yeah, I agree with you. I agree with you. Some more data and some more clinical trials are required actually to get it approved. That's the stage.
That's what I said, that we should undertake studies, because without doing research on this, we will not be able to put it through a regular practice. So I recommend that our research teams of Dr. Rajkumar and like people can undertake such research.
Yeah, Rajkumar, just one line. Dr. Agrawal, whether FDA has approved it?
I am not aware of that, whether FDA is approved or not, but I have got publications where
not approved so far. Not approved so far.
Only for a clinical research purpose, it has been approved and they have given, and the paper are published. Number two,
these are future directions.
all meta-analysis which
there are more than 6 trials.
There are number of the papers which are coming, the newer form of the immunotherapy, that is the intralymphatic and epicutaneous route of the administration, and people are doing the research. And I agree that for the research purpose, these have been approved and researches can be done on this. Any comment, Dr. Subir, on the intralymphatic and epicutaneous route, only this route? Any comments?
It should be done.
Yes, sir. I had a discussion at international level about intralymphatic. It is administered from inguinal area, but the evidence is still to come. So at this point of time, it's not 100% foolproof. Only 2 doses of intralymphatic immunotherapy has to be given, and that is effective. But still more of the studies has to come, and then only this can be labeled as, yes, this is the authorized route for immunotherapy. And just single sentence, I got a file with me, that is the off-label use of sublingual immunotherapy. And there are around 2.5 pages with me, because whatever I'm doing is authentic, that is not illegal, and how one can use this off-label use of sublingual immunotherapy. 2.5 page literature is with me, how you can dispense, how you can order sublingual immunotherapy. If anybody interested, I can send this paper to him.
I think
Dr. Subir, we don't have to trust.
Only say one thing.
Controller has to be trusted.
At least off label you can do anything, but then you have to inform your patient, this is what I am doing, this is off label usage, and then patient has to be informed very clearly that is the issue.
Always do
we are
everything
unnecessarily diluting it was basically an immunotherapy. So what I'm trying to say, what if somebody is doing it, okay. But whatever you do, you should inform your patient. This is off-label use.
Even the manufacturers.
I agree with you. But
Yes.
one thing what Dr. Rajkumar said very clearly.
Yes.
Sublingual immunotherapy efficacy is not questionable. But
Yes,
when we practice it, we should know whether the particular material used is approved by the government of India. That is number one. And whether the internationally recommended amount of allergen is there in that particular antigen.
And
So I think there is
one more sentence, Dr. Rajkumar. One more sentence.
Yeah.
As somebody said that sublingual is being highly misused. I say even subcutaneous is also being highly misused by many of
there is a
many of
difference
our
between
doctors.
that. Dr. Rajendra Prasad, there is a difference.
So let me complete it.
One sentence, sir. One sentence.
One second. There is one second. There is a use and misuse of both.
Everything.
The roots. So let us not go and know that there is the participants and the panelists should be very clear. There is no question about the efficacy. We can discuss about which is better, but better sublingual or subacute, that's a different thing. The efficacy, there is no problem. Only the problem is how you get it. If you get it correctly from the licensed agents, or it is processed by due permission of the state government or government of India, absolutely no problem. And if whatever you are doing, that should be informed to the patient. That's also. With that,
Yes.
I think the panel discussion is complete. And if the organizers, I know the
Dr. Rajkumar, Dr. Arif Ahmed wants to ask a question. He was saying in between. Can you
so
ask?
I don't know. Let me take the permission of the organizers because we are already 15 minutes late. 15 minutes.
5 minutes.
If the organizer give me time for 5 minutes, I will go for the question answer. Otherwise, we will stop here. Thanking all the panelists. Organizers, please
Sir, we'll
let
stop.
us know what we need to do.
I think with due permission from the next speaker, can we spend 5 minutes from you, Dr. Agarwal?
With due regards, I thank all the panelists. They have been given exact the statement as per the law, as per the today's scenario. And I thank everyone for the participating. Thank you so much. I close this session. Thank you so much.
Thank you.
Thank you, Dr. Rajkumar.
Thank you, Dr. Rajkumar. Thank you, everyone, for a very active participation.
Yeah, Rajkumar, well conducted.
Well conducted.
Thank you so much, sir. That's really a wonderful session. It's really
That was his suggestion only to include this particular session in the 1 hour session in this.
Great, sir. Great. Really
And
great.
he has been a great help to us in finalizing the scientific program.
Fantastic, sir. Fantastic. Yeah. Sir, I think next we'll welcome next session by Dr. M.K. Agarwal, sir, on environmental insects as source of clinically important inhalant allergens. Dr. M.K. Agarwal, sir.
Yes, I will start, please.
What happened? How many were there? Able to. Sir, you can open your PowerPoint on the desktop. Then you can go to the share screen.
Yes, I will be doing that. I will share the screen now.
Yes. Now you go to the projection mode. Yeah, correct. That's right.
Well, I thank the organizers and the scientific committee for giving me this opportunity to present my work on insect allergy. This is a subject which is very close to my heart. And after such an animated panel discussion, I am very happy that this took the way it was. Dr. Rajkumar conducted and regulated this properly. Now I will be talking about environmental and insect as sources of inhalant allergens for patients of allergic respiratory diseases in India. As we have already discussed many times, that allergy research was delayed in our country for almost half century because Western scientists said that the disease was confined only to temperate regions of the world. Dr. Shupuri created a department. That's why he's considered as father of allergy. As I said yesterday, also, I always project his photograph as my homage to him and my respect to the departed soul. He also created, he is the founder of this Indian College of Allergy and Applied Immunology, and this is the 53rd and 54th annual conference of this college in which we are presenting our work. So as we discussed, environment has got infectious agents, they cause disease, and nature has provided us protection by immune response, innate immunity and acquired immunity to protect us from these noxious substances. But whenever this immune system malfunctions, we develop three types of diseases: autoimmune diseases, when the systems, our body starts working against self-proteins, immune response started against self-proteins like rheumatoid arthritis and SLE. Immunodeficiency disorders like AIDS, where the immune response is lesser than what is required. But we are now concerned about the hypersensitivity disease, where the body produces large number of antibodies, more than what is required. And the antibody involved is IgE class of antibody, and the diseases we are talking of are allergic rhinitis and bronchial asthma. So the allergens which cause these particular respiratory allergic disorders are classified into 4 groups. And inhalants are the most important group of allergens which cause respiratory allergies in most of the patients. Allergens vary from place to place, as Dr. E.B. Singh has been referring, and we are always pointing out in every conference that we should have regional calendars worked out so that our patients are tested and treated with allergens to which they are actually exposed. So allergy becomes a local problem. When it comes to allergens, anything and everything on this earth can be a source of allergen substance, be it toothpaste, be it gloves, be it medicines. But we are bothered about the inhalant allergens, pollen of flowers, fungal spores, dust mites, insect particles, etc. When it comes to pollen, Dr. A.B. Singh yesterday discussed, we can identify pollen grains in the air, we can quantify them, how many pollen of a particular type were present in per cubic meter of air, and we can make their seasonal calendars. Similarly, we can do the things for fungal spores. But what about these? This particle or this particle, evidently neither pollen nor fungal spore, they are of some insect origin. So we are surrounded by a large number of insects. It has been reported that there are more than 6,25,000 species of insects around the world. Actually, the latest one paper I was reading where there are more than 15 lakhs species of insects. Actually, it is the largest biomass present on this earth is of insects. Until 1980, we started working on this subject of insect allergy in 1967 or 68. One pool officer, Dr. Pushpalata Bhatnagar, joined our department, who started helping me. She was a zoologist. She started helping us in working on the insects as sources of inhalant allergens. So I remember her today. But the role of insects as sources of inhalant allergens, even though we published our first paper in 1969, it remained a source of controversy, a subject of debate. But during the last 4 decades, we have done intensive work in our Department of Respiratory Allergy. Dr. Rajkumar is the head of the department. Now we have got a national center there. I hope that this particular part of the research, which is still needs lots of work, will be taken care of by Rajkumar and his team. Actually, why I say so, because in my opinion, insects constitute the most important group of inhalant allergens after or side by side with dust mites. How could the insect become sources of inhalant allergens? Number one, during their life cycle, they release scales and other emanations from their body. After their death and decay, their detritus becomes airborne. And when these patients are exposed to these particular emanations, if they are genetically predisposed to become sensitized to those particular proteins, then they develop allergic respiratory diseases to insects. Common insects, which are in our surroundings, it does not need any. Butterfly is such a beautiful creature, but in my experience, it is causing significant allergic reactions in more than 30% patients. Cockroach is worldwide now recognized as one of the most important, and we take pleasure in saying so, that when our first paper was sent to Journal of Allergy for publication, it was rejected by the Journal of Allergy USA. Dr. Charles Reed was the editor at that time. And the reviewer wrote, "We cannot comprehend a cockroach crawling down the airways and causing bronchial asthma." That was the nastiest comment I ever received from a reviewer. And that probably challenged us in proving that they cause allergy. Now I'm glad that we have been able to convince the international fraternity about the role of cockroach and other insects in the respiratory allergic disorders. Housefly, mosquito, moth, these are the common insects, rice weevil, which cause significant allergic reactions in a large percentage of patients. So the first thing we did was identification, procurement of common environmental insects, prepare their allergen extracts, and perform various clinical tests. The first paper was published in 1971 in Annals of Allergy, USA. The tests were performed: intradermal bronchial provocation test, conjunctival test, PK test, which we do not do anymore. All of them had a very good correlation, and we had very significant 38.4% positive intradermal response in patients as against 7.5% in healthy volunteers. But the international community was still not convinced. So when I met Dr. Ross Rocklin in one of the conference, that what will convince you that insect cause allergy? He said, one in vivo test, or rather 2 in vivo tests, 1 in vitro test, and the third thing which he demanded was demonstration of insect-derived allergens in respirable size particles in the air. First two were not difficult. We identified these insects, performed skin prick test and bronchial provocation test, which we have discussed with you. And then we did the skin test on these patients. And you can see that the right column, it is a little noisy slide. You can see on the right side of the corner in red, the bracket in the figures in the parenthesis are the markedly positive reactions with different insects. And you can see 37.3% of these tests were positive. And if you see the percentage to moth, 40%, mosquito, 44%, and like that, we have got a high degree of positivity to these insects. Then the second was in vivo test. In vivo test, we developed RAST, radioallergosorbent test. When we compare the positivity percentage with other group of allergens, pollen, fungi, animal denders, they also show significant markedly positive reactions in our patients. But when we compare it with insects, which is 31.1% in this study, whatever I am presenting in this slide, that shows that the insects constitute the most important group of inhalant allergens in India. We did the analysis of 162 patients to different group of allergens. And out of 162, 100 showed positive reaction to one or the other insects. 59 to one or the other pollen, and fungi were 20 of them. These were the patients who were positive to at least one allergen. So again, you can see that the insects constitute the major allergen group. Then we did the analysis of the patients, how many patients were allergic to which particular group of allergens alone in association with that other. You can see that out of the 100 patients, 40 were allergic only to insects. 17 were positive to insect and pollen, and 4 were to insect and fungi. In any case, it clearly shows that insects are producing or are causing sensitization in large percentage of our respiratory allergy patients. Then we did the RAS test on our patient with the insect allergens. And you can see that in negative cases, we had 3.2% positive cases. 1 plus was 24.2, 2 plus was 69.2% correlation, and 3 plus and 4 plus was 100% correlation. So average markedly positive reactions produced sera from patients showing markedly positive reactions. 78.4% were showing specific Ig levels to insects. So the second part also is demonstrated, the requirement of the international community. Please bear with me. I have to, my charge is going. I have put it on charge. Just 1 minute, please. So this clearly shows that there were high degree of correlation with the RAS results. Then we started doing quantification of airborne allergens. We developed an immunochemical technique by which we were able to collect the particles using an air sentinel on a polytetrafluoroethylene membrane. And the particles were collected, eluted, and were used in RAS inhibition assays to quantify the airborne allergens. So air samples were eluted, aliquots of 50 microliter each were used as inhibitors, and you can see this is the inhibition. The seasonal variation in Culex allergen was demonstrable. To check the specificity, we used pooled air samples and developed a dose response curve with the homologous allergen extract and airborne samples, which were parallel, that clearly showed that what we were quantifying was specific. We did the same study of immunochemical quantification of some other insect allergens, cockroach, housefly, moth, butterfly. They all showed seasonal variations, and there also dose response curve with these extracts were also parallel to the samples collected from the air. We did SDS page, immunoblot to identify the allergenic proteins in different insects. And then we also performed immunoblot with a large number of patients of a given insect. In this case, it is cockroach male. You can see there is a very gross heterogeneity of clinical sensitivity proteins on the end, but there are some which are common. So we have worked on this, and we will be working on the major allergens. Now we will see if we can do that. Immunotherapy with single insect extract, mosquito. Immunotherapy with multiple insect extracts conducted by Dr. S.N. God. 2, 3 papers, 4 papers he has published in international journals, and we have got excellent, he has got excellent therapeutic response to insect allergens. If I say so, if you take the total number of clinics, allergy clinics working in our country, or if you take large 100, 200, 500 prescriptions coming from the private practitioners or the practitioners from Patel Chest or from Metro Hospital or so on. Large percentage of our patients' prescription contain insect allergens, and we get very good results with them. So in conclusion, results of skin prick test, ELISA and RAST, immunoblots, immunotherapy with insect allergens conclusively established, as well as the demonstration of insect allergen particles having allergens in the air, clearly establish the role of insects as sources of inhalant allergens. Using a new immunochemical technique, presence of insects-derived allergens was demonstrated in respirable sized particles in the air, and of the various allergens studied, insect constitute the most important group of the antigens. Still, people are not using insects, and I will not say so. They are using insect extracts now for the diagnosis and immunotherapy of the patient, but more research is required on their quality control, on their identification of major and minor allergens, so that the subject is taken care of in the interest of patients. Thank you. I think I have finished quite early now. Dr. Rajan Prasad is relaxing. Dr. A.B. Singh is there. Organizer का कोई नहीं पता है. So now Dr. A.B. Singh, you take over. आप अनम्यूट करिए डॉक्टर साहब.
Sir, I am here only.
Dr. A.B. Singh, unmute करिए.
Okay.
Sir, I am Dr.
Dr. Surennath also says.
Surennath
is there.
Okay.
I was in the paper presentation, so paper.
All right. So I think the last paper of today's is there. That is management of anaphylaxis. That will be by Dr. Sonam from Vallabhbhai Patel Chest Institute. Dr. Sonam, are you ready?
Yes, sir.
Can you show your first slide?
Yes, sir. Is it okay, sir?
Yeah.
The
Sonam
slide
is
is.
assistant professor at the Department of Pulmonary Medicine at Vallabhbhai Patel Chest Institute. And he is also actively working for the last couple of years in the field of allergy and immunology. Rather, he is managing the OPD of the Vallabhbhai Patel Chest Institute. Dr. Sonam.
Thank you very much, sir, for a nice introduction. First of all, I am thankful for the organizer to give me an opportunity to speak on this platform. Today, my topic for the discussion is management of anaphylaxis. We all know anaphylaxis itself is an allergy, and it can also happen with the skin prick test or during with the treatment, that is allergen immunotherapy. So the objective of anaphylaxis in education is who is at the risk, when it can happen, how do we know it is an anaphylaxis, where it can happen, what should we do, and why is follow-up is needed. So it is easy for me that most of the person has already discussed in the panel discussion. So I am starting with the definition of anaphylaxis. Anaphylaxis is an acute allergic systemic reaction during which all or the sum of the following are present. This is urticaria, angioedema, upper airway obstruction, bronchospasm, hypotension. In some cases, this manifestation may be accompanied by cardiovascular or gastrointestinal disturbances. Anaphylaxis can be fatal without evidence of cutaneous involvement. The clinical criteria for diagnosing anaphylaxis is it should be an acute onset of illness that is within a minute or hours with the involvement of skin, mucosal tissue or both, in at least one of the following, that is respiratory compromise, for example, dyspnea, wheezing, or bronchospasm, or reduced blood pressure associated with symptoms of end organ dysfunction, or more than two of the following that occur repeatedly after exposure to the allergen, that is again within minutes to hours, that the two of these four, that is involvement of the skin tissue, mucosal tissue, for example, generalized hives, itchy flush, swollen lips, tongue, and uvula, respiratory compromise, reduced blood pressure or associated symptoms, or persistent gastrointestinal symptoms like cramping, abdominal pain, and vomiting. Or it is in reduced blood pressure after exposure to the non-allergen. That is, the reduce in blood pressure for infant and children should be the low systolic blood pressure for the age-specific definition, or it should be more than 30% the baseline. For adult, it is less than 90 millimeter of mercury or more than 30% decrease from that person baseline blood pressure. So something about the incidences of anaphylaxis. The anaphylaxis incidence is continually increasing year by year. This slide shows this bar diagram show the overall anaphylaxis from 1995 to 1999. In even specific anaphylaxis for food, medication, serum, all are increasing year by year. And what are the overall anaphylactic triggers? That's what are the trigger agent for this anaphylaxis? The most common is food in nearly 35% of cases. Subsequently, drugs, insect sting, and the idiopathic accounts for nearly 20%. And less frequently, exercise and allergen vaccine are also responsible for 3 to 5% of these triggers. So food-induced we already see is the most common. The prevalence and incidence is 35 to 55 of anaphylactic reaction are caused by food allergy. That is, accidental food exposure are common and they are unpredictable for this. Prevalence of food hypersensitivity is greatest in the first few years of life. That is 6% of children less than 3 years of the age affected. And it is decreased over the first decade. The incidence is increasing. The prevalence of peanut allergy is double in children less than 5 years than in the last 5 years. The common triggers for food allergen are peanut, tree nut, shellfish, fish, and the other additional which are common in children are milk, egg, soya, and wheat. These 8 allergens account for almost 90% of all allergic reactions due to food allergens. Then the second is medication. The medication induced one. It is estimated that 550,000 serious reactions to drugs per year in USA, and the reaction to penicillin is the highest number of documented death from anaphylaxis each year. The common triggers of this medication are antibiotics, especially beta-lactamase, then aspirin and other non-steroid anti-inflammatory agents. They are equal to the most trigger. Reaction more severe when medication are given injectable form than those given orally administration. Then idiopathic. There are numbers of anaphylaxis we can not find what are the triggers. So in a study, it is found that 50% of anaphylactic reaction was idiopathic. However, in another study, it is found that more than 70% are found to be an idiopathic. The trigger is unknown in spite of skin testing, extensive dietary history, assessment of all possible causes such as mastocytosis. So they concluded that many of the cases of anaphylaxis are unknown origin, making the prevention of this anaphylaxis is very difficult. So if the anaphylaxis is happen, or if there is anaphylaxis, then what are their signs and symptoms? The most common symptoms are cutaneous, and the urticaria and angioedema are seen in nearly 85 to 90%, flushing in nearly 50%, followed by pruritus without rash in nearly 2 to 5%. The second most common symptom is the respiratory, We have dyspnea and wheezing upon in nearly again 50%, upper respiratory angioedema in 50 to 60, and rhinitis in nearly 15 to 20%. The cardiovascular symptoms are hypotension, giddiness, syncope, diaphoresis, again seen in 30 to 35%. Then the abdominal in form of nausea, vomiting, diarrhea, and abdominal pain seen in 25 to 30%. Then least, that is miscellaneous other symptoms are seen in such as headache in 5 to 8%, substernal pain in nearly 5%, and seizure in 1 to 2% cases. So the fatal event can rapidly progress. So the anaphylaxis can rapidly progress. The time to the respiratory and cardiac arrest were 5 minutes for the etogenic reaction, 15 minutes for the venom, and 30 minutes for the food. So before labeling as anaphylaxis, we should rule out all the other differential diagnosis. We already discussed in the panel discussion, we should rule out the vasovagal or the other differential diagnosis before label this is an anaphylactic reaction. So the common differential diagnosis for anaphylaxis are vasovagal reaction, myocardial infarction, insulin reaction, hysterical reaction, laryngospasm, medical toxicity, carcinoid syndrome, hereditary angioedema, systemic mastocytosis. However, here we are discussing the allergen immunotherapy and skin prick test. Here the most common differential diagnosis is the vasovagal reaction. We already discussed it. So if there is happen, although all the faculty says that it is very rare, rarest to rarest that anaphylaxis can occur with the skin prick test or with an allergen immunotherapy. In the last 4 years, I didn't see any this anaphylaxis with this skin prick test or with the during the allergen immunotherapy. But we should be ready, as we already see show in our demonstration in the workshop, that we should be ready with each for any if happen for a rarest. Sometimes it happen. We should ready with all the equipments for treatment. So we should prepare our skin prick test center or the allergen immunotherapy center with all the requirement for treatment of anaphylaxis, that is including pre-filled syringe of epinephrine and antihistaminics, oxygen, bed. We should be prepared for if there is happen, although it is considered as a very rarely it's happening with these allergic respiratory diseases. So there are 3 R's of the anaphylaxis emergency action plan. The first R is recognize the symptoms early. If anybody is complaining the symptom, we should recognize as early as possible. It may be an anaphylaxis. If the symptom we recognize, the second R is the response quickly, to treat quickly for this anaphylaxis. And then third R is the review, what cause the reaction. So these 3 are the action plan for the anaphylaxis emergency, that is recognize early, response quickly, and review for the reaction. So if the patient general anaphylaxis, if the anaphylaxis happen anywhere, if the pre-hospital, then the management of acute event is place the patient in the recommended position with the feet elevated, check the airway, and if required, secure it necessary, administer epinephrine. This is the drugs which save the life. The treatment of choice is the epinephrine, and followed by the initiation of oxygen therapy. So we remove all the allergen. If still the allergen is there, then call for assistant. The patient should be left on the flat. Do not allow him to stand or walk. Then give the intramuscular injection of adrenaline or epinephrine or the mid-thigh lateral aspect, and then call for oxygen and the other ambulance and other treatment. So anaphylaxis emergency should be included what the symptoms we look for, what medication to be used, what are the dose of medication, where the medication should keep, what the order should we do, anaphylaxis emergency practical drill. So the drugs, I already sent you the drugs, the the drug of choice for the treatment is the epinephrine, and it should be given in a dose of 0.3 to 0.5 ml in a concentration of 1:1000 intramuscularly. This is important intramuscularly. Drug dosage is important. Then in child, it is 0.5 ml per 10 kg. And then the second drug is the antihistaminic, the diphenhydramine in a dose of 25 to 50 milligram. It can be given intramuscular or intravenous. Then the other what we is corticosteroids and H2 antagonist. Many people think that corticosteroid is the first line of treatment during anaphylaxis. However, epinephrine is the drug which should be given first. So this is the dose chart for the age as well as the weight. If the weight age from 1 to 12 and weight from 5 kg to 50 kg, what is the dose of adrenaline? So administration immediately. Failure to administer epinephrine promotely is the most important factor contributing to the patient to the death. And the vasoresponsive effect of epinephrine with the effect preventing and relieving laryngospasm and bronchoconstriction be the life-saving for the patient. So this is the pharmacokinetics, how it works, the epinephrine. All the three parameters, that is systolic pressure, diastolic blood pressure, and heart rate. All these three are maximum pharmacokinetics are effect within 10 minutes of the injection within epinephrine. So give it easy as early as possible. Then the histamine, why not first histamine? Its antagonist is histamine only have much lower onset of action than the epinephrine. And the guidelines state that antihistaminic are supportive therapy, do not replace epinephrine. It should never be used alone in a treatment of anaphylaxis. After epinephrine may be useful for control of the other cutaneous and cardiovascular manifestation. So first we should give the epinephrine, then we think for the other drugs like antihistaminics. So the ancillary treatment, second line to epinephrine, already discussed. Antihistaminic ranitidine in 50 milligram kg in an adult and 12.5 to 50 milligrams in a children. That is total dose should be given injectable of 5 minutes. Then again cimetidine IV 4 milligram per kg. Then we are, if the patient is asthmatic, we can give nebulized albuterol or the salbutamol, and then methylprednisolone 1 to 2 milligram per kg. For refractory hypotension, if the patient dependent hypotension, we can use dopamine for 400 milligrams in 500 ml of normal saline, IV to 2 to 20 microgram per kg per minute. Then glucagon 1 to 5 milligrams IV of 5 minutes, followed by infusion in 5 to 15 milligram per kg per minute. Then is the one dose of epinephrine is okay, or we should repeat the dose of epinephrine? So this slide shows that sometimes the anaphylaxis can require more than 1 doses of epinephrine. So these are the various studies showing that requiring number two doses of epinephrine. This shows that these studies in 99 shows that it is 36% of the anaphylactic reaction require 2 doses. Again in 2006, 33, and in another by Hammond et al. Says that 25% are requiring, and then this study shows that 18. So overall, the anaphylactic reaction shows that 15 to 35% of patients requiring second dose of epinephrine. So the second dose of epinephrine may require 2 doses if the severity or the biphasic reaction. The need of second dose is seen. I already shown you in the last slide. That 15 to 35% are requiring. Second dose, when should they administer? The second dose should be administered within the 5 minutes of the previous dose. There is no way to predict when to require that. It is depend upon the severity and our clinical judgment when to require this second dose of epinephrine. Then the therapy is other than epinephrine in the retrospective given in the emergency. So this is a retrospective study. What are the other drugs given to the anaphylactic reaction in a center published in 2010? That this is, although it is a retrospective study, that shows that only 20% of the pediatric patient with food-related anaphylaxis are receiving only the epinephrine is receiving in only 20%. So we should know the first treatment of choice is the epinephrine. And the other medication, what they're receiving is antihistaminics in nearly 60%, corticosteroid in again 50 to 60%, IV fluid in nearly 25%, and beta-2 agonist in 13%. So this is a retrospective study shows that only 20% are receiving the epinephrine. In those who are receiving this 20%, this epinephrine, what is their route of giving this epinephrine? That 75%, nearly 75% are receiving subcutaneously. So we should know if the first choice of drug is epinephrine, and the treatment should be given intramuscularly. So what the anaphylaxis killer energy? Who is at that is? Anyone can happen this anaphylaxis, especially those with food such as peanut, tree nut, seafood, shell food, egg, insect sting, bite, rubber latex, or a medication. When it can happen, it is usually happen within the minutes or any time the allergen person comes in contact with his or her triggers. How we know? Several symptoms occurring at the same time, such as itching, hips, flashing, difficulty in breathing, vomiting, diarrhea, giddiness, confusion, or shock. And where it's happened, it is for a general anaphylaxis. Although we are discussing the allergen immunotherapy and skin prick test, that is in our practice. However, it can happen anywhere in the emergency room, ward, home, restaurant, school, children care, sports facility, bus, car, aeroplane. And even in our cases, skin prick test room and the allergen immunotherapy center. Then what we should do, inject the epinephrine, local emergency medical services, notify the family quickly, and anaphylaxis should be mild or it can be fatal. Why is follow-up needed? Anaphylaxis can occur repeatedly, trigger need to be confirmed, long-term prevention strategy to be implemented. So finally, I summarize as the causes of anaphylaxis are food, venom, latex, drug, exercise, and idiopathic. Although it's rarely can occur with the allergen immunotherapy and skin prick test, the prevalence is underestimated. Up to 12 million person are at risk, and the several symptoms occur at the same time within a minute of the trigger contract is how to diagnose, and the treatment of choice is the epinephrine, that is intramuscular for the anaphylaxis. Thank you very much, sir.
AB Singh, sir.
Nicely presented. Dr. Sonam, nicely presented.
Thank you very much, sir.
It is very important.
Thank you, Dr. Sonam. But you have already got compliments from Dr. Agarwal. That's more than enough on behalf of our entire college.
Yes, well done, Sonam. I must also say, well done.
Thank you very much, sir. Thank you.
Very important topic.
Yes, we should. Everybody should know the treatment.
Actually,
sir, many even our physician thinks that this corticosteroid is the drug of choice, and many are even prescribing these drugs, sir.
Dr. A.B. Singh, I always recommend that in our workshops, one lecture of anaphylaxis should always be there.
Sure.
Because this is very
yes, sir. From last time we also keep, and last time I also take, sir. So in future we also continue to keep this talk in the workshop also, sir.
That's very nice. Thank you.
Thank you.
Sonam is our upcoming hero.
Thank you, sir. Thank you very much, sir. With your blessing, sir.
No. Definitely.
Thank you, Dr. Rajendra Prasad, Dr. Agarwal, whom I can see here, Sonam. Is Dr. Surendranath still on the line?
Yes, sir.
Yes, sir. Yes, sir. Sir has joined.
Dr. Surendranath, hand over to you. Thank you very much for the entire day sessions, and maybe we will have a good sleep today.
I'm at Calcutta.
Well done.
Thank you.
Sir is in Calcutta, sir. Actually, he went for a conference there. He's handling from there now.
So he has joined from there.
Yes, sir. Yeah.
Okay,
Scientific
sir, thank you so much.
Managed very well. And tomorrow, I don't think he will be able to join. So tomorrow again, you
that is Dr. A.B. Singh. That is the big advantage what COVID has taught us. That is a virtual platform.
And
I
this is
always say
very,
that
very
you can.
economical also.
Then if you have 3 laptops, today I have attended 2 meetings. One is yours, and one is another meeting of some on the vitamin C. So I mean, this is the great advantage.
That's
And
of course frequent interaction and
yes, without much of the expenditure also, not too much of expenditure.
Katuria,
please
you also
stop
presented very
share.
well.
Thank you. I am unable to see. Sonam, please.
Thank you, sir. Katuria, you did well. Congratulations.
As usual.
Thanks.
Thank you, Dr. Surendranath. Enjoy the Calcutta weather.
Regarding the scientific paper, sir, I was there for the entire session.
Okay.
Your very good discussion was there. Dr. Sandeep has analyzed and discussed very well. Almost it took 2.5 hours for 7 papers.
Very
so it
nice.
was very good discussion.
How many papers were there?
7 papers, sir.
Anyway, that's good. Actually, next time we'll try to have more. Actually,
This time there was no Raju Award.
No, this year no.
This year no.
So it was well organized, sir. Scientific paper.
Okay. Thank you.
Thanks.
There is no advantage.
So we meet tomorrow.
Tomorrow 9:30.
Thank you, sir. Thank you so much.
We will be there, sir, as per your instruction.
Yes, sir. On behalf of Pediatric Academy of Telangana State, I really thank Dr. Sonam, sir, for that last lecture, but a wonderful lecture. And Dr. Professor Rajendra Prasad, sir, and Dr. P.C. Katuria, sir, and Dr. M.K. Agarwal, sir, the Bhishma Pitamaha of Allergy, and Dr. Anand B. Singh, sir, Dr. Vikram Jain, sir, Dr. Arif Ahmed, sir. Thank you so much for staying till the end, and thank you for making these sessions wonderful, and also by your presence and making it a grand success. Thank you so much, sir. We'll conclude for today. And we will.
Thank you, Dr. Pavan Kumar.
Thank you, Pavan.
Thank you.
Thank you.
Dr. Pavan, whatever
Surendra,
leads
sir.
you have taken, they are the foundation of this college.
Pardon, sir?
They are the founders of this college. Foundation.
Yes, sir. Yes, sir. Yes, sir. You're all founders. You are all founders, sir. Very happy. You are all like a pillars for that college. Yes, sir.
Maybe we'll continue
No,
our collaboration
actually,
with your
Dr. Pavan,
pediatric society also.
Dr. A.B. Singh
Very true.
has been the secretary of the college for more than 20 years. And I will be openly saying that the college activities are going on smoothly, uninterrupted because of his tireless efforts. He does something or sometimes it's very difficult, he will be able to manage things. And therefore, my compliments to him. And I wish him a very long association life so that our college goes on working like that.
Great, sir.
For
Thank
your
you so
nice
much,
words.
sir.
No. Dr. A.B. Singh did well. Another name I always say A.B. Singh is aerobiology.
Aerobiology Singh.
Thank you.
In this conference, I have not uttered this word, but at the end,
Okay.
on the penultimate day, I said he is aerobiology Singh.
Okay, Pavan and Dr. Surendranath,
Thank you,
we
sir.
will meet tomorrow.
Thank you. Thank
Dr.
you.
Pavan and
Thanks
Dr.
a lot, sir.
Surendranath needs to be
Okay, sir.
completed.
See you all
Okay.
tomorrow. Yeah.
And thank you very much.
आज एमके अग्रवाल
sir.
साहब
Thanks
आज
a
से
lot.
हम रात को 8 बजे आपसे बात करेंगे.
रात को 8 बजे चलिए सर, आपका इंतजार करेंगे.
हाँ.
ओके सर.
Bye bye, sir. Good night.
नमस्कार.
Good evening.